Hello guys, can you see me? Hello. Hello everyone. Can you see me? And so voice is audible? Everything clear, right? Okay. Good morning everyone. Good morning. Okay. So for the next 4 days, okay, for the next 4 days, what we are going to do, we are going to do the physiology. And how we are going to do the physiology, we are going to do the physiology in such a way that we are going to integrate a lot of things. Okay, we are going to integrate a lot of things so that you will be getting a better scores. Okay. Let me tell you one thing. First itself. See, in the last exam, in the last FMG exam, how many questions came from physiology? Okay. See, direct questions from the physiology are 8. That's it. The direct questions which came from physiology are 8. Okay. And how many questions are you going to get from that book which you got already? Okay, in your mails or in your WhatsApp, that book, whatever you are having, it will at least, it will give you 15 to 20 marks indirectly, because there are a lot of integrated topics. Okay. So if you go through that book which I gave, it's going to give you almost around 15 to 20 marks. And how many questions will be coming from physiology? All the questions are going to come from the physiology. From that book, all questions, direct physiology questions and indirect pathology and medicine related questions are going to come from that book. Okay. So the first thing, stick with that book. Stick with that book. All questions are going to come from that book. All direct questions, and indirectly also you'll be getting benefited from that one single book. And what you need to do, so for the next 4 days, you need to watch the video or watch this lecture from starting to end. Okay, don't think that okay, I'm having the leisure time, I will be listening to it after some time. No, it's not going to work like that. The leisure time should be used for revision. You need to learn here itself, in this class itself. Okay, in this class itself, you need to understand, at least you need to understand all the concepts and learn as much as possible, and the remaining time you should be using it for revision. Okay. And physiology, what kind of subject is physiology, sir? I'm telling you, physiology is a damn easy subject. Okay, it's a very easy subject, and no doubt you are going to answer all the questions, no doubt. Physiology is an easy subject. Okay. And one more thing, whatever I'm going to write, okay, whatever I'm going to write, that PDF will be, that annotated PDF will be shared with you at the end of the class. The annotated PDF, you are going to get that. There is no doubt about it. Second thing, if there is any power cut, okay, if there is any electricity issue, don't go anywhere. I will be again joining. Okay, I will we will give you the information that what happened and in how much time I'm going to join. Like, I have to take some other source, right, for Wi-Fi. I will join. Just wait. Okay. So without any further late, shall we start? Without any further late, shall we start? Okay. Yes. Chalo. Now in this today's class, okay, I'm going to start with the endocrine. Okay, endocrine, I'm going to directly start with the endocrine, because before exam and last exam also, endocrine, how many questions came? 3 questions are coming from the endocrine. 3 questions are going to come from the endocrine. I will show you what are those 3 questions also. Okay, so 3 questions are going to come from the endocrine. So let me begin with the endocrine. Let me share my screen. Okay. See, as I'm doing it from iPad, okay, whatever I'm going to write, you can see that. And in the middle, I will be showing my face. Okay, in the middle, I will be showing my face wherever it is required. Okay, wherever it is required, I'm going to come back. I will be explaining you. Okay, but for most of the time, whatever I'm going to write and whatever I'm going to talk, you can only hear that. Okay, you can only hear that. Have lots and lots of water in between the class. Physiology, the basic subject, right? For most of the students, it's a nightmare. Physiology is a nightmare. Yes, of course, medicine is a hard thing, but for most of the students, even physiology is little difficult. Okay, I will make it as easy as possible. Just trust me. Okay, you be attentive. Have cups of water or cups of coffee or tea. Be attentive. That's it. Next, see, this is my number. If you have any doubts, you can contact me on my number 77807 82243. This is my WhatsApp number. Okay, if there is any trouble during the class, you can also call me directly, or you can just keep a WhatsApp message. Okay, chalo. So endocrine physiology, sir. Now in the endocrine, what are the important topics that you need to know for your exam? Okay, important topics that you need to know for your exam. The number one important topic is insulin. Second one, secondary messengers. Okay, so secondary messengers like CAMP, CGMP, IP3. Okay, inositol triphosphate. So insulin, regarding insulin, a lot of questions are going to show up in your exam. Direct questions will come. Insulin, secondary messengers. Regarding hormones like growth hormone, thyroid hormone, like for other hormones like epinephrine, norepinephrine, cortisol, all other questions are going to be indirectly asked. Okay. Having said that, so what is this? Whatever you're seeing here, this is the hypothalamus. Okay. Here, this is the hypothalamus. So to the hypothalamus, what is attached? See, this is anterior pituitary, posterior pituitary. Okay, anterior pituitary and posterior pituitary. So question from anatomy. Okay, question from anatomy. A anterior pituitary, hai na? This is the anterior pituitary. It is developed from where? Anterior pituitary is developed from Rathke's pouch, right? Anterior pituitary, from where it is developed? It is developed from Rathke's pouch. Okay, like embryonically, like it is developed from the structure called as Rathke's pouch. At posterior pituitary, this area. Okay, this posterior pituitary. From where it is developed? So posterior pituitary, it is developed from new rectoderm. Okay, new rectodermal layer. From new rectoderm, this posterior pituitary, it is developed. Anterior pituitary is also called as adenohypophysis. Posterior pituitary is also called as a neurohypophysis. Okay, anterior pituitary, adenohypophysis. Posterior pituitary is also called as a neurohypophysis. See, now itself I am telling you, the last FMG exam, the recent FMG exam, a question was asked in the hypothalamus. What is that question? Hypothalamus is thermoregulatory center. Thermoregulatory center. Okay, sir, आपका hypothalamus है, whatever is there, it regulates your body temperature. Regulates body temperature. That's the FMG question which was asked. Okay, just I'm telling you here itself. Hypothalamus, it's a thermoregulatory center. Okay, now from the pathology integration. See, in some individuals may these Rathke's pouch cells, okay, the Rathke's pouch cells, okay, they can transform into tumors. Okay, so Rathke's pouch, whatever the remaining cells, leftover cells, the remnants of the Rathke's pouch, they will become tumor. So that tumor is nothing but craniopharyngioma. So craniopharyngiomas, they are remnants. Okay, they are the tumors occurring from the remnants of the Rathke's pouch. So done. So this slide is completed. Okay, so what you have learned from this slide? Come on, recap, sir. What we have learned from this slide? Arey, hypothalamus hai, ye upar hai. It's on the top. Hypothalamus is on the top. So hypothalamus is connected with what? Anterior pituitary and posterior pituitary. Anterior pituitary is also called as, come on, anterior A for A. Anterior pituitary is also called as adenohypophysis. Posterior pituitary is also called as a neurohypophysis. Adenohypophysis develops from Rathke's pouch. Posterior pituitary is developed from new rectoderm. Okay, remnants of Rathke's pouch, which is forming a tumor. The tumor is called as craniopharyngioma. That's a pathology integrated thing. Okay, and that's one of the most common tumors in the children, craniopharyngiomas. Right? Chalo. Guys, here itself, I just want to confirm, is everything okay? My voice, like everything is clear? The speed in which I am going, is everything clear? If you have any issue, you can always message me in the chat box or personally in the WhatsApp. I will change myself. I will change according to you. At the end of the day, you should be benefited. Okay? Chalo. Next, draw this diagram, sir. Wherever possible, try to have this diagram. So make it little big only. A lot of things are going to come. Make it little big. So what is here on the top? This is the hypothalamus. Hypothalamus. This box, whatever I have drawn here, this is the hypothalamus. Imagine it's the hypothalamus. Now down to it, I'm showing only here anterior pituitary. Okay, here what I'm showing only the anterior pituitary. I'm not talking about posterior pituitary. Later I will talk about the posterior pituitary. For right now, I'm talking about anterior pituitary. This is what? Anterior pituitary. Okay, the topic is anterior pituitary. Now, if you have colors, different colors, try to draw 5 different colors here. One red color, nucleus. Okay, one blue color, one green, one black. Well, let me take some other color. Pink and black. Okay, so hypothalamus mein there are different types of cells. Okay, there are red color cells. Okay, these cells are nothing but the cell bodies. Okay, a red color neurons are there. This blue color neurons which are forming a nucleus. This green color neurons which are forming a nucleus, and this pink color nucleus, and this black color nucleus. Okay, these are the different types of nuclei which are present in the hypothalamus. Okay, hypothalamus may different types of nucleus here. This red color nucleus, this blue color. These colors are for understanding purpose only. Okay, now try to draw the same colors here in the anterior pituitary. Red, followed by blue, followed by green, pink, and black. Okay, now see, hypothalamus. Always you have to start from the hypothalamus because hypothalamus is the master. It's a master of what? It's a master regulator of endocrine activity or endocrine system. So this hypothalamus, whatever is there, it's the master regulator. It's a master for everything. He is the highest control. He is the master regulator of endocrine system. Is who? Hypothalamus. Yes, of course, hypothalamus controls your body temperature. True. But your hypothalamus also controls all the endocrine hormones. Okay, your endocrine hormones are controlled by whom? It's not the anterior pituitary, it's the hypothalamus. For example, look. So, this red color nucleus, it is producing a hormone called as GnRH. क्या है? GnRH. The GnRH का full form क्या है? What is the full form of the GnRH? So GnRH full form is gonadotropin. Okay, gonadotropin releasing hormone. Okay, gonadotropin releasing hormone. Full form. GnRH, gonadotropin releasing hormone. See, this gonadotropin releasing hormone through the blood. Okay, from the hypothalamus through the blood, where it will come? It will come and act on the same red color cell. Okay, same red color cell. Okay, this cell is called as what? This cell is called as gonadotrope. Okay, this red color cell. Okay, let me write here itself. Gonadotrope hai. The cell is called as a gonadotrope. Aha, okay. So GnRH from where it is coming? GnRH is coming from the hypothalamus. So this GnRH is going to come and act on gonadotropes. Okay. This blue color nucleus, what it is producing? This blue color nucleus, it is producing something called as CRH. Okay, CRH. What is CRH full form? Corticotropin releasing hormone. So all releasing hormones important. All releasing hormones. See, here also releasing. Here also releasing. Okay, blue color full form. Let me write here. Corticotropin releasing hormone. Corticotropin releasing hormone. Okay, corticotropin releasing hormone. Now this corticotropin releasing hormone, now where it will come and act? It will come and act on this blue color cell. What is the name of this blue color cell? It's called as a corticotrope. Okay, it's called as a corticotrope. Next, the green color nucleus in the hypothalamus is going to release TRH. TRH का full form क्या है? Sir, TRH का full form thyrotropin releasing hormone. Thyrotropin releasing hormone. Thyrotropin releasing hormone. This thyrotropin releasing hormone is going to come and act on which cells? Thyrotropes. Okay, thyrotropes. Okay, done. Next one is the pink color cell. So the pink color cell, this pink color cell, what it is going to release? This pink color cell is going to release, look, let me write here, the pink color cell is going to release growth hormone releasing hormone. Okay, so growth hormone releasing hormone, GHRH. Growth hormone releasing hormone, not GnRH, it is GH. Okay, GHRH, growth hormone releasing hormone. Now this growth hormone releasing hormone is going to come and act on which cells? Which cells? Growth tropes. No, it is somatotropes. These somatotropes. Okay, done, sir. And what is left over? The black color nucleus. This black color nucleus, it is going to release something called as dopamine. The black color nucleus is releasing dopamine. Now this dopamine is coming through the blood. It is going to come and act on this last cell, the black color cell. Do you know what is that black color cell? Anyone? Okay, let me give you the chance. So anyone can say what is that black color cell? Last cell in the anterior pituitary. Last cell in the anterior pituitary. Can anyone? Exactly, Alicia Sheikh, exactly. Okay, it's a lactotrope. The last color cell, this one is lactotrope. That's it. So first we have completed the ABCD. Okay, we have done with the ABCD, sir. So there is something called as a hypothalamus and there is anterior pituitary. Okay, hypothalamus, anterior pituitary. Hypothalamus releases which hormones? Look again. Hypothalamus releases C, gonadotropin releasing hormone, corticotropin releasing hormone, thyrotropin releasing hormone. Okay, growth hormone releasing hormone. So the question which you are going to ask in your FMG exam, right? Releasing hormones are produced by. Releasing hormones are produced by. What's the answer? Hypothalamus. Okay, that's the answer. All the releasing hormones are going to be produced by hypothalamus. Done. Chalo, next, let's extend the topic. Say again. Let's go one by one hormone. This is your hypothalamus. Here is the anterior pituitary. Okay, this is the anterior pituitary. Now, what is the first color cell that I have drawn? We have drawn the red color cell. FMG question came from this area this time. Not this time, before time. Bacho, please tell me. So what is this red color nucleus producing? Red color hypothalamic nucleus. This red color hypothalamic nucleus, what it is producing, sir? GnRH, gonadotropin releasing hormone. The gonadotropin releasing hormones are going to act on which cells? Sir, gonadotropes. Now these gonadotropes are going to release what? Okay, gonadotropes. Hey, what they are going to release? These gonadotropes are going to release gonadotropins. Okay, gonadotropins. What are the examples of gonadotropins? FSH and LH. Done. The gonadotropes are going to release FSH and LH. Let me write here. FSH, LH, they are gonadotropins. Done. Now, first FSH का काम क्या है? What is this FSH? Follicle stimulating hormone. Okay, follicle stimulating hormone. So, follicle stimulating hormone, इसका काम क्या है? What is its work? Okay. So in the name itself, it's there. Bacho, please listen. In the name maybe it's there. Follicle stimulating hormone means it's going to act on the follicles. It stimulates the follicles. It goes and acts on the follicles, stimulates the follicles. Okay. So let me write here. Sir, this FSH है ना, it will go to the ovary. See, female में ovaries है. Ovaries में क्या है? Ovaries में eggs है, follicles है. Okay, these are the follicles. Now this follicle stimulating hormone, it will go to these follicles and makes these follicles to grow. Okay. Now these follicles, now these growing follicles, what they will release? Now these growing follicles, they will release when they are active. See, when the FSH is acting on these follicles, what they will release? they will release, okay, these follicles, for example, okay, these follicles, what they will release? They will release estrogen. Okay, done. So FSH, it goes to the ovarian follicles. It goes to the ovarian follicles. This is ovary, sir. It goes to the ovarian follicles and stimulates the follicles to grow every month. Female may ovaries may follicles will be developing. Okay, so the follicles, they will develop and they will wait for the sperm. Okay, so these growing follicles, they will produce estrogen. Now, FMG may, they can ask you also this. Sir, which cells of the follicles produce this estrogen? Here I am showing you the follicle. See, a follicle here. Okay, let me show you in the next slide. Imagine a follicle cell. Sorry. So this is the follicle. So these follicles are surrounded by some cells. Okay. See, this total thing is called as a follicle, ovarian follicle. Pura ka pura kya hai? A total thing is the ovarian follicle. Okay, what is the central thing? The central black color thing is called as the oocyte. Okay, the central thing is the oocyte. And what are these cells? These red color cells, these cells are the granulosa cells. Okay, granulosa cells. This is the question which was asked in the FMG exam. Granulosa cells, it's the granulosa cells which produce estrogen. Okay, so females, all the females who are listening to this class, thank your granulosa cells. Okay, the estrogen which is there in your body, from where it is coming, sir? The estrogen is produced by these granulosa cells. So granulosa cells are the ones which produces the estrogen, right? And what about these green color cells? These green color cells are called as the theca cells. Theca cells. Okay, so these theca cells are the ones which produce androgens, or you can say testosterone. Okay, so theca cells in females, yes, true. Even in females, the ovaries produce the testosterone. No doubt in that. Okay, you will learn more in gynecology also. So it's the theca. If you want to know in specific, it's the theca interna cells. It's the theca interna cells which produces the testosterone. Later, this testosterone will be converted into estrogens. Later, the testosterone will be converted into estrogens. Okay. So what I have taught you so far. Okay, draw. If you haven't drawn it, please draw it. This is little important. They will ask you. Female में granulosa cells है. Granulosa cells produces estrogen. Okay, estrogen. And theca interna cells produce testosterone. In females also. Okay. Okay, done. Let's come back to our topic. Sir, FSH, follicle stimulating hormone. Where it is acting? It's acting on the ovary. On ovarian follicles. It's acting on the ovarian follicles. When it's acting on the ovarian follicles, the granulosa cells produce estrogen. FSH is acting on the granulosa cells. To be very frank, FSH is acting on the granulosa cells. So the granulosa cells are producing estrogen. Done. Now, estrogen ka kaam kya hai? What is the function of this estrogen? Anyone? The estrogen is going to go to the breast. Okay, it's going to go into the breast and helps in breast development. Breast development के लिए, okay, breast development like mammogenesis. Okay, like for the breast development, you need estrogen. And the same estrogen, it's also going to one more place, sir. Where it is going? Can you tell me what is the structure that I'm drawing here? Okay, see, this is the uterus, right? The estrogen will go to the uterus. And in the uterus, what it will do? In the uterus, it will help in development or proliferation of this layer. This is called as endometrium. The estrogens are going to act on the uterus. The estrogens are going to act on the uterus. Okay, let me write here. And what is going to do? Endometrial proliferation. Okay, so these are the functions of the estrogen. Estrogen का काम क्या है? Breast development, and estrogen is going to act on the uterus and help in the growth of the endometrial tissue or the endometrial proliferation. Done. Okay. Now, so far is that clear? So far is that clear? Shall I go forward? Yes. So in the beginning, for some students, certain students के लिए, it's a little hard, like to come with the pace. Okay, but I will be repeating the same topic, repeating again and again. In the beginning, it will be little difficult for us to sync to your level and to my level. It's a little difficult, but just wait. Okay, you'll get everything. You'll get everything. चलो. Now, अभी LH का काम क्या है? Okay, what's the function of this LH? LH का meaning like that. The full form of the LH is a luteinizing hormone. Okay, LH means luteinizing hormone. Now, every month one follicle is developed because of the FSH. Like because of the FSH, one follicle is developed. No, one follicle is developed. Sir. Okay, follicle is absolutely developed. Look, one follicle every month, one follicle is going to completely develop. That developed follicle is called as what? Graphian follicle. Okay, this develop every month. One follicle is going to develop because of the FSH. One follicle, like of course many follicles develop, but at the end, one follicle is going to completely mature. So this matured follicle is called as, this is matured, this one, matured follicle. This matured follicle, okay, is called as Graphian follicle. Okay, sir, a Graphian follicle, this matured follicle. Now, this LH is going to act where? This LH is going to act on this Graphian follicle. Okay, in the middle of the month, every month in the middle of the month on the 14th day, the LH is going to be released. The LH is acting where? The LH is acting on the Graphian follicle. When the LH is acting on the Graphian follicle, do you know what happens? The follicle will rupture and release the oocyte. Okay, so the follicle is going to rupture. Okay, the follicle, it is ruptured. Okay, the follicle is ruptured, and what it have released? It have released the oocyte. The central oocyte is released. Okay, these are the granulosa cells. Okay, now the follicle is ruptured and it is releasing what? Oocyte. This is our oocyte. Okay, now what happened? What is this process, sir? The rupture of the Graphian follicle. A process का नाम क्या है? What is this process called as? So this process is nothing but ovulation. So who is helping in ovulation? Which hormone is helping in ovulation? It's the LH. It's the LH. Okay. Okay. LH is acting on the Graphian follicle. LH is acting on the Graphian follicle so that ovulation happened. Ovulation happened and oocyte is released. Oocyte is released. Okay. Now this ruptured follicle का नाम क्या है? This ruptured follicle का नाम क्या है? Follicle rupture हो गया. Oocyte release भी हो गया. Now this ruptured follicle is called as what? This is called as corpus luteum. Okay, just remember it's the corpus luteum. Okay, so it's the corpus luteum, the ruptured follicle, the ruptured Graphian follicle is called as, okay, let me write here, ruptured Graphian follicle. The ruptured Graphian follicle is called as what? Corpus luteum. Now this corpus luteum, what it will produce? Corpus luteum is going to produce what, sir? The corpus luteum is going to produce progesterone. This is the corpus luteum. This one corpus luteum is there, right? Now, after ovulation, this corpus luteum is going to produce progesterone. Okay. So this is what I want you to know. The ruptured graphene follicle is going to produce the progesterone, and that progesterone maintains the endometrium. It maintains the endometrium. Okay, for pregnancy, it maintains the pregnancy also. If at all pregnancy is there, it helps in the like maintenance of the endometrium during pregnancy. So ruptured graphene follicle produces what? Progesterone. Okay. So guys, wait. Here, what I want you to understand here is, sir, how many gonadotropins are there? FSH hai, LH hai. FSH, look here, FSH helps in production of estrogen, no doubt, right? FSH helps in production of estrogen. LH, what it is helping? LH by causing ovulation helps in the production of progesterone. Okay. So this is what I want you to know. FSH always for estrogen. FSH helps in the production of estrogen. Progesterone helps in the production, LH helps in the production of progesterone. Is that clear, sir? If you have any doubt, you can ask in the chat box. If you have any doubt, please ask in the chat box. Joshi Sharma is asking how maturation of the follicles is going to occur. See, how maturation of the follicle, maturation of the follicle, it's nothing but, when FSH is acting, okay, when FSH is acting on the follicles, the follicles are arrested, okay. Actually, in female, the follicles are arrested in meiosis 1. Meiosis 1 may, like, they have arrested. When FSH is acting on these follicles, that meiosis is going to be resumed. Okay, that meiosis is going to be resumed. That you will study in your gynecology, like that, how, in which phase the follicles are arrested and what happens. That you can study in your gynecology also. But here in physiology, mein, FSH helps in follicular development. LH helps in ovulation. Okay. See, like, it's very clear that if we are teaching from iPad, we can't have the camera on. When I'm writing, we can't have the camera on. That's the issue with iPad. Not with my iPad. Any iPad doesn't support camera. That's the issue, Aisha. That's why. Okay. Now, chalo. Certain questions. Now, let's discuss certain questions. Sir, A क्या है? Hypothalamus. A क्या है? Anterior pituitary. In anterior pituitary, which cell I have discussed? I have discussed about the gonadotrope. Sir, gonadotrope, it produces which gonadotropins? FSH, LH. FSH, LH. Sir, FSH helps in the production of what? FSH helps in the production of estrogens in females. And LH helps in the production of what? Progesterone. Now, Abhi, different question. Now, sir, when you have sufficient amount of estrogens, female ke body mein sufficient amount of estrogens are there. Okay, sufficient amount of estrogens are there. Do you require further estrogens? No. So what these estrogens will give? Estrogens will give negative feedback. Okay, estrogens will give negative feedback to FSH. Female के body में sufficient amount of progesteron है तो, so progesteron enough है. So these progesteron, what they will give? They will give negative feedback to LH. Okay, so who gives negative feedback to FSH? It's the estrogens. Who gives negative feedback to LH? It's the progesterone. Done. Questions? Done. LH के बारे में don't forget. LH helps in ovulation. LH helps in the production of progesterone. Done. Next. Continue, sir. So female का part हो गया. Now, let me discuss questions from the male. Again, question which was asked in the recent exam. Recent exam में भी एक question आया. Now, look. A है anterior pituitary. In males, maybe anterior pituitary is there. Now, what is the cell in the males? Right now, I'm talking about the males. So this is the gonadotrope. Gonadotrope. Sir, males may also, gonadotropes are going to produce what? FSH. Males may also, LH is going to be there. Okay. So in male, FSH is there, LH is there. Now my question to you, what is the function of FSH in males? What is the function of FSH in males? FSH in males. What is the function of FSH in males? FSH is going to act on testis. But let me show you the testis here. For example, a testis here. Okay. Testis mein, there are two types of cells. For example, testis mein, there are two types of cells. First cell is called as a Sertoli cell. Okay. First cell is called as Sertoli cell. Now this FSH in males is acting on Sertoli cells. Okay. Now the Sertoli cells, what they will do? So the Sertoli cells, they will release something called as inhibin B. Okay, inhibin B. Inhibin B. What this inhibin B will do? Inhibin B will give negative feedback to FSH. Okay, that's it. FSH in males are going to act on Sertoli cells. Sir, Sertoli cells. Okay, the Sertoli cells ka function is helps in spermatogenesis. The Sertoli cells, let me write here. Sertoli cells, they help in spermatogenesis. Okay, they are the nursing cells. Okay, they'll take care about the sperms. They are the nursing cells. They will help in the maturation of the sperms. Okay, the Sertoli cells form blood, testicular barrier. Okay, these are all the questions, sir. Sertoli cells, they help in spermatogenesis. They are the nursing cells. They form blood testicular barrier. Okay, and what they will release? They will release inhibin B, which will give the negative feedback. And LH ka kaam kya hai? LH is going to act on a different types of cell. L for L. LH is going to act on cells called as Leydig cells. Okay, Leydig cells. LH is going to act on which cells? Leydig cells. This Leydig cells is the most important question. Okay, Leydig cells. Now these Leydig cells, what they will release? Leydig cells produce testosterone in males. Testosterone. LH is going to act on the Leydig cells. Leydig cells produce testosterone. It's the Leydig cells produce L for L. LH acts on Leydig cells. Leydig cells produce testosterone. Now testosterone, is it powerful? No, it's not powerful. So Leydig cells, this testosterone, it will be converted into powerful testosterone called as dihydrotestosterone, DHT, with the help of enzyme called as 5-alpha reductase. Okay, so testosterone, with the help of this enzyme called as the 5-alpha reductase, it will be converted into dihydrotestosterone. And this dihydrotestosterone in males is responsible for this dihydrotestosterone, not the testosterone. Dihydrotestosterone is responsible for development of male external genitalia. That's the question. So male external genitalia is because of testosterone? No. Epiandrosterone sulfate? No. It is a dihydrotestosterone. Okay. Male external genitalia. And the same dihydrotestosterone, this DHT, this dihydrotestosterone is also responsible for male pattern baldness. Okay, males ko baldness hota hai na, like that baldness is because of what, which hormone? Is the dihydrotestosterone. Okay, male pattern. Okay, and with aging, like if a male is getting into his 60s and 70s, the same again question, this dihydrotestosterone is also responsible for one more thing. Okay, let me write here. It's also responsible for a pathological condition that is called as benign prostatic hyperplasia. Okay, males में prostate gland increases in size with age. Prostate gland size increases with age. That is called as a benign prostatic hyperplasia, BPH, benign prostatic hyperplasia. It's because of what? Dihydrotestosterone. So dihydrotestosterone is responsible for BPH, benign prostatic hyperplasia. It is also responsible for the development of male external genitalia. It is also responsible for the male pattern baldness. Okay, is that clear? So what this testosterone is going to do? So this testosterone, once you have enough amount of testosterone, this testosterone is going to give negative feedback for LH. In males, who gives the negative feedback to LH? It's the testosterone. Testosterone gives negative feedback to LH. Inhibin B gives the negative feedback to FSH. So I know it takes some little time. I'm trying to integrate as much as possible because lots of questions are going to come from this area. Okay. Nahala, I hope I have repeated. I hope you should understand. So can you repeat FSH? FSH simple. FSH, it helps in follicular development. Follicles are developed. They produces the like estrogens in females. In males, FSH acts on Sertoli cells. Okay, FSH acts on Sertoli cells. So Sertoli cells produce inhibin B. Okay. And Sertoli cells, the Sertoli cells in males, testis में Sertoli cells, they form a lining which is called as a blood testicular barrier. Okay. The Sertoli cells helps in development of the sperms. Sertoli cells kaisa hai, like they are like the nurses. What nurses will be doing in the hospital? Nurses will be taking care of the patients. In the same way, sperm development ke liye you require the Sertoli cells. They will give the nutrition to the sperms. Yeah, class will be till 7. Okay, I will be giving the breaks in the middle, like small breaks, like 5 minutes breaks I will be giving, and one lunch break will also I will give. Okay, you don't worry about that. So chalo, next. So, and in the recent FMG exams, what they will ask you? I have taught you, sir, a testosterone hai. It will be converted into what? Dihydrotestosterone, right? It will be converted into DHT. With the help of which enzyme 5-alpha reductase. Now, from pharmacology integration, who inhibits this 5-alpha reductase? A drug called as finasteride. Okay, so finasteride is a drug which will inhibit 5-alpha reductase. So what happened to DHT levels? Goes down. So male pattern baldness can be decreased. Okay, so finasteride is a drug which inhibits 5-alpha reductase, which is used for the treatment of baldness. Okay, to decrease the hair loss. Finasteride is 5-alpha reductase inhibitor. Chalo, done. Next. What else I should teach you? Gonadotropins wala topic completed hai sir. Gonadotropin topic is completed. Now, again, if you have as many white papers as possible. Hypothalamus, anterior pituitary. First thing already I have discussed. There is nothing I should be discussing now. It's everything completed, sir. Let me take black. Okay, this red color thing completed. GnRH acts on gonadotropes. Gonadotropes produce FSH, LH. This thing is completed. Done. Next, which color cell? Now there is blue color cell. This blue color cell, what it is producing? The blue color cell is going to produce CRH, right? CRH. The CRH is going to act on which cells? Corticotropes. The CRH is going to act on corticotropes. Now, corticotropes, what they will produce? Corticotropes are going to produce ACTH. From here, new topic. Okay, the CRH, corticotropic releasing hormone, is going to act on cells called as the corticotropes. So, corticotropes are going to release ACTH. Okay, so ACTH का full form क्या है? ACTH, adreno कार्टिकोट्रोपिक हार्मोन. Sir, ACTH का full form adrenocorticotropic hormone. Sir, in the name itself, it's there adreno. So where it will act? Adrenal gland. It's going to act on adrenal cortex. It's going to act on adrenal cortex. ACTH is acting on adrenal cortex. Not adrenal medulla, adrenal cortex. So now this adrenal cortex is going to produce ACTH. Whenever ACTH is acting on the adrenal cortex mainly it's going to produce cortisol. Cortisol. This is how cortisol is produced. Okay. So hypothalamus release CRH. CRH acts on corticotropes in the anterior pituitary. Corticotropes produces the ACTH. ACTH acts on adrenal cortex. So adrenal cortex release cortisol. So what kind of hormone is cortisol? It's stress hormone. Okay, stress hormone. So during stress, it increases in your body. During stressful conditions, it increases in your body. Okay, whenever there is stress, it increases in your body. Cortisol. It's the stress hormone. Okay. Next. So blue color cell is also completed. After blue color cell, what is the cell that we have discussed? It's a green color one. This green color cell, what it is going to release? The green color cell is going to release TRH, thyrotropin releasing hormone. Thyrotropin releasing hormone is going to act on which cells? Thyrotropes. Thyrotropes are going to release what? TSH. Thyrotropes are going to release TSH. TSH का full form क्या है? Thyroid stimulating hormone. Okay, thyroid stimulating hormone. Now this TSH is going to act on thyroid gland. TSH is going to act where? On your thyroid gland. So thyroid gland is going to make T3, T4. Okay, thyroid gland is going to make T3 and T4. And what's the next thing? The next cell is the pink color cell. I hope I have drawn the pink color cell. So pink color cell, what it is releasing? So the pink color cell is going to release something called as a growth hormone releasing hormone. Okay, growth hormone releasing hormone. The growth hormone releasing hormone is going to act on which cells? You know, it's already somatotropes. So somatotropes are going to produce growth hormone. Okay, growth hormone. Now, this growth hormone, where it will go? Okay, growth hormone releasing hormone acts on the somatotropes. So somatotropes are going to release growth hormone. A growth hormone, where it will go? So growth hormone, now you tell me, what is the structure? This is the liver. Growth hormone will go and act on the liver. So liver is going to convert, or like not convert, the growth hormone, when it's acting on the liver produces insulin-like growth factor 1. Okay, ILGF1, insulin-like growth factor 1, which is also called as somatomedian C. Somatomedian C. When growth hormone MCQ. This is the MCQ. When growth hormone is acting on the liver, liver produces insulin-like growth factor or somatomedian C. Simple question. Done, right? And what we are left with? Sir, now we have left with the last color nucleus, the black color one. Okay. Guys, listen with your both the ears. This is little special, sir. Okay. So I'm asking you, what is this black color cell? This black color cell is called as lactotrope. Anterior pituitary में lactotrope है. Okay. Now this lactotrope, what it will release? See, lactotropes always they're releasing prolactin. In female में lactotropes are helping in prolactin. Okay. Now my question to you, imagine. So there is this 20-year-old girl. Okay, imagine. Okay. So for example, there is this female. Okay. So 20-year-old girl, 20 years. She is 20 years. Now, is she secreting any milk? A 20 years old girl, she is not a pregnant. She is not a pregnant. Okay. She haven't delivered the baby. Now, do you think is she going to produce milk? No, there is no milk production. Why? Array, she is having hypothalamus. She is having anterior pituitary. Anterior pituitary में क्या है? Anterior pituitary में lactotrope भी है. Lactotropes are there. Then why she is not producing the milk? Because look, This is the answer. See, this hypothalamus is producing what? Dopamine, I have said you. Sir, this dopamine inhibits the lactotropes. Dopamine inhibits the lactotropes. So lactotrope inhibit ho gaya. So the dopamine inhibits the lactotrope. When lactotrope is inhibited, prolactin is not there. Prolactin is not there. Okay, not decreasing. Okay, let me keep a into mark here. Prolactin nahi hai. So prolactin nahi hai to milk production bhi nahi hai. So prolactin helps in what? Milk production. So a female before delivering the baby, okay, in female before delivering the baby, what is there? Dopamine is there. Okay, in a female who haven't delivered, she is having dopamine. Dopamine inhibits the lactotropes. Negative always. This is one inhibitory hormone. Dopamine inhibits the lactotropes. So prolactin nahi hai. So when prolactin is not there, milk production bhi nahi hai. Okay, so done. Okay. So these are the points which I want you to know. So based on this, I can write one thing. Dopamine is antagonistic of prolactin. Dopamine decreases the prolactin. Dopamine decreases the prolactin. So take this note. Dopamine is antagonist. Okay, it's an antagonist of prolactin. It's physiological antagonist. Okay, because dopamine decreases the prolactin. Okay, so far is that clear, guys? So far is that clear? Please tell me. Exactly, Garima, you are true. So dopamine levels decreases postpartum. After delivery, dopamine comes down. After delivery, dopamine comes down. Okay. So yeah, Vijay Krishna, some girls produce milk even though they are not pregnant. Okay, so, Vijay Krishna is asking, some certain girls, they might produce milk that is abnormal. That is called as a galactoria. Okay, so without delivering the baby, if a female produces a milk, that is called as what? Galactoria. Okay, that's an abnormal condition that is seen in conditions called as prolactinomas. We will discuss. Don't worry, we will discuss about that also. Okay, so for 1 hour we have discussed the basics. Okay, this 1 hour is very, very important. This 1 hour is very, very important because now I am going to discuss certain cases. 4 cases I am going to discuss. Okay, before going to the cases, first let me tell you 2 direct single liner questions. देखो, अरे ये एंटीरियर पिट्यूटरी है ना, देखो गाइस, ये एंटीरियर पिट्यूटरी है. एंटीरियर पिट्यूटरी में सेल्स है, 5 different types of cells है. If you stain those cells, okay, if you put hematoxylin and eosin stain, 2 cells will be in red color. 2 cells will take, okay, eosinophilic stain. They will be taking very, like, red color or, like, dark pink color they will take. Okay, so what are these acidophilic cells? It's the somatotropes which produces a growth hormone, and lactotropes. This lactotrope. See, these 2 cells are acidophilic cells. A lot of times this question has been asked. So which are the acidophilic cells in the anterior pituitary? It's the somatotropes and lactotropes. Somatotropes and lactotropes are the acidophilic cells. Okay, and these 2 hormones, the growth hormone and prolactin, they are also called as the twin hormones. Okay, they are also called as what? Twin hormones. Growth hormone, prolactin are called as what? They are called as the twin hormones. Why? Because they have similar structure. Okay, structural wise they have a little similar structure and they use the same type of receptors. So that's why they are called as the twin hormones. Just remember that one word. Acidophilic cells in the anterior pituitary, somatotrope, lactotrope, they are acidophilic cells. They stain dark pink in color. Okay, now that's the one question which I want you to know. Okay. Next, now let me discuss about the cases. I will come to this area later. First, let's discuss about the cases. Guys, imagine there is this one female, एक female sir. Okay, एक female है. Now imagine she is a 20-year-old female or 15-year-old female. She is going on scooty and she had an accident, for example. Okay, unfortunately she had a RTA, road traffic accident. So during that road traffic accident, she had a trauma to her head. Okay, she fall and she had a trauma to her head. So during this trauma, what happened is her pituitary stalk, Okay, this area is called as a pituitary stalk, sir. Okay, that pituitary stalk got severed. Cut means severed means cut. Here cut ho gaya. So what happened? Now hypothalamus. Okay, now hypothalamus is not a contact. It lost its connection with the pituitary gland. Anterior pituitary and posterior pituitary, they got separated. Like, yeah, the hypothalamus and anterior pituitary, they got separated. So what happens? Now releasing hormones are not coming. So if releasing hormones are not coming means what happened to growth hormone levels? Growth hormone kam ho gaya. Okay, TSH kam ho gaya. TSH is not getting released from the anterior pituitary because from above, thyrotropin releasing hormone is not coming. From here, the releasing hormones are not coming. So that's why see FSH is going down, LH is going down, ACTH is going down. All hormones are going down, but even dopamine is not coming from above. Now, even dopamine is not coming from above. When the pituitary stalk is severed or damaged, the dopamine is not being released from hypothalamus. It's not coming to the anterior pituitary. It's not coming to the anterior pituitary. When dopamine is not there, what happens? Now, lactotropes, they got activated. Now, lactotropes releases prolactin. So, prolactin levels goes up. So, this is the MCQ. If the pituitary stalk is damaged, all hormones decreases. See, all hormones decreases except prolactin. Sorry for the spelling mistakes. Like, you just try to correct them. So all hormones decreases except, okay, except prolactin. Prolactin increase hone to in this 20-year female, if prolactin is increased after the accident, what she will do? She will produce milk. She will produce milk. That abnormal milk production without baby is called as galactoria. Okay. Okay. That abnormal milk production is called as what? Galactoria. Galactoria. Okay, now you understood? So first case completed. In pituitary stalk damage, all hormones decreases except prolactin because the dopamine is not coming down. Is that clear, guys? Next. So case number 2 is Sheehan syndrome. Okay, case number 2 is Sheehan syndrome. So shall I explain you about the Sheehan syndrome? Sir, these are all integrated cases with medicine as well as gynec. Physio, gynec integration, physio and medicine integration. Why it is called acidophilic? See, acidophilic because they are taking acidophilic. Like acidophilic means the acid loving. Acidophilic means they will take acidic stains. Okay, they will take acidic stains. Acidophilic. Okay, eosinophilic or acidophilic, they are the same thing. Basophilic means they will love to have the blue color stain. Basophilic, like no, the base loving. So, एक क्या है Sheehan syndrome? Sir, let me explain one by one. Sheehan syndrome. Okay, let me explain in this slide. You don't need to draw this. Just look here. Now, who is she? She is a happy mother. Happy mother. Okay. Now there is a baby. Okay, there is a baby. Okay. Now, what happened? So the baby is getting delivered. Okay, during delivery, the baby delivered. Okay, just wait. Before delivery, let me tell you what happens. Array, guys, look, when the baby is growing, the mother have to take care about herself. See, the mother have to take care about herself, and the mother should also have to take care about the baby. Okay, the mother have to take care about herself, and the mother also have to take care about the baby. So during pregnancy ke time mein certain changes will happen in the mother. Okay, during pregnancy ke time mein certain changes will happen. What changes? One change is her pituitary gland size increases. Pituitary gland size increases. How much percent? 136% increase in size. Pituitary gland become 136%. 100% increase means double. Okay, 100% increase means double. 136 means the pituitary gland size becomes even more than double to supply the hormones for baby also. Okay, so if it is, see, now it's a bigger tissue, right? It's bigger tissue. The pituitary gland become hypertrophy. It's a bigger tissue. Now it will require, tell me, more blood flow or less blood flow? It will require more blood flow. It demands more blood flow. It requires more blood flow. Okay, it requires more oxygen. Okay, TK. Delivery date came. Okay, now you have delivered the baby. Okay, you have delivered the baby. Okay, the baby delivered, sir. Okay, the baby delivered. But during delivery के time में क्या हुआ sir? During delivery के time में, now you should tell me what happened. Delivery के time में, in this particular female, some problem came. Okay, so delivery हो गया. Even delivery के बाद भी, like, you know, even after the delivery, what is happening in her body? Sir, she is losing the blood. She is bleeding. Okay, blood is coming from her uterus, bleeding. So this condition is called as what? Lot of blood is going, sir. Lot of blood is going. That is called as post, means after. Partum means delivery, means postpartum means after delivering. Postpartum hemorrhage. So postpartum hemorrhage occurred. Lot of bleeding, sir. Whenever there is a lot of bleeding, what happens? Sir, in this female, now she is not happy. Okay, so lot of bleeding is happening. Now look, whenever there is a lot of bleeding, her BP decreases. Whenever her BP decreases, in order to maintain the BP, in order to increase the BP, the blood vessels will undergo spasm. The blood vessels will undergo vasoconstriction. See, already the BP is going down. In order to protect her, in order to keep her alive, the blood vessels will undergo spasm like this. To increase the BP, the blood vessels will undergo vasoconstriction. So now look here. Now, see, when the BP is decreasing, there is vasoconstriction. Whenever the vasoconstriction, now in this female, see, the blood vessels are undergoing vasospasm. Postpartum vasospasm, vasoconstriction. Whenever the vasoconstriction occurs, what happened to the blood flow? Sir, blood flow to all organs decreases, also anterior pituitary. So blood flow decreases. On one side, pituitary gland is asking more blood. Okay, it demands more blood. But what is happening in her body right now? Because of the severe vasospasm or vasoconstriction, blood flow decreases. So that will cause ischemia. Okay, that will cause ischemia of pituitary gland. First ischemia occurs. Later, the pituitary gland will die. The total pituitary gland will undergo necrosis. The total pituitary gland will undergo necrosis, sir. So this condition is called as postpartum necrosis of pituitary gland, also called as Sheehan's syndrome. Okay, because of the severe vasospasm, blood flow decreases, leading to ischemia of anterior pituitary. Okay, so let me write here. Say postpartum means after delivery, there is a necrosis of pituitary gland in certain females. Which females? So those females who have PPH, postpartum hemorrhage. They will see either देखो the पूरा का पूरा. Okay, and this pituitary gland, sir. This is the pituitary gland. Okay, the whatever I am showing here, this is the pituitary gland. पूरा का पूरा pituitary gland is gone. So what happens? Growth hormone levels decrease, TSH decrease, FSH, LH, ACTH, even prolactin. See, even prolactin is going down because lactotropes bhi mar gaya. Like, you know, even the lactotropes are dead. Okay, I'm not very good with the Hindi. I'm trying to manage with whatever little I know. Okay, whatever little I know. See, lactotropes are also dead. So what happens? Even prolactin is going down. Okay, all hormones decreases, even prolactin. All hormones decreases, even prolactin. Done, sir. That's it. So in medicine or in gynecology, how they will give you is, see, this female after delivery ke baad, what is required? She requires, or she have to do the breastfeeding. Are abhi prolactin nahi hai. Whenever prolactin is not there, so there is failure to what? Breastfeed. Okay, so failure to breastfeed. So breastfeeding is not happening because she is not having prolactin. So failure to breastfeed after delivery. Think about Sheehan syndrome. Failure to breastfeed. Think about Sheehan syndrome. Okay, is that clear? So 2 cases are completed. Okay, failure to lactation or failure to breastfeed. Okay, she will also be very weak because TSH is not there. Okay, thyroid hormones are not there. She will become very weak. Okay, muscle pains are going to be there because thyroid hormones are not there. That will cause muscle pains. Okay, a lot of things will happen. Failure to lactation is the most important point. Failure to lactation, failure to breastfeed. Is that clear, sir? Chalo, next. Case number 3. Case number 3, highly integrated with the pharmacology. Okay, let me ask you one thing. Sir, before this class, before this physiology classes, you had which classes? Okay, which online classes before this physiology? Which online classes happened before physiology? Oh, patho. Before patho? Okay, only general patho completed. Only general patho completed. Cell injury, inflammation, neoplasia, genetics. Only general patho. Okay, done. Understood. Okay, take it. Let me ask you one thing. Before explaining the concept, let me ask you one thing. Alright, guys, imagine there is this one couple. Okay, imagine they're newly married couple, sir. Okay, a boy and there is a girl. Okay, boy and girl, they got newly married. Okay, they got newly married. And this fellow, after marriage, immediately he went to some foreign country because of some other purpose, like, he's working there, he's working in some, like, the Middle East, or he's working in America or somewhere. He went, okay, immediately after marriage. Now, after 6 months, he's going to come back. Imagine, he's coming back after 6 months to meet his wife. Okay, now tell me, is he going to be excited or not? Okay, he's going to meet his wife after, like, newly married couple, they are meeting after 6 months. Is he going to be excited or not? Or is she going to be excited or not? Tell me. Yes, of course they're excited. Okay, they have planned many things. Okay, they will be planning many things and they are going to be absolutely excited. Okay, they're newly married couple, like, many things are very new, so they are very excited, very much excited. Okay, am I right or not? Right. Now, imagine this couple are going to stay for the next 1 month together. 1 month they are going to stay continuously. This husband is going to stay with the wife continuously for 1 month, or, like, maybe for 6 months. He's continuously staying. Do you think even after 3-4 months, do you think the same excitation is going to be there? Definitely not. Definitely no. The same excitation is not going to be there. He will be feel like, okay, like, okay, let me go back. And his wife is also like, you are eating my brain. You please go back. Okay, the kind of thing will be there. So same logic applies. Even in our hypothalamus and anterior pituitary. Look, the concept is, okay, let me erase this. Continuously, if someone is there, continuous relationship is boring, right? Continuous relationship is boring. Once in a while, coming and going, that's excites. Dekho idhar. A hypothalamus. This is the hypothalamus. Okay, and what is this? Anterior pituitary. Hypothalamus and anterior pituitary. Now, let me teach you about what is this. This is the gonadotrope. So not gonadotrope. This is nucleus, right? Hypothalamic nucleus. It is releasing GnRH. GnRH. Now this GnRH is going to act on itself. Gonadotropes. Now the important point is how this GnRH is coming. Usually during puberty, this GnRH, okay, it comes once in a while. This GnRH is coming in a day. It comes in regular intervals. Okay, not continuously. It comes once in every 12 hours, something like that. Okay, so GnRH is released in pulsatile doses. These are called as pulses. Pulses means it's a fancy word, like, coming in regular intervals, once in a while, pulses, little by little. Okay, so just like a husband, once if he's coming once in a while, okay, once in a while, the gonadotrope is happy, the wife is happy, excited. Now this gonadotrope is going to release what? FSH and LH. Both are produced. FSH and LH are getting released. Okay, so pulsatile release of GnRH excites the gonadotropes. So FSH is released, LH is released. Done. But if The same GnRH, if it is there in continuous form, so let me write. If you are giving this GnRH continuously, these gonadotropes are inhibited. The gonadotropes will become desensitized. The receptors will get desensitized. Okay, so these cells are going to be inhibited. So what happened to FSH-LH? FSH levels decreases, LH levels also decreases, inhibited. Okay, so here I am telling you, pulsatile, if you are giving GnRH in pulsatile doses, FSH is released, LH is released. If you are using the GnRH, or if you are giving GnRH continuously, if there is GnRH in continuous, release, then FSH levels goes down, LH level goes down. So if you ask me, sir, how this is helpful for us, like in FMG exam mein, how this is going to be helpful for us? In pharmaceutical industry mein, pharmacy mein, okay, in pharmaceutical industries, we have manufactured drugs which are similar to GnRH. GnRH like drugs. We have manufactured GnRH like drugs, are also called as GnRH analogs. We have manufactured GnRH analogs. Okay, so what are those drugs? Now that's the question. See, there are drugs like GnRH analogs. Here I have written leuprolide, nafrelin, goserelin, buserelin. Okay, all these are GnRH like drugs. I have taught you already. Okay, I have already taught you continuous GnRH. What it will do? It will suppress. It will suppress FSH, LH. Gonadotropin release means if it will suppress FSH and LH, gonadotropins. Are my questions to you one by one. Look, now pathology, sir. देखो, एक female है. Now she is sad, sir. Okay, she is sad. Why she is sad? Because she is 18 years old. Maybe she is 18 years old. She's little sad. She's crying because she haven't had her menses started. No menstruation. No menses. Okay, no menses means she is not into her menarche. Menarche not started. Okay, puberty not started, sir. No menses. No breast development. Okay, she's little worried. Every girl, okay, is into their menarche. Okay, everyone attain their puberty, but I'm 18 years. Okay, still I haven't got my puberty. 18 years, 16 years, I haven't got my puberty. No menses, no breast development. So what you have to do? You have to give this GnRH like drugs. Dekho, you have to use this GnRH like drugs. How you have to use them? In pulsatile dose. Because pulsatile dose is what they will do. They increases the FSH. They increases the LH in this female. Okay. So if I'm the doctor, I will give the GnRH analogs. How I will give GnRH analogs? In little by little, pulsatile doses, not high doses, little by little. Okay. So I will ask her to take every day as one small tablet. Okay. After every 12 hours, something like that. Pulses. Okay. If I am giving in pulses, what happens? Her anterior pituitary is stimulated. Anterior pituitary, it releases what? FSH and LH. You know, FSH helps in follicular development. Estrogens are going to be produced. Estrogens helps in breast development. Estrogens helps in endometrial proliferation. LH helps in ovulation. And after ovulation, you know, the things like, you know, after that, after some time, after 14 days, menses will also occur. Okay, so for the treatment of this, the one single question from pharmacology and physiology, very much integrated. Delayed puberty ko, how you are going to treat? You are going to use this GnRH analogs in pulsatile dose. Okay, in pulsatile dose, you are going to use that in pulsatile dose. Next, see, next case. So, there is this one female. Okay, there is this one female. Okay, sir, she is just 8 years old. She's just 8 years old. Now she have started her menstruation. Okay, she have started her menstruation. So 8 years में menstruation, do you think it's normal? No, definitely not. Okay, she is also worried. Her mother is worried. Her mother is worried because do you want such a small girl to go through all this painful process, menstruation and all at 8 years? No, definitely not. She's very such small girl. She doesn't know anything about it. Okay, so what you have to do? You have to stop this menses. You have to stop the reproductive cycles. You have to stop the reproductive cycles. For that, what you have to use? Are same drugs use karo. Okay, like use the same drugs, same GnRH and logs, but use them in continuous dose. Okay, use the drugs in continuous dose. They continuously use kare, so what happens? I have taught you continuously. If the husband is staying with the wife is going to be bored, and the husband is also going to be bored. In the same way, if you are giving the drugs in high dose continuously, her anterior pituitary gonadotropes are inhibited. FSH goes down, LH goes down. So without FSH, LH, reproductive cycles cannot occur. Without FSH, no estrogen. Without LH, no ovulation, no menses, nothing will occur. So precocious puberty. Precocious puberty is also called as early puberty. Now this female is having what? She is having precocious puberty, early puberty. We have to use the same drugs in continuous dose. So precocious puberty, how you have to use them? You have to use it in continuous dose. Not only for precocious puberty, remember, like other integrations, I just want you to by heart this. In endocrine mein, sorry, gynecology mein, there is a condition called as endometriosis. That's growth of endometrium outside the uterus. Okay, endometriosis means more and more endometrium is growing outside the uterus, maybe in the abdomen, maybe in the fallopian tube, maybe in the ovaries. So इस condition को भी how you have to treat? Continuous GnRH. Breast cancer के लिए and prostate cancer के लिए भी you have to use these drugs. Okay, that's like you will study these three things in pharma. Just I'm trying to integrate. So precocious puberty, endometriosis, breast cancer, you have to use this GnRH drugs in continuous dose. That's it. So all cases are completed. Okay, all cases are completed, sir. So GnRH drugs, they can be used in pulsatile doses for the treatment of delayed puberty, and they can be used in continuous doses for the treatment of precocious puberty, also endometriosis, breast cancer, and prostate cancer. Okay, in all these three conditions, or you can say all these four conditions, we want to decrease the FSHL. You have to decrease the FSHLH. You have to decrease the estrogen. Okay, so is that clear? I'm asking you. So we have almost started, like, no, it's almost 1 hour 20 minutes. 1 hour 20 minutes ho gaya. Is that clear? It's reversible. Okay, of course it's reversible. No, it's reversible. Once you stop the drugs, everything will come back. Okay, it's reversible. Abra Alam, like, no, I will try to repeat wherever you want, but like, try to be a little attentive. If it is stop working, like try to get connect with a better Wi-Fi, like, because other students are also there, no, that's why. First, let me ask you some questions. So far, delayed puberty को treat करने के लिए, for the treatment of the delayed puberty, okay, you are going to use the GnRH and LOX in continuous form or delayed, continuous form or pulse style form. Tell me. If there is precocious puberty, tell me. If there is precocious puberty, you have to use them. Come on, guys, be active. I want you to be active. If there is precocious puberty, what do you have to do? You have to use the drugs in which form? Continuous form, or you have to use the GnRH and LOX in continuous form or pulsatile form. Precocious puberty treat करने के लिए. Satish, Sebin, Sushmita, Abra, Gharima, Sai Pranati. Oh, okay, you are messaging. I haven't seen. Yes, continuous form. Can you tell me, sir, in females, estrogens are produced by which cells? Estrogens in the females are produced by which cells? Let me see who can answer. Estrogens are produced by which cells? Which cells? Cells, Satish. Cells. Granulosa cells. Testosterone is produced by which cells in the males? Testosterone is produced by which cells in the males? Leydig cells. Testosterone is produced by Leydig cells. Leydig. Okay, Leydig cells. In females, testosterone is produced by. In females, testosterone is produced by theca internal cells. Theca in female, testosterone is produced by. In females, testosterone is produced by the theca internal cells. Okay, theca internal cells. Okay, done. Now, in Sheehan syndrome, that is the postpartum necrosis of the pituitary gland, which hormone level increases? Sheehan's. Any hormone level increases in Sheehan's? Any hormone level increases? No hormone level increases. No hormone level increases. Okay. In pituitary stalk damage, which hormone level increases? In pituitary stalk damage, prolactin level increases. Okay, done. Chalo. Let's go forward. The last case. One more case is there. Yeah. Okay. So this is also a repeatedly tested thing. In FMG exam, repeatedly tested thing. Sir, इधर देखो. Now we are having a tumor. So this is the hypothalamus. Okay, imagine hypothalamus. ये क्या है? Anterior pituitary है. This is your anterior pituitary. Anterior pituitary में this cell is there. This is the lactotrope. ये क्या है? Lactotrope. Lactotrope को tumor आ गया now. Okay, lactotrope को क्या है? Now it is getting the tumor of the lactotrope. So this tumor of the lactotrope is called as what? Prolactinoma. So the tumor of the lactotrope is called as prolactinoma. That's the most common tumors, most common anterior pituitary tumors. Pathology, very, very important. Prolactinomas are the most common anterior pituitary tumors. I think it's already there. So yeah, it's already here. See, prolactinomas are the most common anterior pituitary tumors. So a tumor आने तो anterior pituitary को tumor आने तो. Okay, for example, there is prolactinoma, sir. See, this tumor of the anterior pituitary, it will come and compress. Okay, these prolactinomas are the tumors of the anterior pituitary. When they are growing, tumor hai to like big cells, right? Big mass of tissue. That will start to compress the structure, sir. See, this optic chiasm is getting compressed. That optic chiasmal area is getting compressed because of this tumor. Okay, so here, this is the prolactinoma. A tumor hai na? A prolactinoma hai. This tumor, what it is showing? It's showing the mass effect. It's showing the mass effect. Mass effect means compression. It's compressing the visual pathway. Visual pathway compress ho gaya. So, aisa compress hone to what happens? If the visual pathway is getting compressed, definitely vision loss will be there. What kind of vision loss? So, if the optic, see, prolactinoma, if it compresses the optic chiasm, okay, this structure is called as optic chiasm. Okay, if optic chiasm is compressed, that will lead to, say, vision loss. Which type of vision loss? In both the eyes, the side vision is going to be lost. Okay, the central vision is okay. But the side vision is lost. So they go on this side, the person can't see this half, and on the other eye, the person can't see the other half. The sides, here is the nose, for example. So medial vision is okay, but the side vision is gone. Gaya. So this is called as a bitemporal hemianopia or anopsia. Both are like, you can say anything. So bitemporal hemianopsia or anopia. So prolactinomas compresses the optic chiasm, leading to bitemporal hemianopsia. Okay. Are prolactinoma hai to see prolactinoma, what it is going to produce? Prolactinomas produce what? Prolactin. Prolactinomas produce high levels of prolactin. This prolactin, what it will do in the female? See, for example, this is happening in a 15-year-old female or 20-year-old female. अरे prolactinoma के वजह से, because of this prolactinoma, ज़्यादा prolactin है body में. Prolactin, what it will do? It will produce the milk. So 15-year-old girl is producing the milk. So that is called as what? Galactorrhea. Abnormal milk production, galactorrhea. This prolactin also stimulates the breast. Okay, in males especially, this prolactin in males, only in males, this is going to happen. Prolactin in the males causes breast enlargement in males. Because of the high levels of prolactin, the males will have a female-like chest. Okay, so that's called as a gynecomastia. Okay, this is called as the breast development in males. Breast and development in males. Breast development in males. Okay, so females are going to have abnormal milk production is going to be called as a galactorrhea. It's only seen in females, sir. Males में galactorrhea is not seen. galactoria, it's milk production. Abnormal, there's abnormal milk production. Abnormal milk production. Now, one more thing. See, have you ever heard, I'm asking you, imagine there is a female. Okay, imagine there is a female. She delivered a baby. Okay, she delivered a baby. After delivering the baby, so this female may menses are not going to be seen. This female may menses are not going to be for almost 6 months. Have you ever heard about it? Delivery के बाद female में delivery after the delivery, the female is not going to have the menses for the next 6 months to 1 year sometimes. Okay, do you know why? Because she is breastfeeding. That's lactational amenorrhea. She is breastfeeding. Yeah, exactly. Let me tell you the concept here. The baby is feeding, no? When the baby is feeding, in the mother, what is there? In the mother, prolactin is there. When the baby is having the breastfeeding, prolactin is there. Prolactin. Do you know what this prolactin will do? Prolactin inhibits GnRH. So prolactin inhibits GnRH. So GnRH is not there. GnRH nahi hai to FSH bhi nahi hai, LH bhi nahi hai. Without FSH and LH, no menses. Simple. Done. Okay. So during breastfeeding, prolactin is there in the mother. Prolactin inhibits, this is the point which I want you to know. Prolactin inhibits gonadotropins, FSH, LH, so menses nahi hai, amenorrhea. The same way, even prolactinoma's condition may be. Okay, even in the prolactinoma condition, zyada prolactin hai body mein, a lot of prolactin is there. So prolactin is there, that is leading to amenorrhea, no menses. So this 15-year-old girl or 20-year-old girl who is going to have the prolactinoma, so menses stopped because of this prolactin. Prolactin inhibits the GnRH. So no FSH, no LH, no menses. So the female is going to have amenorrhea. Okay. So what are the problems because of the prolactinoma? The prolactinoma is going to cause a bitemporal hemianopsia. Amenorrhea is going to be there. Galactorrhea and gynecomastia is going to be there. Amenorrhea, galactorrhea, gynecomastia in the males. And in the males, because of the prolactin, even the libido, the sexual drive, the feeling for the sex, the urge for the sex, the desire for the sex goes down. Okay, so that prolactin is also going to decrease the libido. Okay, in males and as well as the females, the libido is going to be decreased. The desire for the sexual activity is going to go down. So now, how we are going to decrease the prolactin? Now in these females, the main problem is prolactin hai, zyada prolactin hai. So how we can decrease the prolactin? By giving dopamine, by giving drugs like dopamine. Okay, so for the treatment of the prolactinomas, all of the following drugs can be used. See, like we can use dopamine, or this L-dopa. L-dopa will be converted into dopamine in the body, or dopamine-like drugs, or dopamine receptor agonists like cabergoline, bromocriptine. They are nothing but the dopamine. This cabergoline, bromocriptine, they will go and stimulate the dopamine receptors. They act like dopamine. So drugs like cabergoline is the drug of choice for prolactinoma. Cabergoline, bromocriptine, L-dopa, dopamine, all these can be used. See, I have given here the 4 drugs. Why I have given the 4 drugs? Because this is the question. All of the following can be used in the treatment of prolactinoma, except kind of question is asked. So cabergoline, bromocriptine, levodopa, dopamine, all can be used because all will decrease the prolactin. Okay, so topic completed. Case 4 completed. Prolactinomas causes decreased libido. True. Prolactinomas causes gynecomastia, galactorrhea, amenorrhea, bitemporal hemianopsia. Even it causes headaches. Because of the prolactinomas, the patient is going to have the headache. Okay, write that also if you want. So done, sir. Is that clear? If you feel like, sir, you are going too fast, please let me know. Again, I am telling you, trust your teacher. Trust me. Okay, trust me. That one single book, that one single physiology book, whatever is there, it might look little bulkier. But yeah, I will send the PDF after the class. It might look little bulkier, but it will give you almost 15 to 20 questions. If you go through it in detail, whatever I'm teaching you, Not only physiology, but even the integration questions will come. Okay, all physiology questions are going to come, no doubt about it. Okay. Yes, of course, infertility can be caused by because of the prolactinoma. Infertility because without ovulation, without that thing, how we can expect the fertilization? Yes, of course, true. Of course, true, Shalu. Shalu, is that Shalu? Shalu, yeah. Okay, come on, take a deep breath, sir. Yes, of course. Of course, theoretically speaking, after 6 months, even if she want to get pregnant, she can't become pregnant. Okay, within the next 6 months. Of course, there are exceptions. I know people who got pregnant even after 1 month, but theoretically speaking, in majority of the people, even if they want to become pregnant after delivery for the next 6 months, they can't become pregnant because prolactin is there. Now the mother have to think about it. Mother have to take care about the baby. Already one baby is there. Okay, nature have decided already one baby is there. So no second baby after 6 months, till 6 months. Okay. Inhibitory action of somatostatin. I'm coming there. Somatostatin, Garima, I will come there. Okay. So done. Next. Garima is asking, sir, A kya hai? Inhibitory control by hypothalamus is shown on. Okay. Come to this slide, sir, once. Come to this slide. Before this slide, it is there. Before this. I have already taught you. Dekho. So this is hypothalamus. This is anterior pituitary. Hypothalamus, anterior pituitary. Hypothalamus mein there is a nucleus, different nucleus. This is a different nucleus. Okay, this is a different nucleus, and this is a different nucleus. One nucleus already you know what it produces, a dopamine. Okay, dopamine. This dopamine, what it will do? This dopamine, it will come and inhibit what? Dopamine inhibits lactotropes. Dopamine inhibits lactotropes. So what happened to the prolactin? Prolactin decreases. Okay, there is no prolactin. So this hypothalamus, look, hypothalamus, by producing the dopamine, it can inhibit prolactin. One thing. And not only that, there is one more nucleus which produces something called as growth hormone inhibitory hormone, which is also called as somatostatin. Okay, somatostatin, growth hormone inhibitory hormone. Okay, so this growth hormone inhibitory hormone, okay, it will come and it will act on this growth hormone inhibitory hormone. It will act on somatotropes. Somatotropes, you know, somatotropes produces what? Growth hormone, right? So this growth hormone inhibitory hormone, what it will do is it will inhibit the somatotropes. Okay, they will inhibit the somatotropes. So what happened to the growth hormone? Growth hormone levels decreases. Okay, so regulation wise, so growth hormone inhibitory hormone and dopamine, they can inhibit growth hormone and prolactin. So this is the question in one of the NEET PG exams. This was the question asked in the NEET PG exam. Inhibitory control by hypothalamus is shown on which hormones? By producing somatostatin, growth hormone levels can be inhibited, and by producing dopamine, prolactin levels can be inhibited. That's it. Okay, Garima, is that okay? Done. Chalo, next, posterior pituitary. Guys, now itself I am telling you. Look, in your book, lot of certain unnecessary things are also there. I'm going to omit them. Lot of unnecessary things, like too much pathology related things are also there. Pure pathology topics are also there. I will omit them. Now itself I am telling you. For example, if you go to the thyroid topic, thyroiditis, a lot of topics are there which are going to come in pathology. Okay, usually I have designed this book both for first year students as well as for the exam going students. For exam going students, I will strike out certain topics. Okay, I will strike out certain topics. For example, I will do like this. Means they are not needed. Okay, they are not needed. Okay, so chalo, let's continue with the posterior pituitary. Posterior pituitary. Posterior pituitary. Now my question to you: it produces which hormones? Posterior pituitary produces which hormones? Take a big star mark. It does not produce any hormones. Does not produce any hormones. They just store the hormones. This posterior pituitary, it store two hormones. What are they? Oxytocin or antidiuretic hormone or vasopressin. Oxytocin and vasopressin. Okay. Oxytocin and vasopressin. These are the two hormones which are stored in the posterior pituitary. Now let me discuss about the oxytocin. Very famous question in FMG exam, even the last FMG exam, not this FMG exam, last. Okay. Oxytocin, from where it is produced, sir? It is produced from the paraventricular nucleus, PVN, paraventricular nucleus of hypothalamus. Okay, sir, this vasopressin or antidiuretic hormone, it is produced from where? It is produced from supraoptic nucleus of hypothalamus. Supraoptic nucleus of the hypothalamus. Let me draw a small image. It will be easy for you to understand. Dekho guys, a hypothalamus hai. Hypothalamus mein these are different nuclei. These are different nuclei. Right now I am drawing what? I am drawing the posterior pituitary. Hey sir, posterior pituitary. Okay, this is the posterior pituitary. Posterior pituitary. So this nucleus, what is this nucleus? First nucleus is supraoptic nucleus. This supraoptic nucleus, it produces antidiuretic hormone. And that is going to come and stored where? It's going to come and getting stored in the posterior pituitary. Now this paraventricular nucleus, right? Paraventricular nucleus of hypothalamus. It produces what? It produces oxytocin. And where it is oxytocin getting stored? Oxytocin is getting stored in the posterior pituitary. Done, sir. Okay, so supraoptic nucleus produces antidiuretic hormone. Paraventricular nucleus of the hypothalamus produces oxytocin. And they are coming and getting stored in the posterior pituitary storage. This is the storage site. FMG question. FMG question. Look, FMG question. Now, antidiuretic hormone, the FMG question is this one. Array, there is a vesicle. Dekho. There are vesicles. Here, this is the vesicle in which antidiuretic hormone is stored. ADH is stored. ADH, antidiuretic hormone. So the vesicle in which the antidiuretic hormone is stored, these vesicles are called as Herring bodies. This is the question which was asked. Okay, so Herring bodies are the vesicles in which the antidiuretic hormone is stored. Okay, now one more thing. How to remember this, sir? Sir, today you are teaching us, okay, for the next 1 week, we can remember this. But after this, how? Just there is a mnemonic. The mnemonic is SOAP. 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 See, S for supraoptic nucleus. Supraoptic nucleus. It produces what? Antidiuretic hormone. Sir, P for paraventricular nucleus. Paraventricular nucleus produces oxytocin. Don't confuse. The arrow should be like here. Supraoptic nucleus produces antidiuretic hormone. Paraventricular nucleus produces oxytocin. SOAP. Mnemonic is SOAP. FMG question. Supraoptic nucleus. Supraoptic nucleus produces antidiuretic hormone. Paraventricular nucleus produces oxytocin. Done. Now questions regarding the oxytocin. Sir, oxytocin का काम क्या है? Sorry. Just wait. Doctor, could you please explain inhibitory reactions of somatostatin? I have explained. It is mentioned in the notes. Okay, done. Okay, is everything clear? Okay. Now, look, sir, oxytocin ka functions kya hai? You know, already know. Oxytocin causes uterine contractions. Simple, very easy. Oxytocin is responsible for milk ejection. Milk ejection. When the baby is sucking the nipple, when the baby is latching onto the mammary glands, and when the baby is sucking the nipple, the milk have to come. Milk have to come. Okay, milk have to come out of the breast. So that is called as milk ejection. Or instead of milk ejection, they will also use the word galactokinesis. Okay, galactokinesis के लिए. Okay, for galactokinesis, galacto for milk, kinesis means movement, or milk ejection. What do you require? Oxytocin. Oxytocin. And the same oxytocin is also used for, it's a drug of choice for treating which condition? For the treatment of condition called as postpartum hemorrhage. When the female is bleeding, blood. Okay, when the female is bleeding, like no, bleeding out of her uterus, blood is coming out. What do you have to give? Give oxytocin. Uterus will contract and bleeding will stop. Uterus will contract, bleeding will stop. For the treatment of postpartum hemorrhage, you can use oxytocin. And in gynecology, will study so breast engorgement condition ke liye bhi. Okay, for the breast engorgement condition, you can use oxytocin. For induction of labor, this is induction, INDU, sorry, spelling mistake, induction. Okay, so for the induction of labor, can you tell me what is induction of labor, sir? Anyone in this class? Anyone who is listening to this class, can you tell me what is induction of labor? This might have nothing to do with the induction stove. Induction of labor. Induction of labor means the female got 38 weeks pregnancy, 9 months completed, 38 weeks ho gaya, 40 weeks ho gaya, but she is not going into the delivery. You have to start the delivery. Means if you have to start the delivery, give oxytocin. If you want to initiate the labor, if you want to kickstart the labor, if you want to start the labor, give her oxytocin. That is called as induction of labor. So for induction of labor, what is the drug of choice? Oxytocin. Breast engorgement, oxytocin. Postpartum hemorrhage, treatment. Even for prevention and treatment of postpartum hemorrhage. The drug of choice is oxytocin. For both for prevention as well as the treatment ke liye bhi, we will use oxytocin. So oxytocin is produced by parametric nucleus, helps in uterine contractions, helps in milk ejection. It's a drug of choice for postpartum hemorrhage, breast engorgement, and induction of labor. Okay. Next, antidiuretic hormone is produced by supraoptic nucleus. I have explained to you. And where it is stored? The antidiuretic hormone is stored in which bodies? Ring bodies. Okay, ring bodies. Done, sir. Now I'm asking you, sir, the next topic, the small topic is there. I will explain you. Is it clear so far? Okay, is it clear so far? Come on, sir, once. Please give me the confirmation. If I see yes, sir, from your side, I will be very much happy. I will also be happy. Okay. Yeah, bacho, now let me show you one question. These are all the previous year questions. So this is a question which was asked 2 times in exam. Okay, FMG exam mein, and even in INACD exam, once in FMG exam, once in INACD exam, this question has been asked. Now, it's from the endocrine physiology as well as gynecology. Endocrine physiology, gynecology, sir. Now, try to answer this. Upon cervical stretch means the delivery. The baby is coming down. Baby is going down into the cervix. From the uterus, baby is going down. Okay, you know, right? Dekho. This is the uterus, fallopian tubes. The baby is going down like this. Okay, cervix is getting stretched. The cervical area is getting stretched. Upon cervical stretch, uterine contractions and delivery occurs. When the cervix is stretched, see, once the cervix is stretched, automatically uterus will contract. Upon cervical stretch, uterine contractions and delivery occurs. Which of the following shows similar mechanism? Take a screenshot if you want. Take a screenshot. Don't worry, I will include this in the PDF, our PDF also. When I'm sharing, I will share this also. Upon cervical stretch, uterine contractions and delivery occurs. Which of the following shows similar mechanism? Now, before answering, let me explain you. Let me show you the slide. Okay, don't write, just listen. Guys, idhar dekho. In our body, there are 2 examples. See, when the baby is coming down, or coming out of the uterus, first cervix will dilate and cervix will stretch. Now, this information via the neuron, see, what is the stimulus? Stretch of the cervix. Stretch of the cervix. In the late pregnancy, the cervix is going to stretch and the baby is going to come down, descend down. So, via the neurons, this information is going where? This information is going to the hypothalamus. Okay, the information is going to the hypothalamus and pituitary gland. So, what the hypothalamus and pituitary gland will do? Now they will release oxytocin. Now this is the time. Now this is the time to expel the baby. Now this is the time to expel the baby. So now oxytocin is being released. And what this oxytocin is going to do? See, the release of oxytocin. Oxytocin is going to cause contraction of the smooth muscle. The uterus is going to contract and delivery will occur. Delivery will occur. So this reflex is called as, whatever I have taught you so far, this reflex is called as a neuroendocrine reflex, because see, through the neurons information is going. This is the afferent. This is the afferent. Means through this neurons information is going to the central nervous system. And what is the response? Response is coming in the form of a hormone. Okay. One limb is afferent limb is neural and efferent is coming via the hormone. This is called as a neuroendocrine reflex. Okay, neuroendocrine reflex or neuroendocrine reflex. So this cervical stretch, upon cervical stretch, oxytocin is released, leading to the uterine contractions. This is called as neuroendocrine reflex. Okay, similar reflex is there in our body. Similar kind of reflex. What is that similar kind of reflex? When the baby, when the baby is sucking the nipple. Okay, when the baby is sucking the nipple of the mother, again, see, from the nipple, this information will go. The baby is sucking. This information will go to the hypothalamus. Okay, the information will go to the hypothalamus. And the baby is sucking. Now, immediately, the posterior pituitary, again it will release oxytocin. Means hormone is getting released. Endocrine hormone is getting released. One limb is a neural. One limb is information is going via the neurons. Afferent is a neural. And response is coming in the form of a hormone. Oxytocin is going to release. And what is the effect? Now see, milk ejection. Okay, so these are the two examples of neuroendocrine reflex. These both are examples of neuroendocrine reflex. So now tell me, based on this, what is the answer? Now, what is the answer? Milk ejection by oxytocin is also an example of neuroendocrine reflex. Okay, done. So with this, the basic things I have completed. The basic things, whatever you have to know in the endocrine, the basic things completed. Now after this, we can do the hormones. Shall I go to the hormones? Is that clear? This MCQ is clear? Okay, now itself I am adding it to the PDF so that there won't be any missing topic. So copy in our PDF. Okay, I'm adding it here. See, now itself I'm adding it, paste. I have added, okay? It is answer. Now now this is something happy for you. Now the happiest moment is take your pen and strike this table. This table will be discussed in renal. The same table will come in renal also. So here I'm not going to discuss. Okay, regarding this table, we'll discuss it in. This is all about the antidiuretic hormone, ADH receptor. We'll discuss it in the renal. Right. Topic discussed in renal. Renal physiology. Chalo, take a deep breath, sir. Deep breath and have a sip of water. Now let's discuss about growth hormone. The first hormone that I'm discussing is growth hormone. Hormone simple, growth hormone. You already know the story, sir. This is slide, you already know it. Hypothalamus. Let's go one by one. Hypothalamus first. What is releasing? Growth hormone releasing hormone. Growth hormone releasing hormone acts on somatotropes. Somatotropes produces growth hormone. Growth hormone, when it acts on liver produces insulin like growth factor or somatomedian C. I have already taught you this. Okay. See, when you have sufficient amount of insulin-like growth factor, it's the insulin-like growth factor. What it is giving? See, it's the insulin-like growth factor. It is inhibiting. Okay, just write the inhibit word here. Write it here. Inhibits. Okay. So inhibits. This insulin-like growth factor inhibits the anterior pituitary. The insulin-like growth factor is giving the negative feedback to the hypothalamus. Sufficient amount of growth hormone is there. Sufficient amount of growth hormone is there. So it is giving what? Negative feedback. The question which was asked in the exam is, who gives the negative feedback to growth hormone? The negative feedback to the growth hormone is given by insulin-like growth factor. Okay, for the production of the growth hormone, negative feedback is given by insulin-like growth factor. Insulin-like growth factor gives the negative feedback to hypothalamus as well as the anterior pituitary. It decreases the growth hormone. It decreases the growth hormone. Okay, done. And not only this, now say I have already taught you hypothalamus. Okay, hypothalamus produce something called as somatostatin. Okay, it produces something called as somatostatin. What is somatostatin will do? Somatostatin inhibits. Okay, somatostatin inhibits anterior pituitary. Somatostatin inhibits anterior pituitary. So growth hormone levels can go down. Okay, you already know this. Everything know this. The questions which you need to know is, who gives the negative feedback? Insulin-like growth factor gives negative feedback. This is the one question. Second question which I want you to know is, say when you are doing fasting. Okay, when you are doing fasting, what you will be having? So when you are having fasting, you will be having which feeling? Hungry. Okay, you will be having hunger. Right? You'll be having hunger. See, when you are having hunger, your brain, your intestines, okay, your brain, your intestines, they will produce something called as ghrelin. Okay. So during fasting or during hunger situations, your GIT, okay, your GIT, that's the intestines and stomach. Okay. And let me write here, your brain, your GIT, and your pancreas. These three things, mainly GIT, mainly GIT. Question is GIT. They will produce what? They will produce a substance called as ghrelin. This is ghrelin. They will produce a substance called as ghrelin. Question is, even this ghrelin will stimulate the somatotropes. So what happens when ghrelin is stimulating the somatotropes? Growth hormone level increases. Okay. So ghrelin also increases the growth hormone. True. Ghrelin also increases the growth hormone. True. Ghrelin increases during fasting. True. Growth hormone increases during fasting. True. All these statements are true. If someone asks you, sir, during fasting, which hormone level increases? Growth hormone level increases. Okay, during fasting, ghrelin increases. So stimulate the somatotropes. So growth hormone level increases. Done. Done. Okay. Ghrelin is mainly produced by, in one of the ARISE exams. I haven't gave that question. Some other faculty was giving this question. Which ghrelin is mainly produced by GIT. Ghrelin is mainly produced by GIT. That's the question. Okay, I have seen this in ARISE grand tests. Okay. Next. A growth hormone का काम क्या है? What are the functions of the growth hormone? Okay. Now here lot of things are there. I don't want you to remember each and everything. First, right, sir, growth hormone. It increases the blood glucose levels. First of all, okay, wait. First, right, it's an anabolic hormone. Anabolic hormone. Okay, anabolic hormone. Anabolic means what, sir? Anabolic means build up. Okay, building the body, it builds the body. Okay, increase the muscle mass, it builds the body. Anabolic means building, not breakdown, building. It increases the protein synthesis and all that stuff. It's anabolic hormone. It's one of the important anabolic hormone. Second thing, actions. Growth hormone, it increases the blood glucose levels. Most students don't know this, but this is very, very important. Growth hormone increases the blood glucose levels. Okay, growth hormone increases the blood glucose levels. How? By glycogenolysis. Lysis, glycogen will break down, or gluconeogenesis. Okay, gluconeogenesis. By these mechanisms, okay, growth hormone, by causing the glycogenolysis in the liver and gluconeogenesis and gluconeogenesis, they increase the blood glucose levels. True. Okay, they increase the blood glucose levels. Okay, that's a very important thing. So can I say growth hormone is a glucogenic hormone? Yes, it's a glucogenic hormone. It increases the blood glucose level, so it's a glucogenic hormone. Okay, glucogenic hormone. Okay. Next, what are the actions? The direct actions. Growth hormone ka direct actions means directly growth hormone. What it is going to do? It increases the bone growth, epiphyseal growth. You know it already. Okay. And it causes decreased insulin sensitivity. Insulin ko it's going to inactivate the insulin. Think like that. Think like that. Are insulin inhibit ho gaya? Insulin inhibit hone to what happens again? Blood glucose levels बढ़ जाएगा. Simple again. So growth hormone, what it is doing? Growth hormone causes a glycogenolysis, a gluconeogenesis, and it also decreases insulin sensitivity. That also increases the blood glucose levels. So finally, growth hormone increases the blood glucose levels. That's the one point I want you to know. Growth hormone increases the blood glucose levels. It increases the blood glucose levels. That's why it's called a glucogenic hormone. Okay. I have said you, growth hormone is an anabolic hormone building. So that's why I see protein synthesis, muscular body, big muscular body. Okay, proteins are going to go up in your muscles. Okay, your muscles are going to be bulkier, hypertrophy. Okay, and this sodium retention is not needed. And direct action says lipolysis. The fats, unnecessary fats will be broken down. You'll be getting what kind of body? That V-shaped body you are going to get. Okay, so you are going to get a gym physique. So proteins are increasing, but fats are going to go down. The lipolysis. So these are the direct actions. Bone growth, increase the blood glucose levels. Okay, a protein synthesis and lipolysis. Done. Now in PG exam में see this growth hormone का indirect actions है. Indirect actions का मतलब क्या है? What is the meaning of that? Indirect actions are mediated by insulin like growth factor. Growth hormone acting on the liver. See, growth hormone, when it acts on the liver produces insulin like growth factor. Now the actions because of insulin like growth factor are different. Okay, what are they? See, same bone growth, same things, same bone growth, same protein synthesis, but insulin like growth factor functions like insulin, and it is anti-lipolytic. This is a neat PG level question. FMG men, they have never asked it, but if you want to know it, know it. Insulin like growth factor, it's insulin like. See, here it is anti-insulin. Here it is decreases the insulin action, but insulin like growth factor is insulin like, and it is anti-lipolytic. Here it is lipolysis, here it is anti-lipolysis. But sir, if you say, sir, FMG exam ke liye what we require, they will ask you growth hormone. Just let me show you my face. Just so what they will ask you. Alisha, I am coming that diabetogenic. I will tell you that. Same growth hormone, anabolic hormone. Growth hormone increases the blood glucose level, so it's a glucogenic hormone. Okay, it's a glucogenic hormone. Next, growth hormone, normal direct actions. Lipolysis, protein synthesis. And bone growth. Indirect actions are mediated by insulin like growth factors. Insulin like growth factor is anti-lipolytic. Done. See here, Alisha Sheikh. Okay, Alisha, you are asking it's a diabetogenic hormone, right? Yes, of course it's a diabetogenic hormone because it is increasing the blood glucose levels. So super high levels of growth hormone can cause diabetes. Okay, because growth hormone increases the blood glucose. If you have so much glucose, that can lead to diabetes. So yes, growth hormone is also called as a diabetogenic hormone, no doubt. That will come anyway in the next slide. But if you want to write it here itself, right? As it is increasing the blood glucose levels, okay, growth hormone is also called as diabetogenic hormone. True. Okay. Now growth hormone ka abnormalities. Okay, some integration. See, if growth hormone is deficient during childhood, okay, because of some reason, pituitary gland is damaged or because of some reason, growth hormone deficiency, growth hormone available nahi hai, deficiency children mein. So growth is not going to be there. Okay, so that's going to cause a condition called as dwarfism. This is the heading. Deficiency of growth hormone during childhood is going to cause dwarfism. The body is not going to grow. The body is not going to grow. So the baby is going to have short stature. All the organs are going to be small. Okay, small penis, micro penis. Okay, not only micro penis, heart is going to be small, liver is going to be small, hands and legs, everything, every damn thing is going to be small. So short stature, micro penis. But important thing is, see, they are going to suffer with hypoglycemia. They are going to get unconscious easily. Easily they will be getting unconscious because growth hormone nahi hai. If growth hormone is not there, okay, if growth hormone is not there, blood glucose levels are not maintained. Okay, blood glucose levels are not maintained. So growth hormone increases the blood glucose levels. So growth hormone nahi hai, to they will go into hypoglycemia. So what is the treatment? Dwarfism ko, what is the treatment? Give growth hormone, recombinant growth hormone supplementation. So treatment, recombinant growth hormone supplementation for the dwarfism. For the treatment of dwarfism, recombinant growth hormone. That's it. Now, what if there is excessive growth hormone? Okay, what if there is excessive growth hormone? So growth hormone zyada hai, excessive. When during childhood, for example, during childhood, if there is excessive growth hormone, that's going to cause gigantism. The patient is going to be 8 foot tall, 8 foot tall or 9 foot tall. The patient is going to be gigant. So that condition is called as a gigantism. The patient is going to be tall. Okay, tall in height. Something like that. Tall in height. That's called as a gigantism. During childhood, gigantism means that is before the closure of epiphysis. Before the closure of epiphysis means bones may epiphyseal plate is going to be there. Bones may growth plate is going to be there. That's there in the epiphysis. Okay, so before the closure of growth plate, it causes gigantism. Now in me, for example, right now, okay, right now, if there is excessive growth hormone in my body, what happens? That is going to cause acromegaly. I can't increase in height. My height is stopped. Now what happens is, if I'm having excessive growth hormone, that's going to cause a condition called as acromegaly. See, my bones can't increase in height, sir, but they will increase in thickness. My bones can't increase in length. Lengthwise, my bones can't increase. Lengthwise, my bones can't increase, but thickness-wise, the bones will increase in the thickness. The grit is going to be increased. Okay. Garima is asking, doctor, by what age must the treatment of dwarfism should we start? As soon as diagnosed. Okay, as soon as diagnosed, we can start the growth hormone treatment. The more we do late, the lesser the the effects are going to be. As soon as diagnosed, we can start the treatment. Okay, so because of the increase in the thickness of the bones, what's happening? Because of the excessive growth hormone, because of the increase in the thickness, the patient is going to have frontal bossing, like a prominent forehead. Okay, the hand size and foot size increases. Okay, the size, see, because of the growth hormone, not only the bones, the size of the organs are also going to increase. Growth hormone increases the size of the organs also. The heart size increases, lung size, liver size increases. Okay, hand size, foot size increases. Okay, the tongue is going to be large. Okay, large fleshy tongue is going to be seen, and it's going to come out like a dog. Sometimes even it will come out. Okay, because so large, it can't fit in the mouth. Sometimes it's going to be even coming out large fleshy tongue because of excessive growth hormone. And see, the prominent jaw, the jaw is also going to be prominent. There's a protrusion of the jaw. Protrusion of the jaw is called as a prognathism. Okay, the mandibular enlargement. Okay, so the heart size is going to be increased. That's going to cause the cardiomyopathies. Okay, and these patients are going to have sleep apnea. Why sleep apnea? The tongue might fall back. Okay, the tongue might fall back onto the glottis. You know, right? The tongue is falling back onto the glottis, closes the glottis. That sometimes causes a sleep apnea. During the night, they suddenly wake up. They can't breathe. During the night, they suddenly wake up because they can't breathe. Because while sleeping, the tongue is falling back. The tongue is falling onto the respiratory tract, glottis. The glottis is going to be closed. So that's going to cause a sleep apnea. Okay, obstructive sleep apnea, you can say. Cardiomyopathies can be seen. These patients are going to have the carpal tunnel syndrome. Okay, carpal tunnel syndrome. Sir, anatomy, let me see. What is carpal tunnel syndrome? Which nerve will be affected? Which nerve will be affected in the carpal tunnel syndrome? Can you tell me? Which nerve will be affected in the carpal tunnel syndrome? Can anyone tell me? Carpal tunnel syndrome mein median nerve, excellent. Arey dekho, here is the area of the carpal tunnel, right? This is the area of the carpal tunnel. There are bones. She looks too pretty. Try to catch her. Scaphe, all the bones, lunate, hamate, like, all this bones. She looks too pretty, try to catch her. The mnemonic is also there in anatomy. See, this carpal tunnel, what is what? It's tunnel is made up of bones, right? Tunnel is made up of bones. Now bone size is increasing, the thickness of the bones is increasing, the thickness of the bones is increasing, so the tunnel size decreases. When the thickness of the bones increase, the tunnel size decreases. Here the tunnel size decreases, so that median nerve will be compressed. The median nerve will be compressed, leading to carpal tunnel syndrome. The pain is going to be seen. So carpal tunnel syndrome. Okay, carpal tunnel syndrome. Okay. So this patient who is going to have acromegaly is going to have frontal bossing, prognathism, large fleshy tongue, cardiomyopathies can be seen, hyperglycemia. These patients are going to have hyperglycemia. Let me write here. These patients are going to be diabetic. One thing. So these patients are going to have diabetes mellitus because high levels of glucose. That's going to cause, like, on the long term, that's going to cause heart diseases also, coronary heart diseases. Diabetic patients can develop the coronary heart diseases. Okay. So growth hormone excess, high levels of glucose, so they can suffer with the diabetes mellitus, so that can lead to heart diseases. Because of the non-enzymatic glycosylation process, the coronary arteries can be blocked, that lead to the coronary heart diseases. Okay. So these are the minimum things which I want you to know. These are the minimum things which I want you to know. Most of the time, most of the cases, acromegaly cases, listen, most of the cases, these patients are also going to have galacturia, abnormal milk production. Okay, galacturia, abnormal milk production. Okay, it was seen because, let me tell you why. Imagine this is my hypothalamus. Some students will have it out. My hypothalamus, my anterior pituitary. This is my anterior pituitary. Most of the time, what happens is I have said twin hormones. Twin hormones. What are the twin hormones? Sir, this is a somatotrope, and this is a lactotrope. Lactotrope. They are like boyfriend girlfriend. Okay, boyfriend girlfriend. Now, what happened is, see, the somatotrope को एक tumor आ गया. Like there is a tumor to the somatotrope that is called as a somatotropinoma. Somatotropinoma. What it is going to produce? It would produces excessive growth hormone. Excessive growth hormone. That's going to cause acromegaly. Acromegaly. As they are both friends, most of the times those who have somatotropinomas also have prolactinomas, lactotrope tumor. They even have lactotrope tumors. This lactotrope tumors produces prolactin. This prolactin is going to cause the milk production. That is galacturia. Okay, so most of the time, acromegaly patients also have abnormal milk production, that is called as galacturia. Galacturia. Most of the time, somatotropinomas coexist with prolactinomas. Somatotropinomas exist with prolactinomas. Okay, done. So growth hormone abnormality is completed. Growth hormone abnormality is completed. Now treatment. How we can treat the acromegaly or gigantism? How to treat the acromegaly, sir? Growth hormone excess hai. So how to treat? Can you tell me? Can anyone tell me how to treat the acromegaly or gigantism? Simple. Use somatostatin analogs, because somatostatin, what it will do? Somatostatin decreases the growth hormone. So somatostatin analogs like octreotide or like lanreotide. Okay, octreotide or lanreotide, they are the somatostatin analogs used in the treatment of acromegaly or even gigantism. Somatostatin analogs like octreotide or lanreotide can be used. Drugs like growth hormone receptor antagonist, receptor blockers, growth hormone. Okay, let the growth hormone be there. Let the growth hormone be there. But you can block the receptors. Growth hormone ka receptors you can block. So there is a drug called as INICET question and NEET PG question. So pegvisomant. There is a drug called as a pegvisomant, which is the growth hormone receptor antagonist. You can use this also. Growth hormone receptor antagonist, pegvisomant can be used. And see, acromegaly patient may, why we are using bromocriptine and cabergoline? Can anyone tell me? Let me see any intelligent student. For the treatment of acromegaly, we are using dopamine. We are using dopamine. Bromocriptine, cabergoline. Okay. Why we are using these drugs? Why we are using these drugs? Dopamine agonists. Can anyone tell me? To stop the galacturia. Excellent, Joshi. To stop the galacturia, I have said you. Acromegaly patients also have galacturia. Acromegaly patients have galacturia, abnormal milk production. So galacturia को stop करने के लिए, you have to use dopamine. When you use dopamine, prolactin level decreases. Galacturia is going to be stopped. Okay. So Garima, Abra, yes, you are both true. Both are true. Joshi, you are true. Excellent. So these are the treatment options available. Pegvisomant you can use. Lanreotide, octreotide can be used. Somatostatin analogs. And for the treatment of prolactinomas, you can use bromocriptine or gabapentin. Now, last thing, I'm asking you generally. Generally, I'm asking you. See, whenever you see a dwarf fellow, whenever you came across a dwarf fellow, short fellow, okay, on the street, you will think, okay, he's suffering with dwarfism. What do you expect the growth hormone levels to be? What do you expect? What do you think? What do you think? He will be having more growth hormone levels or less growth hormone levels? What do you think? Yeah, Joshi. Joshi is saying, I will think that growth hormone levels are less. Any others? Joshi, Garima, Arthi, Abra, Baby, Sandra, Latif, Ovis, Hiba. Can you tell me what do you expect the growth hormone levels to be? You will simply think, a poor fellow, he is not having enough growth hormone. Okay, he's having low growth hormone, less growth hormone. That's basically what we think, right? Yes, but there is one special condition. Okay, one special condition which is called as a Laurent dwarfism. Okay, which is called as a Laurent dwarfism. So what is this Laurent dwarfism? So this is also called as Levy-Laurent dwarfism. See, this Levy-Laurent dwarfism में growth hormone available है, no doubt. Growth hormone is there, but where the problem, growth hormone receptors are not functioning. Okay, so growth hormone insensitivity, growth hormone hai, but it can't stimulate the receptors got mutated. Okay, so growth hormone receptor mutation. So then also same thing, receptors, if they are not functional, means growth hormone can't show the effects. Okay, growth hormone can't show the effects. So if you check the growth hormone levels, they are normal or even elevated. Growth hormone is more, but still the patient is dwarf because the receptors are not functioning. Okay, receptors are not functioning. Now I have already taught you, sir, growth hormone, it acts where when growth hormone is acting on the liver produces insulin-like growth factor 1, ILGF1 or somatomedian C. Now, Abhi, this receptor is not functional. This receptor is mutated. The growth hormone receptor is mutated. When the growth hormone receptor is mutated, now do you think insulin-like growth factor is going to be there? No, it levels goes down. Insulin-like growth factor levels goes down. So whenever insulin-like growth factor is not there, do you think negative feedback is going to be there? No negative feedback. As there is no negative feedback, that's why growth hormone levels are more. Growth hormone levels are even elevated. If you check the insulin-like growth factor levels, they are low. That's it. This is called as a Laurent dwarfism. Simple. Laurent dwarfism. Receptor mutation, growth hormone receptor mutation. Growth hormone levels can be normal or even elevated, but insulin-like growth factor levels are going to be less. That's it. Okay. Next thing, growth hormone. In which times it's going to be increased, in which times it's going to be decreased. In which conditions may growth hormone levels are going to be increased, and in which conditions may growth hormone levels are going to be decreased. Simple. How to remember this, sir? Okay, how to remember this? See, when I was a student, I used to think like, growth hormone means glucose. Growth hormone, it increases the glucose. Guys, think logically. Growth hormone, whenever there is growth hormone, it increases the blood glucose levels. Whenever there is growth hormone, it increases the blood glucose levels. So all the conditions wherever we require the glucose, in that conditions, growth hormone level increases. See. Okay. Again, I'm repeating. Whenever you require glucose, in that condition, growth hormone level increases. Let's go one by one. Dekho. Sir, fasting ke time mein, I'm asking you, fasting, you are doing fasting, sir. Okay, there is like, Navaratri fasting or Ramadan fasting, like, you are doing fasting, sir. During fasting ke time mein, you require glucose or not? Just tell me. During fasting, yes, you require the glucose. So yes, growth hormone levels increases. So during fasting, growth hormone level increases. True. How it increases? I have said you, during fasting, who is going to be produced? Ghrelin. During fasting, hunger releases ghrelin. What it will do? Ghrelin increases the growth hormone. Yes.
Okay, so two conditions complete. Fasting increases the growth hormone, ghrelin increases the growth hormone. So during exercise ke time, okay, during exercise, the trauma means healing ke time, you require the glucose or not? Yes, yes, during exercise ke time, and whenever there is trauma, you need to have the recovery, healing is required. In that time, glucose is required, so growth hormone level increases. So exercise ke time mein, yes, growth hormone level increases. Trauma ke time mein growth hormone level increases because in that time you require glucose. Okay, and you know glucagon, what it will do? Glucagon is also released during fasting. Glucagon also increases the blood glucose levels, and also same glucagon also increases the growth hormone. Glucagon also increases the growth hormone. Glucagon increases the growth hormone. Growth hormone increases the glucose. Okay, so now tell me, growth hormone is increased in which conditions? Fasting, sir. Ghrelin, exercise, trauma, glucagon increases growth hormone. Okay, and during sleep ke time mein, I hope you have already know. Like, see, when I was a small boy, what I used to do is every day after sleeping, I used to go and check my height, because at that time my parents were my parents and my grandparents, they told me that whenever you sleep, you increase in your height. Okay, actually that's true. Whenever we are sleeping, growth hormone is released. We grow in sleep. Okay, so during sleep, okay, especially in the stage NREM 3 and 4, this is the sleep, non-REM sleep. Okay, during NREM 3 and 4, growth hormone is released. That increases the height, that increases the growth of our body. Our body grows during sleep. True, our body grows during sleep. Now, see, what is arginine? Can anyone tell me? Students, please tell me. Can you tell me what is arginine? Simple, sir. Arginine क्या है? Amino acid है. Amino acid. When you will get the amino acid after eating food. Okay. So let me put it this way. Easy understanding. I ate biryani food. Okay. I ate chicken pieces. Okay. So the chicken is digested and what is released? Amino acids are released. These amino acids are stimulating what? Amino acids are stimulating the release of growth hormone. What growth hormone will do? By utilizing these amino acids, arginine and other amino acids, what is synthesized? Proteins. Growth hormone is helping in protein synthesis. Growth hormone, V-shaped body. Growth hormone, that big muscles. Protein synthesis. Okay. So growth hormone levels are increased in fasting, exercise, trauma, ghrelin, glucagon. Growth hormone levels are increased because of amino acid called as arginine. Growth hormone levels are increased during sleep. Okay, and what else? Growth hormone levels are also increased by these sex hormones. I used to remember simple like this. Sir, what are these? Testosterone, estrogen. What are they? They are sex hormones. Sex ke liye, what do you require? Glucose. For that activity, you require the glucose. Okay. So how you can increase the glucose? By growth hormone. Simple. So even this testosterone and estrogen, they are sex hormones. They have to be required. Like, you know, these testosterone and estrogens, they increases the growth hormone increases the glucose, and glucose is required for that activity of sex. Simple. I used to remember like that. Okay, so now you might feel like, sir, all these things are needed. Does this actually needed? Let me show you one question which was asked in the FMG exam. Look at this. Endocrine may say, here I have started the endocrine physiology. Just wait. Here I have started the endocrine physiology. The first question that I kept here, look, this is a question which was asked, the exact question which was asked in the exam. This is a question, FMG exam. Identify the hormone from the picture. Look, see, there is this one hormone which is fluctuating. Okay, there is this one hormone, say, normal levels, daytime. After taking the meal, its level increasing. I have said you, which hormone increases after meal, after eating food? Arginine is released, arginine stimulates. You know what is that hormone? After exercise or trauma, which hormone level increases? Sleep. See, during sleep, especially during deep sleep, which hormone level increases? Can you tell me what is this hormone? Identify the hormone from the picture. Which hormone? So growth hormone. So this is how the questions are going to be asked in the exam. Okay, this is how the questions are going to be asked. Okay, let me give you this question also. Let me copy this. See, you might think, sir, endocrine is taking a lot of time. Let it take, no issue. Let it take. 3 questions will come from out of 8, 9 questions. Lot of questions will come from endocrine. So let it take time. We want the questions. That's it. We have to complete all the questions. That's it. Okay. So come on. Close your eyes and try to recollect. Growth hormone levels are increased by fasting, ghrelin, exercise, trauma, glucagon, arginine, sleep. 6 hormones increases the growth hormone. And who decreases the growth hormone? Who decreases the growth hormone? You already know it, sir. Growth hormone levels are decreased by somatostatin, decreases the growth hormone. You know it. Sir, who gives the negative feedback to the growth hormone? Insulin-like growth factor, decreases the growth hormone. Okay. And cortisol एक क्या है? Sir, cortisol is a stress hormone. During stress, we don't want the growth, sir. During stressful conditions, we don't want the growth. Cortisol is a catabolic hormone. Catabolic. Our growth hormone is anabolic hormone. Both are opposite. So cortisol inhibits the growth hormone. Cortisol inhibits the growth hormone. Okay. So these are enough. So the other things are not yet, will unnecessarily confuse you. So growth hormone decreased by somatostatin, insulin-like growth factor, and cortisol. Done. Done. Last but not the final, but not least, one integration with the pharmacology. So somatostatin analog called as octreotide, where we have discussed somatostatin analog, octreotide, lanreotide, pegvisomant. They are used in the treatment of acromegaly. Yes, so pegvisomant, this octreotide, somatostatin analog, it is used in the treatment of acromegaly, no doubt. But the same octreotide is also used in other conditions where esophageal varices. Okay, so esophageal varices, you know, right? Esophageal varices, dilated veins in the esophagus. Okay, if the esophageal varices, you can use the drugs like octreotide, no doubt. Okay, for esophageal varices, you can use octreotide, no doubt. You can use other drugs also. Okay, but octreotide can be used. Next, there is a condition called as secretory diarrhea. Okay, secretory diarrhea. Secretory diarrhea means, do you know what is secretory diarrhea? Secretory diarrhea means in certain conditions, these are the conditions. In certain conditions, like tumors, which tumors? Gastrinoma, insulinoma, VIPoma, carcinoid syndrome. There is excessive production of substances like serotonin, 5-HT3, serotonin, carcinoid syndrome, serotonin. Gastrinoma excessively produces gastrin, a hormone called as gastrin. Insulinoma condition में excessive amount of insulin. VIPoma, excessive production of vasoactive intestinal peptide. See, in all these conditions, one thing is common, sir. All these hormones are more. Insulin more, gastrin more, 5-HT3, serotonin more. Whenever I'm having carcinoid syndrome, gastrinoma, insulinoma, VIPoma, because of this excessive hormones, the patient is going to have secretory diarrhea. How to stop this secretory diarrhea? Use a drug called as octreotide. If you use octreotide means what? It's somatostatin. The somatostatin inhibits everything. Somatostatin lifelong, remember. Okay, याद रखो. Same. Somatostatin not only inhibits growth hormone, but also inhibits serotonin, inhibits gastrin, inhibits insulin, inhibits VIP. So to stop this diarrhea, to stop this secretory diarrhea, what is the drug that we can use? Octreotide. Done, sir. Why I kept it here? Because it's a question asked. Like, you know, it's physiology and pharmacology integration. Somatostatin analog octreotide is used in the treatment of acromegaly, esophageal varices, and secretory diarrhea. Okay, secretory diarrhea that is seen in syndromes like gastrinoma, insulinoma, and VIP. Is that okay? So with this growth hormone completed. Guys, is that okay? Whatever I'm trying to integrate, does it make sense? Do you like it? Or should I change the way I teach, or do you want me to integrate more, or do you want me to, sir, like all these integrations we don't want, simply you keep physiology as physiology and you want me to teach? It's like, how do you want? Are you understanding what I'm teaching? It's perfect, right? It's perfect. Integrations are good, right? Yes. because certain students will complain, sir is like, integrating a lot of things we can't understand, like that's why. Okay, I don't want to like have that thing. Okay, have a sip of water. I'm giving you a 5 minutes break. Okay, I will give you, this is just a five minutes break, not even 5 minutes. You just simply sit. Okay. Okay, I will decrease the speed. You just sit, take deep breath. Okay, take deep breaths. Sit 2 minutes, close your eyes and relax. Okay, 2-3 minutes, just relax. Okay, we'll start in the next 2-3 minutes. Just a water break. I will give you the lunch break later. Okay, I'm also stopping my video and I'm muting myself. We'll start in 2-3 minutes. Yeah, I'm from Andhra. My mother tongue is Telugu. Yes, I'm from Andhra. Right now I'm in Andhra. I came to my home. Okay, we'll start.
Okay. Okay, guys, let's continue. Now, before continuing, let's try to have some like questions. Okay, the basic questions which I want you to know here itself. I'll be using like some small questions in the middle. And I hope everything's clear. Okay. Now, before going to start the next hormone, let me show you something which was also tested many times in FMG exam. This is a pure FMG question. This is not even NEET PG. Look here. See, they will show you this. What is this type of hormone action? This is one cell. Okay, this is one cell. Okay. Now the cell is producing certain chemicals or hormones, you can say. These hormones are coming and acting on the adjacent cells. These hormones are coming and acting on the adjacent cells. So what is this type of action called as? One cell is producing, okay, certain hormones. These hormones are coming and acting on the adjacent cell. This type of action is called as what? This type of action is called as what? Like I will give you certain options like autocrine, endocrine, merocrine, paracrine. What is this type of action? See, site or just a site, adjacent site. So this is called as a paracrine action. Okay, this is called as what? Paracrine action. Okay, so this is a question. Image shown below depicts which of the following type of cells? Paracrine. Okay, then what is autocrine and endocrine? Merocrine, there is nothing else merocrine action. What is autocrine, autocrine and endocrine? Look here, let me show you in this. Again, the repetition. See, paracrine means, see, it's one cell, it is producing certain hormones, and these are acting on the adjacent cell. Then it is called as what? Paracrine signaling. Okay. Then what is autocrine? Auto means self. Auto means self. Okay. So this cell is producing certain chemicals or hormones. These hormones are acting on the same cells. It's a self-stimulatory, self-stimulatory, auto-stimulatory. It is stimulating its own self. Okay. Sounds funny, but it's true. It's stimulating its own cells. Sometimes cells even do that. Okay. They will stimulate their own receptors. So this is called as what? Autocrine signaling. Okay, autocrine signaling. You know about the paracrine? Paracrine means the hormones are going to stimulate the adjacent cells. What is endocrine? Endocrine means, see, one cell is going to release these hormones, and these hormones are coming into the blood. Okay, now the blood vessels are involved. Through the blood, they are going to the distant sites. Okay, these hormones, they will go to the distant sites and they are acting on the cells, the distant cells. Okay, so this is called as endocrine. So endocrine means blood vessels are involved. Endocrine means blood vessels are involved. Side signaling is paracrine. Self-stimulation is autocrine. Okay, so this is the one thing which I want you to know. This is the basic thing. So I'm taking these 2 slides. Let me copy this thing. And let me paste in our endocrine physiology. The starting itself I am keeping. Okay, this is a basic thing. FMG question done. Okay, FMG question done. So the next hormone that we are going to discuss is thyroid hormone. The next hormone, let's take the heading. Thyroid hormone. Okay, thyroid hormone. So can you tell me what are the thyroid hormones? T3 and T4. So how these thyroid hormones are synthesized? So thyroid hormone biosynthesis. The topic that I'm going to talk here is the thyroid hormone biosynthesis, how these T3 and T4 are produced. Okay. Now, I will explain you this in the form of a story. Okay, I will explain you the whole thyroid hormone biosynthesis in the form of a story. Because I believe that it will be easy if you remember like that. Now imagine if today your mom is going to make a special dish for you. What she's going to make? Chicken, that's the usual thing. Chicken, mutton are usual things. She's going to make fish today. Okay, fish fry. So fish is what? Seafood.
Okay, seafoods are rich in what? Iodides. Okay, so today you ate fish. So what you're going to get? You're going to get the iodides. So after digestion and absorption, what happened to the iodide levels in your blood? The iodide levels in your blood are going to go up. Okay, the iodide levels are going to go up, sir. Now this iodide is our hero. Okay, he is our hero, sir. Iodide is our hero. Iodide, I minus. Okay, I minus. Basically, our heroes, they're with this negative charge. Our heroes in our movies, heroes are shown like negative people. Okay, negative people. They are having all the bad habits, but okay, our hero. Now, here I am showing you the follicular cell. Where is this follicular cell present? Sir, follicular cells are present in the thyroid gland. Okay, thyroid gland. For easy understanding purpose, guys, look here. देखो, ये आपका thyroid gland है. Okay, thyroid gland है. Here I am showing the blood vessel. A blood vessel है. This is the blood vessel. Thyroid gland में, guys, look. These are the follicular cells. See, one cell, one follicular cell, second follicular cell, third follicular cell, fourth, fifth, sixth, and seventh. So these cells are the follicular cells. And in the center, what do we have? In the center, this area, the central area is called as colloid. The central area is called as what? Colloid. Okay, follicles. There are millions of follicles are there. Millions of follicles are there. In the center of the follicles, there is a material called as colloid. The space is called as colloid. In this colloid, mein, T3 and T4 are going to be synthesized. T3, T4 synthesis occurs in the colloid. Okay. Now I am showing you. See, these are the follicular cells. Here, center is the colloid. This blue color material is the colloid. The same thing I am showing you here. This is one follicular cell. One follicular cell. Here in the center, there is colloid. Okay. Now our hero is ready. Our I minus hero is ready. Okay, done. Now, if there is hero, there should be definitely heroine. Okay, who is our heroine, sir? Who is our heroine in this story? See, follicular cells, they produce a material called as, see, follicular cells, the rough endoplasmic reticulum produces RER, rough endoplasmic reticulum produces proteins. What is that protein? Here, it is producing a protein called as thyroglobulin. The rough endoplasmic reticulum of these follicular cells produce thyroglobulin. See, this thyroglobulin, it is packed and moved. See, this is the thyroglobulin protein. This thyroglobulin protein, now it is moving where? It is moving into the colloid. Now this is our heroine. This is our heroine. Okay, thyroglobulin. So if I'm talking about the heroine, I'm very much excited to talk about her shape. Okay, I am very much excited to show you how she looks like. Okay, so let me show you our heroine. Sir, this is our thyroglobulin, our heroine, thyroglobulin. Okay, thyroglobulin is a protein. Now, on this thyroglobulin, look, there are many tyrosins. Thyroglobulin, it is made up of amino acids. Of course, it is made up of amino acids. It's a protein, right? It's made up of amino acids. But one amino acid is more in quantity. So this red color thing, it is coming again and again. So this amino acid is called as tyrosin. Tyrosin residues are more. Our heroine may tyrosin residues are more. This is tyrosin. Okay, this is our heroine. Thyroglobulin, which is having a lot of tyrosin amino acid residues, tyrosin amino acids. Done. So hero is ready. Heroine is also ready. Okay. Now they have to meet. For them to do anything, okay, let them decide what they want to do. But first of all, they have to meet. Okay. Now, see, first, this iodide, I minus, will be taken into the thyroid gland. See, this iodide is coming, this green color one. Iodide is coming into the cell along with sodium with the help of this transporter. This is called as what? Sodium iodide symporter. We call it as like this, sodium NaI, sodium iodide symporter. With the help of sodium iodide symporter, iodides I minus came into our cell. Okay, done. This is called as uptake. Now, our hero, he's a little bit not happy. He's not happy. Now, where he have to go? He have to go into the colloid because heroine is not here. He's not happy. So now this iodide, now it is going where? It is pumped into colloid. It came into the colloid. It became I minus. Sorry, it became I minus. It came into the colloid. with the help of a transporter called as a pendrin. Okay, our iodide ion I minus, our iodide ion I minus came into the colloid with the help of pendrin. Okay, uptake by sodium iodide importer and moving into the colloid with the help of a transporter called as pendrin. Okay, now heroine is here. See, this is our heroine. Heroine is here. Our hero I minus, he is also ready. But do you know suddenly what happened? This heroine, okay, she is very good girl. Okay, now she rejected our hero. She is not liking our hero. Okay, our hero is not being liked. Do you know why? Because our hero is not of a toxic person. He's having a lot of negativity. He's having negativity. Do you think girls like negative people, negative persons, like toxic males? Yes, of course, in reality, they do prefer bad persons. They will always choose the bad persons. Okay, but here, speaking ideally, our heroine doesn't like our iodide because I minus is there, negativity is there. So we have to remove that negativity. Our hero have to take out that negativity. Okay, so who is going to help? There is a friend, very good friend. Okay, his name is called as thyroid peroxidase. Okay, his name is called what? The enzyme, this enzyme is called as a thyroid peroxidase, which is present in the colloid. It's present in the colloid. What this thyroid peroxidase is going to do? The thyroid peroxidase he will be coming to the hero and saying, "Arey, you are so much toxic person. Like you are going to hurt that female. So remove that toxicity. Remove that all the toxic thoughts, toxic behavior." So now our hero is going to change. The I minus is converted into I2, iodine. Iodide is converted into iodine. Okay, iodine. So this process is called as oxidation. That removing the negative charge is called as oxidation. So oxidation is done by which enzyme? Thyroid peroxidase. Thyroid peroxidase. Okay, done. Now after he became a very obedient, very gentle, very polite, innocent boy. Okay, now he's feeling shy to go and meet with the girl. He can't go and have a conversation with that girl, our heroine. Okay, again, who is going to help? Now the same friend, thyroid peroxidase. This is the thyroid peroxidase. This molecule is there. No, this one. See, the same thyroid peroxidase, TPO. It's called as a TPO, thyroid peroxidase. He's going to take our guy iodide. Sorry, not iodide, iodine. Now this iodine is coming, and it is coming and meeting with the thyroglobulin. Our heroine, both are meeting now for the first time. Both are meeting. Okay, with the help of thyroid peroxidase. Now, for better understanding, look, for better understanding, now let me show you the same thing in other slide. Next slide. Let me take the other slide. Okay, look. This is our heroine, thyroglobulin, our heroine. Okay, now our hero. Let me take our hero in the green color, same green color. Now our hero, that is I2, is coming and binding with what? The tyrosines. Who is helping in this process? Thyroid peroxidase, our friend. TPO, thyroid peroxidase, is taking this iodine. The iodine is getting incorporated. Onto tyrosine amino acids. Okay, one iodine here. Look, here 2 iodines are coming and sitting. Here 2 iodines are coming and sitting. Here also, for example, 2 iodines are coming and binding. 2 iodines are coming and binding here. So iodine is being incorporated like this. So this process is called as what? Organification of iodine. The second reaction with the TPO is called as organification. Organification of iodine means iodine is coming and getting binded with the thyroglobulin. Both are meeting each other. The hero and heroine both are meeting each other. Okay. Now, because of this organification process, what we have? Okay, because of this organification process, what do we have? I'm getting messages. You guys are messaging me. No, you are not messaging. Okay, these are some other messages. Okay, no issue. So, because of this organification process, what we have? Array, look, this is one tyrosine with the 2 iodine. So this molecule is called as what? DIT, diiodotyrosine. So diiodotyrosine, this molecule with the 2 iodines Okay, this is called as a DIT. Here there is only one iodine. This is called as monoiodotyrosine. Again, this is diiodotyrosine. This is diiodotyrosine. Here also diiodotyrosine. Maybe if there is only one iodine, that is called as monoiodotyrosine. So now tell me, because of the organification process, we are left with, because of the organification process, we have diiodotyrosines and monoiodotyrosines. So our friend thyroid peroxidase bought iodine, and iodine, our hero is meeting with our heroine, that is thyroglobulin. Okay, now hero and hero both are met. Okay, they liked each other. Now what they have to do? I'm asking you now what they have to do. They both liked each other. Now they are into a relationship. Now what they have to do? They have to do something, but they don't know how to do it. They have to do something. They don't know how to do it. Again, who is going to help here? Again, the same friend. The same friend is saying, "Arey, you guys don't know what to do." Okay, let me tell you what to do. The same thyroid peroxidase, TPO, they will bring these molecules, one MIT molecule and one DIT molecules, they are going to be fused. You guys have to fuse. So now the same thyroid peroxidase, they will fuse the DIT molecules and MIT molecules. When one DIT is fusing with one MIT, it will form T3. Okay, if one DIT is fusing with the other DIT, it forms T4. See, di here. T4 means 1, 2, 3, 4. Okay, T4. So this is how T3 and T4 are produced. This is how T3 and T4 are produced. So the last reaction where our TPO is fusing, this last reaction, the fusion of DIT MIT, the fusion of DIT MITs, this reaction is called as, the last reaction is called as coupling. Okay, this last reaction is called as coupling. They are fusing with each other. Okay, so this is how T3, T4 are produced. Is that clear, guys? Okay, you can say these are the babies. T3 and T4 are the resultant products. These are the babies. So this is the story. Okay, this is the love story of our iodide I- and thyroglobulin. Coupling में MIT and DIT molecules, they will fuse. TPO will fuse MIT and DIT molecules. That's it. Organification means we are taking the iodine. Okay, I2 is going to come and fuse with iodine, is incorporated onto thyroglobulin. Iodine is incorporated onto thyroglobulin. Okay, that is called as organification. Mahima, look. Right. See, I have taught you that this is our thyroglobulin. Okay, thyroglobulin mein which amino acid is more? Tyrosine is more. You know it. Tyrosine is more. Now the iodine have to come and bind with. The iodine have to come and bind with this, the tyrosine. This process is called as organification of iodine. So this is a tyrosine, right? This is a tyrosine. Tyrosine is binding with iodine. Okay, iodine. So this is called as organification of iodine. After organification, fusion. After organification, fusion. So how many reactions are there total? There are 3 reactions, sir. First, what are the 3 reactions? First, you need to remove that negative charge. That is called as oxidation. Okay. Now after that, organification. Okay, the friend have to bring both the people together. Okay, the organification. After organification, they have to fuse, coupling. Okay, so oxidation, organification, and coupling reactions. Oxidation, organification, and coupling reaction. There is a small mistake here, typing mistake. Can you tell me what is that? Fusion of one MIT and DIT will form T3. DIT plus DIT fusion will form T4. This is called as a coupling reaction. Last step, coupling reaction. Is that clear, guys? Oxidation, organification, coupling reaction. All are done with the same friend, TPO. Okay, TPO, thyroid peroxidase. It does oxidation, organification, coupling reaction for the production of T3 and T4 in the colloid. Is that clear? If that is clear, I will show you the step by step whatever I have taught you so far in the next 5 minutes. Right, fill up the thing. Fill up this. Whatever I have taught you so far, the same thing only. Okay, fill this up. Don't write extra details. I will just highlight whatever is required. See, what is first thing? Our hero have to enter into the follicular cell with the help of sodium iodide symporter. Okay, right. Uptake of iodide. This is also called as iodine trapping with the help of sodium iodide symporter. Okay, sodium iodide symporter. There are certain chemicals or drugs, you can say, they blocks the sodium iodide symporter. There are drugs like perchlorate and thiocyanate. Okay, perchlorate and thiocyanate, actually they are poisons, to be very frank. The perchlorates and thiocyanates, they will block the sodium iodide symporters. They will block the sodium iodide symporter so that T3 T4 production goes down. Okay, right. First step 1, iodide, our hero have to enter into the follicular cell. Now after that, our heroine should be produced. So second thing is synthesis and secretion of thyroglobulin. Our heroine, thyroglobulin, from the rough endoplasmic reticulum. Synthesis and secretion of thyroglobulin. Synthesis and secretion of thyroglobulin. Okay, done. Now after this, oxidation of iodide. What is oxidation of iodide? Don't write all this stuff, not needed. Oxidation of iodide means I minus is converted into I2. That's it, enough. Oxidation of iodide, I minus is converted into I2. What is organification? Organification means our iodine, small spelling mistake, iodine, iodine. Iodine is incorporated into tyrosine residues. Iodine is going and sitting on. Iodine is going and sitting on tyrosine residues. Iodine incorporate into tyrosine residues of thyroglobulin. Organification also completed. Coupling reaction. What is coupling reaction? Coupling. This couples. The MIT is going to fuse with the DIT, or a DIT can fuse with DIT. It will produce T3 and T4. It will produce T3 and T4. Done. So oxidation, organification, coupling reaction. Oxidation, organification, and coupling. All are done by one single fellow. He is TPO, thyroid peroxidase. Done. In the NEET PG exam 2019, NEET PG, I exactly don't know whether it's 2019 or 2020, but anyway, this question was asked. Sodium iodide symporter. Sodium iodide symporter is present in, sodium iodide symporter. It is present in the thyroid gland. True. It's present in the follicular cells, also called as thyrocytes. So true. Okay. They are present on the thyrocytes, also called as follicular cells. True. But you have to by heart it, sir. There is no other way. You have to by heart it. This sodium iodide symporter is also present in salivary glands, okay, mammary glands, placenta, gastric mucosa, in eye and choroid plexus. In all these places, the sodium iodide symporter, they have asked this question only just because they have asked this question. I kept it here. Otherwise, I wouldn't have. It's a previous year NEET PG question. Previous year PYQs. Like a previous year NEET PG question. Sodium iodide symporter is present in thyrocytes, mammary glands, salivary glands, choroid plexus. You can say placenta, gastric mucosa, all these things. Okay. So now I'm just coming back. I'm just showing my face. If you have any doubts, please ask me here. If you have any doubt, please ask me. So far, is that clear? Now have you understood how thyroid hormones are produced? Thyroid hormones, we are at the end. We are completing the thyroid hormones. Is that clear? Okay. Ajmal, Satish, Jyoti, Mahima, yes, Venkateswaran. Now, in FMG exams, they will ask you, this is a little integrated. This is little integrated with the pharmacology. Imagine I'm the person. I'm the person who is suffering with hyperthyroidism. I'm having hyperthyroidism. So most of the males will have hyperthyroidism. Most of the females will be having hypothyroidism. So imagine I'm the one. I'm the one having hyperthyroidism. Hyper. Now you tell me, you have to increase the synthesis of T3, T4, or you have to decrease the synthesis of T3, T4 in my body. What you will do? You have to decrease. You have to decrease, right? Yes, Ajmal. Yes, Garima. Yes, you are true. You have to. Yes, Vishnu Jyoti. Yeah, you have to decrease the T3, T4. So how can we do that? How can we do that? See, you already know. See, oxidation, organification, coupling reaction. All these are done by thyroid peroxidase. You already know it. If you can block this thyroid peroxidase, if you block the thyroid peroxidase, automatically T3, T4 production goes down. So how we can block them? How we can block that? See, there are drugs like propyl thiouracil, methimazole, and carbimazole. So this PTU, propyl thiouracil, carbimazole, and methimazole, they are anti-thyroid drugs. Okay, they are anti-thyroid drugs. They decrease the T3, T4. Propyl thiouracil, methimazole, carbimazole, they inhibit TPO, thyroid peroxidase. Okay, in surgery, when you are doing your surgery, you will study this. There is a syndrome called as a Pendred syndrome. What is Pendred syndrome? In Pendred syndrome, this pendrin is a mutated. This one, see, dekho, this pendrin, I will come back. This pendrin transporter, hai na? This is mutated. Okay, so that's called as a Pendred syndrome. Just know this integrations. What is Pendred syndrome? Pendred syndrome mein pendrin transporter is mutated. Pendrin. So because of that, T3, T4 production is decreased, leading to congenital by birth hypothyroidism. Congenital hypothyroidism by birth. T3, T4 production goes down. And also, because of this transporter mutation, pendrin transporter is also present in the ears, cochlea. It's also present in the cochlea. It's also present in the cochlea. Because of that, these patients are also going to have deafness. Okay, these patients are also going to have sensory neural hearing loss. Sensory neural hearing loss is also going to be seen. Okay, so congenital hypothyroidism as well as sensory neural hearing loss. This is called as a Pendred syndrome. Pendred syndrome. And FMG may, recent FMG may, they have asked, so which of the following, these three drugs, is the drug of choice for hyperthyroidism during pregnancy? Which drug can be used? This one, propyl thiouracil. It's the drug of choice for first trimester pregnancy. Okay, first trimester pregnancy may, if the female is having hyperthyroidism, what is the drug that is given? Propyl thiouracil is the drug of choice for first trimester pregnancy. It is a drug of choice for first trimester during pregnancy. Chalo, done, completed. Next, what else you should know regarding the thyroid hormones? Some important points regarding the thyroid hormones. Okay, so T3, T4 इन दोनों में differences क्या है? Okay, first thing, who is active form? T3 is active form, no doubt. T4 is inactive or less active form. Okay, but who is produced in more quantity? More quantity is a T4. Okay, more quantity, say more in blood. See, who is more in blood? Who is more produced? T4 is more produced. T3 is less. Okay, so T4 is inactive. T4 need to be converted into T3. T4 will be converted to T3. I will tell you how. T4 a less active form hai. T3 is more active form. T4 is more in blood. T3 is less in blood. Who gives the negative feedback? MCQ. Who, once you have sufficient amount of thyroid hormones, who gives the negative feedback? T4 gives the negative feedback. T4 gives the negative feedback, not T3. T4 is going to give the negative feedback, not the T3. Okay, so T3 doesn't give any negative feedback because T4 is the real store. The real store of thyroid hormone is the T4. Okay, so T4 gives the negative feedback, but not the T3. Okay, so T4 is going to stay in your blood for a long time, almost a week. T3 only one day. Okay, T3 is only 1 day. T4 almost stays in your body for a week. Okay, done. This is also difference. Okay, T4 is slow action, inactive. T3 is fast action, immediately it will act. Fast action, highly active. T4 is less active, less in blood, less action, slow action. Now, in the recent FMG exams, not one time, many times this question has been asked regarding the thyroid hormones. Are T4 main, which is the main thyroid hormone? This is the main thyroid hormone, more in quantity, but of course it is less active. But T4 and T3 in the blood, they are not in free form. These days, no boy is free, no girl is free, everyone is occupied. In the same way, even in the blood, T4 is binding with a plasma protein. Which plasma protein? T4 mainly binds with globulins, thyroid binding globulins. That's a TBG, thyroid binding globulins, TBGs, thyroid binding globulins, T4 mainly. T3 binds with albumin. Okay, that's the difference. T4 with thyroid binding globulins, T3 with albumin. T3 they haven't asked. T4 they will ask you. T4 are just they will ask you thyroid hormone mainly binds with. The answer should be this. Thyroid hormone mainly binds with means they are talking about T4 only. That because that's the main thyroid hormone. T4 mainly binds with thyroid binding globulins. Okay. Now, some students will have it out. That is, so you said T4 is main in the quantity, but T3 is active. How this T4 is going to be converted into T3? How it's going to be converted? Let me tell you. See, wherever it is required, whenever and wherever it is required in the tissues, not everywhere, in the required tissues, the T4 will be converted into T3. Okay, the T4 will be converted into T3. This process is called as peripheral conversion. Okay, so what is this peripheral conversion? Peripheral conversion means peripherally in the tissue, the T4 will be converted into T3. Okay, with the help of an enzyme called as 5' deiodinase. 5' deiodinase is the enzyme which converts T4 into T3. Okay, this is active form. Now, question is, who inactivates this enzyme? 5' deiodinase is inhibited by, again, see peripheral, P for P. Peripheral conversion is inhibited by propyl thiouracil, same drug. Propyl thiouracil. And again, one more P. Propranolol. Okay, so propranolol and propyl thiouracil, they inhibits peripheral conversion. They inhibits 5' deiodinase. Done, that's it, completed. These are peripheral conversion inhibitors, PTU and propyl thiouracil. So the slide also completed. Main question which was asked many times in the exam is thyroid binding globulins. Okay, T4 mainly binds with thyroid binding globulins. Negative feedback is given by negative feedback is given by T4. Now, next, what do you need to know about the thyroid hormones? Next, what else you need to know about the thyroid hormones? Is there functions? Functions of thyroid hormones, you know, growth hormone, anabolic hormone, growth hormone, protein synthesis, growth hormone, lipolysis, growth hormone, bone growth. Now, what are the functions of the thyroid hormone? Don't write anything. Let me first explain you. First, take a white page, blank page. Okay, before that, let me ask you, let me check my voice and my video. Is everything clear or not? Let me check. Yes, everything seems clear. It's all clear, right? Now, last FMG exam, not this FMG exam, last FMG exam, which happened in the last June. This is the question which was asked. First, let me show you. Okay, this is your tissue. For example, I'm showing you one cell here, one cell. In your cell, what is there in the center? What is this? The center may this round thing. What is this? This is those are what? No, this is nucleus. In the nucleus, what is there? DNA is there. Genes and all the stuff. DNA. Now here is T4. Wherever it is required, T4 will be converted into T3. Now we have T3 here. Okay, done. Now on the cells, on the cell surface, on each and every cell surface, there is a protein present. There is a protein present. Okay, let me show you. This is the protein. Now what this protein is going to do is, this protein is going to always bring 3 sodium into the cell. Sorry, not 3 sodium into the cell. 3 sodium out of the cell, brings 2 potassium into the cell. It's always doing, it's present on each and every cell. It's there on each and every cell. It's a universal protein. We say it's a universal transporter. It transports 3 sodium out, 2 potassium in. So what is the name of this? It's a sodium potassium pump. Or sodium potassium ATPase. Because it uses ATP for this process, energy for this process. It uses the energy for this process, sodium potassium ATPase. Okay. Now, when this T3 acting on the cell, what happens? First thing, the T4, it directly crosses the cell membrane. First event number 1. Okay, so T4 can directly cross the cell membrane. So there is no receptor on the cell surface. Okay, T3 can directly cross the cell membrane, and it even crosses the nuclear membrane. So T3 is directly entering into the nucleus. In the nucleus, it binds with its receptor. In the nucleus, what it is doing? It's binding with the receptor. Okay, so take a big star mark, super important MCQ. Thyroid hormones have which receptor? Intranuclear receptor. Okay, thyroid hormones have intranuclear receptor. Okay, so thyroid hormones, once it goes and binds with the receptor in the nucleus, now what happens? So certain transcription happens, the genes transcription followed by translation. At the end of the day, what I want you to know is, look here, what is happening? There you go, sir, what is happening? What is happening? The number of sodium potassium ATPase, are they increasing or decreasing? So the number of sodium potassium ATPases, their number, okay, is increasing. More number of sodium potassium ATPases, so more number of ATP is broken down unnecessarily. It's true. Now more amount of ATP is getting broken down. More calories are being utilized by the cell. More calories are being utilized by the cell. More number of sodium potassium, more number of ATP breakdown. So more number of ATP breakdown means more calories are being utilized by the body. So that causes or that increases the basal metabolic rate. Okay, so this is why we say thyroid hormones increases the BMR. How it increases the basal metabolic rate? First of all, let me tell you what is basal metabolic rate. Basal metabolic rate means number of calories required by a person. For example, I am 75 kilos. I am 75 kilos. How many calories are required by adult male to keep this body alive for the next 24 hours? For the next 24 hours, if you want the body to keep alive, okay, let me show you. Like, look at me. See, for example, me, this 75 kilos body, if you want to keep this body alive for the next 24 hours, all biochemical reactions I should have to do. I have to maintain my body temperature. I have to keep this body alive for the next 24 hours. How much energy is required? How many calories are required? Somewhere around adult male 3000 to 3500 calories. Females may 2500 to 2700 calories. So the number of calories is called as a basal metabolic rate. To maintain the homeostasis in the body, how many calories are required? Okay, that's called as a basal metabolic rate, minimum calories. Okay, thyroid hormones, what they are doing? Thyroid hormones increases the calorie expenditure, increases the ATP breakdown. So more calories will be utilized by the body. So more basal metabolic rate. Yes, thyroid hormones increases the basal metabolic rate. How? By increasing the number of sodium potassium ATPases. Okay, now this is the first thing. Last point, look here. Throughout the body, what these thyroid hormones are doing? See, thyroid hormones increases basal metabolic rate by increasing the number of sodium potassium ATPases. More calories are being utilized, more ATP is getting broken down. when more ATP is getting broken down, even energy is released, and some energy is released in the form of heat. Okay, so thyroid hormone, sir, thermo. When your BMR increases, when your basal metabolic rate increases, when ATP broke down is happening, some energy is released in the form of heat. So thyroid hormones are thermogenic hormones. It's a thermogenic hormone. It increases your body temperature. Okay, it increases your basal body temperature. Okay, so yes, they increase the basal metabolic rate by increasing the number of sodium potassium ATPases. In certain places, the BMR is not increased. Where? In testis BMR is not increased. If your BMR is increased, what happens? Your sperms will become fry because of that increase in the BMR, increase the temperature. Your sperms, okay, your testis will become, I don't want to go into details, will become fried egg. Okay, so your testis and uterus, these are the reproductive organs. We don't want the heat in this area. So in this testis, uterus, and in lymph nodes also, because lymph nodes is the place where your T lymphocytes, B lymphocytes are proliferating and maturing. So there also we don't want the temperature, otherwise their production will be affected. So testis, high division, high cell division is happening. Uterus, high cell division. Lymph nodes also, the lymphocytes are getting proliferated, new lymphocytes. Spleen also, lymphoid organ, more number of lymphocytes. This kind of thing. Okay, so testis uterus lymph nodes, spleen, and anterior pituitary. In these areas, BMR is not increased. MCQ, NEET PG. Thyroid hormones increases the basal metabolic rate except these 5 areas: testis, uterus, lymph node, spleen, and anterior pituitary. Done. What else you should know? Thyroid hormones, yes, of course, they are thermogenic hormones. I have written here. Add one more point. Thyroid hormones are one of the major catabolic hormones. One of the major catabolic means breakdown. Catabolic hormones. Catabolic hormones mean what? Breakdown. Say protein breakdown, lipid breakdown. Say adipose tissue may lipid breakdown, muscle may protein breakdown. Not good proteins, older proteins. Okay, so older proteins which are worn out, they need to be broken down. So lipolysis and proteolysis, these two are completed. See, yes, of course, they are catabolic hormones, but even during childhood, they even have little anabolic functions, growth functions. What are they? See, on the bone, what they will do? They help in the growth and skeletal development. Thyroid hormones also needed, not only the growth hormone, but also the thyroid hormones are required for the growth and skeletal development. Skeleton develop hone ke liye you require the thyroid hormones. Yes, true. And for the mental cognition, for the development of the central nervous system, for the development of the brain, you require the thyroid hormones. Okay, even thyroid hormone, not only the growth hormone. I have in the morning I have taught you growth hormone increase the blood glucose levels. True. Even thyroid hormone increase the blood glucose levels. Go, it increases. So it's a glucogenic hormone. True. It's a diabetogenic hormone. Also true. Thyroid hormone increases the blood glucose levels go increase karega. How? By glycogenolysis, gluconeogenesis. You know the story. Okay, so simply remember this GI tract, this is not needed. Simply remember thyroid hormones increases the blood glucose levels. Okay, and last and final thing, on the heart. Okay, on the heart, the T3, when it is acting on the heart, what the heart is going to do? The heart is going to produce more sympathetic receptors. Now more number of receptors are going to come. What are these receptors? The beta 1 sympathetic receptor, beta 1 receptors. The number of beta 1 receptors will become more in number. Heart myocytes will produce more beta 1 receptors. So what happened to the heart rate? Now when epinephrine or norepinephrine comes and stimulates this receptor, now heart rate increases. So thyroid hormones increases the heart rate. Okay, the same thing. Heart, look at the heart. Increased number of beta sympathetic receptors or beta 1 adrenergic receptors. Okay, beta 1 adrenergic receptors. And what happens? Now the myocardium is more sensitive to epinephrine, norepinephrine. Circulating catecholamines means epinephrine, norepinephrine. Okay, now the heart will become more sensitive. Means the heart is getting easily stimulated because more number of receptors are there. Done, sir. Thyroid hormone functions are completed. Now, one by one, close your eyes and tell me heart mein. Thyroid hormone increases the heart rate. Adipose tissue, protein breakdown. Muscles mein, protein breakdown. Bone, skeletal development. Central nervous system, brain development. Thyroid hormones are thermogenic hormones. Thyroid hormones increase the basal metabolic rate. Thyroid hormones increases the basal metabolic rate by increasing the number of sodium, potassium, ATPases. Thyroid hormones increases the BMR everywhere except in 5 places, and you know what are those 5 places. Done. Now, say, for example, imagine there is a baby. Okay, imagine there is a baby, sir. Now, this baby, by birth, because of some reason, by birth, T3, T4 are not there. T3, T4 are not available. T3, T4 production is not there. No T3, T4. So do you think growth can happen? I said you, T3 is responsible also for the skeletal development. So no growth. Or you can say stunted growth. Or you can say even dwarfism also, no doubt, dwarf. And what about the mental cognition? What about the mental cognition? No mental cognition, or you can say the patient is going to have mental retardation. Okay, mental retardation because the brain development doesn't occur properly because the T3, T4 are not there. So now this baby, by birth itself, that is congenital. The baby is not having the T3, T4. That is congenital hypothyroidism. Congenital hypothyroidism can lead to dwarfism plus mental retardation. Congenital hypothyroidism can lead to dwarfism and mental retardation. Can anyone tell me what is this condition called as? Anyone in this class? Let me see who is a good boy or good girl. What is this? Congenital hypothyroidism leading to dwarfism and mental retardation. This condition is called as. Come on, buddies. Come on. Jyoti, Garima, Satish, Vishnu, Alisha, Venkateshwaran, Susmita. Come on. Exactly, Alisha. You are true. It is cretinism. Okay, Satish Kumar. Yes, well done. Okay, Garima. Okay, Alisha, Garima. Yes. Okay, Nanda. Yes. Venkateshwaran. Yeah, it is called cretinism. Okay, this is called as a cretinism. Congenital hypothyroidism leading to dwarfism and mental retardation is called as a cretinism. Done. Okay, done, sir. See, regarding this, a good thing. I'm not going to do these pathology things. You know. Okay, don't say like, you know, sir didn't taught us hypothyroidism, hyperthyroidism. Hypo and hyperthyroidism are the topics of pathology. It's not my job. Okay, I'm not going to teach you this. Just for first year students ke liye, first year and second year students ke liye, I even teach the pathology. Okay, I teach the pathology also. That's why I have included. Otherwise, these are not going to be taught by me for FMGE. Okay. Some of your friends might be thinking, why sir didn't taught this? Tell them this is pathology, hypo and hyperthyroidism, clinical features. The patient is going to be obese. These things, these are all pathology things. I'm not going to teach and not required in physio. Okay, done, sir. Next hormone is going to be insulin. We are going to discuss about the insulin. Just sit back and relax. Just let's have a discussion. So most of you guys are from which university? There are almost 70 students. Abra, I will show you. Can you tell me what you guys are from which university? Most of you, I believe most of you are from ISM. Is that true? Are you from China? Lugansk. TSMU, Georgia. Okay, China. Tbilisi, Kakas. Okay. So last FMG exam. Do you know how the last FMG exam was? The last FMG exam was very easy. Very easy, sir. Last FMG exam was very, very easy. No doubt in that. Physiology में 8 questions were there. Direct questions. I'm not talking about the indirect questions. Direct questions were there. All 8 questions were easy questions, and all those 8 questions from that one single book, whatever you are having. You might think, sir, physiology ke liye we have to study 4 days. Of course, because without physiology you can't understand the other systems. Without physiology, it's little hard for you to understand the other systems. Its last paper is easy, yes, easy non-clinical paper, but already most of the faculty knows that it is going to be easy exam, because always December paper is going to be easy, no doubt in that. Always 90% of the December exams, whatever have happened, are always easy papers. Okay, June papers are difficult papers. Okay, ask any faculty or ask any senior, they will tell you June papers are going to be clinical, difficult papers. December papers are going to be non-clinical papers, single liner kind of questions, kind of. Okay, so that's why I'm trying to integrate as much as possible. I will discuss in the previous year questions, physio, patho, medicine, gynae things like that. Okay, yeah. So I'm telling you smoothly that yes, Jyoti, what I'm telling you in a smooth way, yes, the paper is going to be hard. Prepare for, prepare for the worst, so that we can, if it is easy, okay, that's good. If it is easy, okay. So always you prepare yourself for worst. Yeah, it's a December May pass percentages are going to be more, and the paper is going to be non-clinical. Chalo, let's begin the pancreas. Pancreas may I have taught you one of the important topics. One of the important topics in the endocrine is insulin. Now, pancreas got 2 functions. There are 2 functions of the pancreas. One is endocrine function and exocrine function. Pancreas is having dual function. Exocrine function. What is exocrine function of the pancreas? It produces digestive enzymes. This we will discuss in the GIT. Okay, this topic we will do it in the GIT. And what is the endocrine function of the pancreas? Endocrine function is the hormone production. Hormones are going to be produced. Which hormones? I will tell you. See, pancreas mein, there are different types of cells. Alpha cell, beta cell, D cell, F cell, E cell. These are the different types of cells. Alpha cells produce glucagon, right? Alpha cells produce glucagon. Glucagon का काम क्या है? Glucagon increases the blood glucose levels. True. Beta cells produce. You know already. Beta cells produce insulin. Most of the student knows. Insulin is produced by beta cells of pancreas. But as an MBBS graduate, you should also know not only insulin, sir, but also amylin and C-peptide. Insulin, amylin and C-peptide, all these 3 are produced by beta cells. इसका काम क्या है? Now, insulin का काम है to decrease the blood glucose levels. Insulin decreases the blood glucose levels. Okay. Next, D cells. D cells are delta cells, produce somatostatin. Now, some students will have it out, sir. Hypothalamus produces the somatostatin. Of course, even your GIT produces somatostatin. Pancreas produces somatostatin. So D cells are delta cells. They produce somatostatin. So somatostatin, what they will do? They decrease insulin and glucagon and VIP, gastrin, everything. Somatostatin decreases all. Just remember, it decreases all hormones: serotonin, VIP, gastrin, insulin, glucagon, everything. It decreases everything. Okay. F cells produce pancreatic polypeptide. Function we don't know. Epsilon cells produce ghrelin. I have discussed, sir, ghrelin during fasting conditions, during increased hunger, ghrelin is produced. Ghrelin ka one more function I have in the morning, I have explained you. Ghrelin also increases the growth hormone. True, ghrelin increases the growth hormone, plus ghrelin is responsible for the hunger. Okay, the hunger sensation is because of which hormone? Ghrelin. Okay, now these are the cells and their secretions and their actions. Now FMG exam mein, and this is also little high yielding for PG also. Okay, little high yielding for PG. Now look, insulin के बारे में थोड़े टाइम के बाद we'll discuss करेंगे. Now C-peptide. Now let's discuss about the C-peptide. Where do we have discussed the C-peptide? C-peptide and amylin. Look, first point is C-peptide is produced in equimolar concentration along with insulin. What is the meaning, sir? Now, imagine if this is the pancreas. Pancreas is producing 1 molecule of insulin. 1 molecule of insulin. Also, the same beta cell will produce 1 molecule of C-peptide. C-peptide is useless. It comes out in the urine. Okay, but anyway, if there is one molecule of insulin, there will be one molecule of C-peptide. So they are produced in equal amounts. So produced in equimolar concentration along with insulin. Point completed. Now, the C-peptide, it is coming out into the urine. Now, in the urine, I am saying there are 100 molecules of C-peptide. For example, in the urine, I am saying 100 molecules of C-peptide. So how many molecules of insulin is there in the blood? There is 100 molecules of insulin there in the blood. So by looking at the C-peptide, I can estimate endogenous insulin levels, right? By looking at the C-peptide, I can estimate the endogenous insulin levels. So that's why see, so it is considered as a marker of endogenous insulin production. Okay, so it's considered as a marker of endogenous insulin production. So C-peptide is produced in equimolar concentration, and it is also considered as a marker of endogenous insulin production. Done. Okay. Now, okay, guys, look, I'm telling you. So, for example, one more question. This is actually this is a little high yielding and little confusing also. Imagine this 50-year-old guy, 50 years. Okay. Now, he is coming to the hospital. 50 years, diabetic patient. Okay. So 50-year diabetic patient. He came to the hospital in unconscious state. Okay. He came to the hospital in unconscious state. Now, as he is a diabetic, you immediately check the blood sugar levels. Simple, 1 minute mein you are going to check the blood sugar levels. Blood sugar levels are less, so he is hypoglycemic. He is hypoglycemic. His blood sugar levels are low. Now, you want to know why the blood sugar levels are going down. There are two possibilities. Two possibilities. One possibility is he have taken excessive insulin from outside. That is exogenous. You know, right? Diabetic people will take the insulin. So exogenous, outside, from outside, you don't have that any idea. Like, no, he's from a village. Okay, the relatives, they don't know anything. One possibility is from outside he have taken excess insulin. So if he's taking excess insulin, that will cause hypoglycemia, no doubt. This is the one possibility. Or he have taken drugs. For example, a drug called as sulfonyl urea, glipizide, glyburide, glyclazide. I will show them. I will discuss about them later in 5 minutes. He have taken excess tablet. This sulfonyl urea, so tablets called as tab. This is the tablet. Okay, tablet sulfonyl urea. What the sulfonyl urea will do? They will go to the pancreas. They will stimulate pancreas to release more insulin. They will stimulate the pancreas to release excessive insulin. That insulin can lead to again hypoglycemia. So these are the two possibilities. You want to know. This patient is having hypoglycemia, no doubt. Why hypoglycemia? Is it because of exogenous insulin or is it because of endogenous insulin? If you take sulfonyl urea, this is endogenous insulin. Okay, endogenous insulin, right? The pancreas is going to make the insulin. This is the endogenous insulin. Okay, so how to differentiate? How to know? Look, if he is taking exogenous insulin, only pure insulin he is taking. So what about the urine C-peptide levels? Here, urinary C-peptide levels are normal. If he is taking exogenous insulin, the urine C-peptide levels are going to be normal because he is injecting insulin from outside. But in this condition, if he is using the drugs like sulfonyl ureas, they are stimulating the pancreas to release insulin. At the same time, here the pancreas will also make C-peptide, additional C-peptide. So based on the C-peptide levels, we can say whether it is endogenous insulin or exogenous insulin. Okay, so that's the third point. So the C-peptide, based on the C-peptide, you can differentiate endogenous and exogenous sources of insulin. Endogenous sources में C-peptide levels are elevated. If you take exogenous insulin, C-peptide levels are normal in the urine. Okay. So that's the case. That's how you will differentiate. So differentiate endogenous and exogenous sources of insulin in the evolution of C. Okay, in the evolution of our evaluations are not evolution, evaluation of hypoglycemia. Okay, hypoglycemic cases may we will use C peptide. So 3 MCQs about the C peptide produced in equimolar concentration along with insulin. It's an endogenous marker of insulin production. It's an endogenous marker of insulin production, and differentiate exogenous versus endogenous sources of insulin. Is that clear? Next, after this, let me discuss about the amylin. Amylin is very simple, sir. Amylin is very simple. See, just like C peptide, amylin is also produced. Amylin is also like insulin. All are like insulin. Amylin also decreases blood glucose levels. What it is doing, it also, just like insulin, it also decreases the blood glucose levels. See, it decreases glucose spike in the blood. How means this amylin, it reduces glucagon. Glucagon increases the blood glucose, so glucagon levels will go down. So amylin, what it is doing, it's inhibiting the glucagon secretion. By inhibiting glucagon secretion, if glucagon goes down, blood glucose levels also goes down. Good. Amylin, it delays gastric emptying, means it try to understand, like it delays the digestion process. Digestion is going to occur slowly, so blood glucose levels will also rise slowly. Okay, delays gastric emptying, or you can say delays digestion. Okay, delays digestion, so blood glucose levels are not going to spike rapidly, slowly increases. Okay, and amylin, what it gives, it gives the feeling of satiety. Satiety means feeling of I'm done, sir, I'm satisfied, I'm done, I don't want to have more. Okay, so that you won't eat more, your blood glucose levels are controlled. Satiety means I don't want to eat. If you don't want to eat, your blood glucose levels will not rise. Okay, that. So these are the things. Amylin, just like insulin, decrease the blood glucose. Only one point I want you to remember. These things you remember or don't remember, I don't worry. But last thing, pharmacology integrated. See, amylin, what it is doing, it decreases the blood glucose. So we have manufactured drug which is called as the pramlintide. See, in the name amylin is there. Okay, it's a pramlintide. It is amylin analog. It is used where? Used in the treatment of diabetes mellitus. For the treatment of diabetes mellitus type 1. Okay, for the treatment of diabetes mellitus type 1, only 2 drugs are approved. Only 2 drugs are approved. One is insulin. See, apart from insulin, the only drug approved for the treatment of diabetes mellitus type 1 is amylin. Pramlintide. Okay, so pramlintide is the only drug which is approved apart from insulin for the treatment of diabetes mellitus type 1. Type 2 के लिए बहुत सारा drugs है sir, like sulfonylureas are there, like acarbose, different meglitinides, so many drugs are there. Okay, SGLT inhibitors, so many things. So C peptide completed, amylin completed, the basic things are completed. Now in the next 10 minutes we can complete the insulin also. Shall we? Shall I go forward? Done. Which previous slide? Can you tell me what is the specific slide? Abra, can you tell me what is the specific slide? Previous slide means topic. Which topic that one? Endocrinism. This one. Take a screenshot. No, it's simple. No. By birth T3 T4 absent are not there. Into means not there. So causing congenital hypothyroidism. So amylin, important points, sir. It delays digestion, delays gastric emptying, it delays or like you can say it reduces the glucagon secretion, it decreases the blood glucose levels, it increases satiety. Only drug that is approved for the treatment of diabetes mellitus type 1 is pramlintide, apart from insulin. Now, insulin, what kind of hormone it is? It's a first right. Growth hormone. I have already taught you. Growth hormone, anabolic hormone. Thyroid hormones are catabolic hormones, but insulin is one of the major anabolic hormone. Build up. Sorry, it's already written here. So it's a anabolic hormone. Okay, who discovered it? Bullshit. Structure, not necessary. See, insulin is stored along with, if this is the beta cell of the pancreas, if this is the pancreas, if this is the beta cell of the pancreas, insulin, it's stored along with zinc. Okay, insulin is having a structure. There is A chain, there is B chain, there are disulfide bonds, so many things are there. But this insulin is stored with zinc. It's bind with zinc. Why? The insulin is stored with zinc because that zinc stabilizes the structure of insulin. Okay, zinc stabilizes the structure of insulin. Now, just as a integration purpose, I'm integrating it with the PSM. Zinc deficiency, patho also. Zinc deficiency is going to cause a disease. Can anyone tell me? Zinc deficiency is going to cause a disease. Any idea, buddies? Students from Georgia and China. Most of the students are from Georgia and China. Can anyone tell me what is the disease that you will get because of the zinc deficiency? Eczema? No. Rekha, you are true. Not pellagra. Rekha, Garima, you are also true to a bit. It is acrodermatitis. Okay, acrodermatitis. Enteropathic. Okay, in your FMU exam, this is a famous question. Zinc deficiency causes acrodermatitis enteropathica. And one more question which I want you to know here as integration. Suppose I'm telling this selenium deficiency. Selenium deficiency is going to cause a disease called as Kishan's cardiomyopathy. Okay, Kishan's cardiomyopathy. Selenium deficiency, zinc deficiency, and copper deficiency. Copper deficiency is going to cause which disease? Anyone? Zinc deficiency, acrodermatitis enteropathica. Selenium deficiency is going to cause Kishan's disease. Copper deficiency is going to cause which disease, sir? Copper deficiency. Bolomani Priya, it's not Wilson. It's not Wilson. Wilson's disease is because of copper excess. Okay. Minky, not Mindy. Minky, Sai Pranati. It is Minky Kinky. Minky Kinky. Okay. Minky Kinky. Exactly. Minky Kinky. That's also FMG question. The copper deficiency is going to cause Minky Kinky disease. It will again come in PSM also. PSM. So copper deficiency is going to cause Minky Kinky disease, where the kinky means the hair is going to be kinked, like like curling hair. Okay. So Minky Kinky disease is copper deficiency. And done. Wilson's. That Wilson's disease is copper excess. Copper excess will cause Wilson's. Okay, continue. Let's continue. So how insulin is going to be released? Insulin release. The topic is insulin release. Again, very important. Draw this. Take a white paper. Take white paper, sir. Not complete white paper. You can have like half of the page or enough. But write one by one. First thing, this is the beta cell of the pancreas. This is the beta cell. What beta cells produce? Already in the beta cells, they have produced insulin. Insulin already there. Insulin is already ready in the beta cell. Okay. Now, what is this one? This is a blood vessel. This is your blood vessel. And what is this yellow color thing? The yellow color thing is your adipocytes. Adipocytes, and you can also say skeletal muscles. Adipocytes are skeletal muscles. Adipocytes are skeletal muscles. Now, you have taken the food. Afternoon, your mom is going to bring food for you. Some of you might be listening to this lecture while eating. So, you have taken the food. Food is digested in your stomach. After the food digestion, who is going to be released? Glucose is going to be released. So, glucose is here. The glucose came into the blood. Now this glucose, do you want the glucose to be in the blood or do you want the glucose to go into the cells? The glucose have to go into the cells, and from the glucose, the cells have to make ATP. From the glucose, cells have to make the ATP cell. So now this glucose is trying to go into the cell, but it cannot go. It can't go because glucose is a big molecule. Glucose is a big molecule. Of course, in the cells, glucose levels are low, no doubt. Glucose levels are low, but still the glucose can't go there because glucose is a bada molecule, sir. Okay. Now what will happen is, look, now this glucose, it will enter into the pancreatic beta cell. Now this glucose, it will enter into the pancreatic beta cell. Now some students will have a doubt, then how it can enter into the pancreatic beta cell, sir? You said it is a bigger molecule, then how it can enter into the pancreatic beta cell? It will enter into the pancreatic beta cell because here there is a special transporter. There is a special transporter present that is called as GLUT2. So with the help of glucose transporter type 2, with the help of glucose transporter type 2, which is there on the pancreatic beta cell, okay, which is there on the pancreatic beta cell. Now glucose, where it is entering? Glucose is entering into the glucose is entering into the pancreatic beta cell. Now glucose came into the cell. One thing which I forgot to mention in the beginning, see, on this pancreatic beta cell, there are these channels present. There is this channel, lot of these channels are present. This green color channel which I am drawing here. These green channels, what they are doing, they are kicking the potassium out of the cell. They are kicking what? They are throwing the potassium, K plus, out of the cell. They are throwing the potassium out of the cell. Okay, potassium is going out. When the potassium is going out, see, the positive charges are going out. The positive charges are going out of the cell. When the positive charges are going out of the cell will become electrical negative. The cell will become electrically negative. Means the cell is sleeping. The cell is sleeping. Electrically negative means cell is hyperpolarized, not activated, sleeping. Okay. Now what happens? You ate the food. Glucose came into the cell. Now this glucose, okay, now this glucose, finally, it will go through the glycolysis. Finally, the glucose is converted into ATP in the cell. That is glycolysis, electron transport chain. With the help of electron transport chain, okay, electron transport chain, glycolysis, ATP is produced. Now this ATP will come and close this potassium channels. The ATP is going to close this potassium channels. ATP closes the potassium channels. So what is the name of this potassium channel? This potassium channel is called as ATP sensitive potassium channel. Okay, so this is the ATP sensitive potassium channel. ATP sensitive potassium channel. Okay, so now glucose came into the pancreatic beta cell. The glucose via glycolysis, electron transport chain, okay, Krebs cycle, it's converted into ATP. Now this ATP is going to come and close the ATP sensitive potassium channels. Don't worry, one by one step I will make you to write. Okay, now next, when the potassium channel is blocked, what happens? Potassium concentration increases inside the cell. Potassium is accumulating inside the cell. Potassium is not going out, which means the positive charges are accumulating. Positivity is accumulating. So that will cause depolarization. That will cause what? Depolarization means electrically the cell is getting active. Electrically the cell is becoming positive. Electrically the cell got positivity. The membrane got positivity. At this voltage, now what happens when the cell is depolarized? Now for the first time, these channels are opened on the cell. What are these channels? Calcium channels. Now because of the depolarization, calcium comes into the cell. Calcium will come and bind with these vesicles. Okay, calcium is coming and binding with the insulin vesicles. What I hope you already know from general physiology, calcium helps in exocytosis. Now these vesicles will move and release insulin. Now insulin is released. This is how insulin is released. Okay, potassium is responsible for depolarization. Calcium is responsible for exocytosis. MCQ. Which ions are responsible for exocytosis? Calcium. Which ions are responsible for depolarization in pancreatic beta cell? Potassium. Okay. Now, look, this insulin, what it will do? Insulin, what it will do means insulin is going to act on its receptor. This is the insulin receptor which is present on the adipocytes. See, on the adipocytes and skeletal muscles, this is insulin receptor. It's an insulin receptor. Now insulin is going to stimulate its receptors. When insulin is stimulated, the receptor, the cells, when the insulin receptor is stimulated, now look, now what happens is, now let me take this color. Now for the first time, these cells, see these adipocytes, now they are opening these channels. Previously they are closed, now they are opening these channels. Now through these channels, the glucose will enter into the cell. So this is how glucose will come into the cell. Okay, now the glucose is moving from the blood into the cells. So what is the name of this channel? This is called as glucose transporter type 4. Glucose transporter type 4. When insulin receptor is stimulated, now then only these adipocytes and skeletal muscles will produce glucose transporters type 4, through which they will uptake the glucose. So what happened to the blood levels of glucose? They will decrease. The blood levels of glucose decreases. So this is how insulin decreases the blood glucose levels. This is how insulin decreases the blood glucose levels. Done, sir. Total topic completed. Okay. So one by one steps. If you have any doubt, ask me now itself. Okay. If you have any doubts, ask me now itself. Sir, can you explain again the mechanism of beta cell? Rekha, you are asking now, is that clear? Rekha, can you explain again the mechanism of beta cell? See, simple beta cell. Beta cell is releasing the potassium. Initially, the potassium is going out of the beta cell. Potassium is going out. Okay. Now, when the glucose comes into the beta cell, glucose will be converted into ATP. ATP goes and blocks the ATP sensitive potassium channels. That ATP sensitive potassium channels will be blocked because of the ATP. So potassium will accumulate inside the cell. Potassium is a positive charge. Potassium accumulates inside the cell, leading to depolarization. Yes, I will give. So potassium accumulates inside the cell, leading to depolarization. Because of the depolarization, once the depolarization occurs, once that positive potential occurs, calcium channel opens, calcium comes into the cell, leading to exocytosis of insulin. So insulin, what it will do? Now look here, Susmita, now look here, what insulin is doing. First step, see, insulin is coming into the blood. Insulin is going and acting on the insulin receptors. Insulin is acting on the insulin receptors. When this insulin receptor is stimulated, now what these adipocytes and skeletal muscles are doing? They are doing the production of, they are producing the glucose transporters type 4. Once you have glucose transporters type 4, the blood glucose is moving into the cell. The glucose which is there in the blood, it is moving into the cell. So what happened to the blood glucose levels? It decreases because the glucose is moving into the cell. So blood glucose levels decreases. So this is how insulin decreases the blood glucose levels. So insulin indirectly, simple insulin ఏం చేస్తుంది? What insulin does is it incorporates glucose transporter type 4. So with the help of glucose transporter type 4, glucose moves into the cell. Simple. So blood levels of glucose decreases. No, simple. Okay. So the same thing was shown in this image. See, one by one, look. First, sir, what happens? Sir, first, glucose is entering into the pancreatic beta cell. See, first glucose is entering into the pancreatic beta cell with the help of GLUT2. So glucose came into the cell. Glucose, what it will do? It will enter into glycolysis, okay, Krebs cycle, all these steps. Finally, ATP is produced. What ATP will do? ATP inhibits this potassium channels. See, ATP sensitive potassium channels are inhibits. Leading to what? Depolarization. After depolarization, what happens? Calcium comes into the cell. What is calcium will do? Calcium is going to cause exocytosis. Okay, here insulin is there. These are insulin vesicles. So insulin comes into the blood. And from here, you know the story. Next story. Okay, insulin will go and act on the tissues. You know the story. So write these steps one by one. But what is the first step? Simple. Glucose enters into, even if it takes time, right? Insulin, all points about insulin are important. Step one, glucose entry. Glucose enters into pancreatic beta cells with the help of GLUT2. This movement is an example of, see, this movement is example of this one, sir. Okay, let me show in my image. See, first what is happening? Glucose, let me first clear this. See, this one here. The glucose is entering into the cell. So glucose is getting transported. No, glucose is getting transported into the cell. So it is an example of facilitated diffusion. Facilitated, this GLUT2, this movement via this GLUT2 is an example of facilitated diffusion. Or lifelong, remember one thing. Wherever you see the word GLUTs, GLUT, glucose type 1, glucose transporter type 1, type 2, type 3, type 4, GLUT1, GLUT2, GLUT3, GLUT4, GLUT7. All are examples of, all glucose transporters are examples of facilitated diffusions, no doubt. If you see the word GLUT, that example is facilitated diffusion. That movement is called as facilitated diffusion. Okay, glucose enters pancreatic beta cells via facilitated diffusion. So what is happening to this glucose? Glucose generates ATP. Okay, done. What's the next step? Step 2. Step 2, once you have ATP, see, closure of ATP sensitive potassium channels. See, ATP inhibits ATP sensitive potassium channels, leading to potassium, say, reduced potassium efflux. Say, reduced potassium efflux. Potassium is now not going out. Reduced potassium efflux. Okay, so potassium accumulates. Potassium is starting to accumulate. Now, pharmacological integration. So there are drugs called as sulfonylureas. Sulfonylureas. There are drugs. These drugs, what they will do? Sir, sulfonylureas, they will also block what? ATP sensitive potassium channels. So there are drugs called as sulfonylureas. Even they, what is the mechanism of action? What they will do? Even they will act like ATP. They will act like ATP. They blocks ATP sensitive potassium channels. I will explain little bit more about this in next slide. Sulfonylureas block ATP sensitive potassium channels. Okay. Just remember that one point. Step 3. What happens? Step 3 is the accumulation of potassium ions lead to depolarization. You already know about it. Potassium accumulation leads to depolarization. Once the cell is depolarized, the depolarization opens calcium channels. Calcium enters into the cells. Okay, calcium enters into the cells. And last, what is that? Exocytosis. Once calcium ions enters into the cells. Okay, once the calcium ions enters into the cells, what happens? Exocytosis of insulin containing vesicles will be undergoing exocytosis. So there is nothing important about this image, you know, simple. This is the skeletal muscle, for example. This is adipocyte. If you want to write. Okay. See, now here is the adipocyte. Imagine. Now see, insulin is acting on its receptor. See, insulin receptor. Insulin is acting on its receptor. When insulin is acting on its receptor, see, with the help of glucose transporter type 4, glucose molecules are coming in. See, the glucose molecules are coming in. Okay, the glucose molecules are coming into the cell. Simple. That's it. With the help of glucose transporter type 4, glucose molecules will start to come into the cell. So final, I'm asking you, if you have any doubt, still I will explain. I'm asking you, is that clear? Now you understood how glucose is released. Sorry, glucose, not glucose. Insulin is released. How insulin is released? From the pancreatic beta cell. How insulin is released? potassium accumulation, depolarization, calcium entry, exocytosis. Once insulin is released, insulin acts on insulin receptors so that glucose transporter type 4 are produced. They will uptake the glucose. Okay. Which one? Last slide. This one. This one. Right. Now, see, here I'm going to integrate little important drugs. Of course, anyway, the other drugs will be discussed in the pharmacology. Certain things. This sulfonylurea, it's an anti-diabetic drug. Anti-diabetic drug. It's an anti-diabetic drug. What it will do? It decreases the blood glucose levels. How it decreases the blood glucose levels? See, if I take a drug called as sulfonylurea, okay, it's a class actually. Sulfonylureas includes the glipizide, glimepiride, glyburide. These are the sulfonylureas. What they will do? They will block the ATP sensitive potassium channels. Okay. You know the story now. When the ATP sensitive potassium channels, when they are blocked, look here. When the ATP sensitive potassium channels are blocked, potassium will accumulate, leading to depolarization. Once the depolarization occurs, calcium comes into the cell. Once calcium comes into the cell, insulin is released. Insulin is released. So yes, this is how, okay, sulfonylureas increases the insulin release. Sulfonylureas, what they're doing? Increases the insulin release. Okay, so they are also called as this sulfonylureas are also called as insulin secretagogues. Insulin secretagogues means they increases the insulin release by blocking ATP sensitive potassium channels. Done. Okay, now look here. So this is the pancreas. Try to draw it. This is important. There is a tumor to the beta cell. This is the beta cell. It got cancer. The beta cell ko cancer aaya. This beta cell ko tumor is that this is it's releasing what? This beta cell tumor, it's releasing insulin. Okay, it's releasing very high amount of insulin. So what is the name of this tumor? This is called as insulinoma. Insulinoma. More and more and more insulin is getting released. In this condition, what you have to do? You have to decrease the insulin. Okay, as a treatment, what you have to do? Treatment, you have to decrease the insulin. How you can decrease the insulin? By opening the potassium channels. So if you close the, see, if you close blocks, or if you close the ATP sensitive potassium channels, more insulin is released. But if you open potassium channel opener, see, there is a drug called as a diazoxide. It opens the ATP sensitive potassium channels. It's a potassium channel opener. If potassium channels are opened, you think once, if you open the potassium channels, potassium goes out. Okay, if you open the potassium channels, potassium will go out of the cell. So cell will become negative. The cell will become negative because positive charges are going out. So diazoxide, it's a potassium channel opener. It decreases insulin release. It's used in the treatment of insulinoma. So these two drugs in physiology, I want you to integrate. So sulfonylureas are potassium channel blockers. Diazoxide is a potassium channel opener. Sulfonylureas is used in the treatment of diabetes mellitus. Diazoxide is used in the treatment of insulinoma. That's it. Okay, that's it. Other things, pure pharmacology, not here. I know, sir. I am teaching for the last 8 years. Almost I am teaching from the last 8 years. This is your 8th year. Okay, I know from where the questions are going to come. Okay, simple. Whatever I'm going to teach, just know it. If you are in your first year, second year, I would have taught you like in syncretin analogs, like, in first year we do that. But right now it is not needed. Okay. So now what I want is, guys, now take a break. Now what's the time? It's 1:10. Now I'm going to give you the break. How much time do you want the break, sir? How much time do you want me to give the break? 1 hour. Are you are in your home? Huh?
Jyoti, you're in your home, your mom is going to make food. Okay. So maximum I will give you, it's 110, right? Almost 110. I will start the class at 1:45. Is that okay? No, you are in the university. Okay. You want, okay. So okay, take it, no issue. I will manage. You don't worry. I will manage. So if I extend the class till 7, it's okay, right? Normal timings are till 7. I'm not extending. Normal times is till 7. Is that okay, right? You are like, don't say, sir, in our university the theaters are going to be closed, the projection rooms are going to close. Don't say something like that, okay? The class will be till 7. Okay? Take break till 2. Till 2, break is going to be there. Well, guys, can you hear me? It's 2 o'clock. Okay, let me share my screen. Okay, done. So, chalo, let's continue. It's already 2 o'clock. Just give me 1 minute. I have my pencil. Just 1 minute, guys. I have to just make some small changes in my pencil. 1 minute. 1 minute. I'll be back in 1 minute. Okay. Hello. Yeah. So there is a small issue with my Apple Pencil. That's why. Now, let's continue. So, what are the biochemical reactions which are done with the which are done by the insulin? Okay. So this is a little biochemistry integration. A lot of anticipation that a question can come from this area. See, insulin, what it will do to the glucose? It decreases the blood glucose levels. No doubt, right? It decreases the blood glucose levels. Simple as that. Insulin decreases the blood glucose levels. Okay. So all biochemical reactions which decrease the blood glucose levels will be activated. So what this insulin is doing? Look, insulin, it is activating glycogenesis or glycogen synthesis, lipogenesis, okay, glycolysis. So what are all these three biochemical reactions? What they will do? They ultimately decrease the blood glucose levels. Okay. So glycogen synthesis, first one, the glycogenesis or glycogen synthesis. What it will do? It will convert the glucose into glycogen. It will convert the glucose into glycogen. So glucose is going to be converted to glycogen. So glucose levels will go down. Lipogenesis, once you have sufficient amount of glucose, so the glucose will be converted into fats. That's the lipogenesis. Okay. And the glycolysis, what is glycolysis? You will take the glucose, the cells will take the glucose, and the glucose will be converted into ATP. So what at the end of the day, what I want you to know is, insulin final goal is to decrease the blood glucose levels. The ultimate goal is to decrease the blood glucose levels. So any biochemical reaction which decrease the blood glucose levels, they will be activated. See, plus. So they are all getting activated. And any biochemical reaction which increase the blood glucose levels, they will be inhibited. Okay, see, for example, glycogenolysis. Glycogen lysis means glycogen breakdown.
Glycogen, if it is breaking down, it produces glucose. So it is inhibited. See, gluconeogenesis, newly synthesized glucose is forming newly. So that is inhibited. Lipolysis, inhibited, because it stimulates lipogenesis. Okay, and ketogenesis, this is very important. Ketogenesis is important, sir. So till the time insulin is there in the body, ketone bodies are not produced, ketone bodies are not seen. Why? I will discuss in a minute. In the next slide, there is something called as a diabetic ketoacidosis. Okay, diabetic ketoacidosis, the ketone bodies. I will discuss about that here. Okay, for now, just look. Now, in this slide, what we have learned. Okay, in this slide, what we have learned. I have taught you that insulin, its relation with the biochemical reactions. There are certain biochemical reactions which are activated. There are certain biochemical reactions which are activated, and there are certain biochemical reactions which are inhibited. And you have to by heart them. Insulin activates glycogenesis, lipogenesis, and glycolysis, but inhibits glycogenolysis, gluconeogenesis. It inhibits lipolysis and ketogenesis. But one more function of insulin. Insulin ka ek aur kaam hai. What is that? Whenever we give insulin, whenever there is insulin, insulin moves potassium into the cells. Okay, whenever there is insulin, the potassium will be taken into the cells. That's what insulin moves potassium ions into the cell. So that's why in the treatment of hyperkalemias we use insulin. Okay, when the patient is having high levels of potassium, if you give insulin, all that potassium will be taken into the cell. All the potassium will go back into the cell. So that's why in hyperkalemia, what we will use? Insulin. In the treatment of hyperkalemia, we use insulin. True statement. Okay. Now, come to this slide. Now, come to this slide. Not this one. Not this one. Not this table. This table. Not this table. So, from the morning, I have taught you there are certain hormones which increase the blood glucose levels, and there are certain hormones which decrease the blood glucose levels. See, insulin, you know, it decreases the blood glucose levels with the help of glucose transporter type 4. Okay, glucose transporter type 4. With the help of glucose transporter type 4, insulin decrease the blood glucose levels. So you know it. But who increase the blood glucose levels? From the morning, I said thyroid hormones, growth hormone. See, growth hormone is a glucogenic hormone. Thyroid hormone is a glucogenic hormone. Glucagon also increase the blood glucose levels. It also increase the blood glucose levels. Okay, even cortisol, it increase the blood glucose level. Cortisol also increase the blood glucose levels, no doubt in that. And catecholamines, what are catecholamines? Epinephrine, norepinephrine, even they increase the blood glucose levels. So all these hormones increases the blood glucose levels. Yes, of course, growth hormone increases the blood glucose levels, and cortisol also increases the blood glucose levels. Some students might have a doubt. Arey sir, in the morning you said growth hormone is an anabolic hormone, cortisol is a catabolic hormone. Yes, of course, still I am sticking to the same point. It's true. Yes, of course, this is a anabolic hormone. This is a catabolic hormone. This is a catabolic hormone. It doesn't matter whether they are anabolic hormones or catabolic hormones. See, these hormones, whatever I am showing here, they will all do what? They will all cause glycogeno or glycogenolysis. They will cause the breakdown of glycogen lysis, or gluconeogenesis. Okay, gluconeogenesis. With the help of these two, glycogenolysis and gluconeogenesis, they increase the blood glucose levels. Done. Right? Next, after this, the next topic which I want to discuss here is diabetic ketoacidosis. Okay, the topic is diabetic ketoacidosis. Now, for the next 10 minutes, please be very, very attentive, sir. Please be absolutely attentive for the next 10 minutes. Okay, because this is highly important and conceptual. It also comes in the medicine also. Okay, see, first of all, the patient is diabetic. Okay, the patient is diabetic. Which type of diabetes mellitus is mainly seen in this diabetic ketoacidosis? It's a condition which is mainly seen in type 1 diabetes mellitus. Type 1 mein. Type 1 mein, what is the problem? Type 1 diabetes mellitus. What is the main problem? The main problem is he is not having insulin. Type 1 mein insulin nahi hai. Body mein insulin not there. Body mein insulin was not there. So if insulin is not there, Do you think cells can take the glucose? I said you, whenever insulin is there, with the help of glucose transporters type 4, cells will take the insulin, cells will take the glucose. अरे अभी insulin नहीं है, insulin नहीं है तो tissues cannot utilize the glucose in the blood. Tissues can't use the glucose in the blood. Okay, now look at me. So I'm the person who is having type 1 diabetes mellitus. Imagine I'm the person who is having type 1 diabetes mellitus. Okay, imagine. Now in my body there is no glucose, sorry, no insulin. So my tissues are crying. Array, I can't use the glucose. But tissues, do you know what they will think? They will think that this person is not eating. The tissues will think a glucose is there. First of all, the glucose is there in the blood, but tissues can't use it. Okay, so the tissues will think, why we are not getting the glucose? Because maybe he is not eating properly. But at the end of the day, they have to get the glucose. So now my body is going to release counter-regulatory hormones, MCQ. Now my body, what it is doing? My body is going to increase the counter-regulatory hormones. What are these counter-regulatory hormones? Glucagon, epinephrine, cortisol, growth hormone, even thyroid hormone. These counter-regulatory hormones are being released. Why? Because they all increase the blood glucose levels. So the tissues are thinking that this person is not taking glucose. That's why they are not getting the glucose. But in reality, already glucose is there. But who is not there? Insulin is not there. Tissues doesn't know all this stuff. So tissues simply, what they are doing, they are increasing the counter-regulatory hormones like epinephrine, norepinephrine, cortisol, growth hormone, glucagon. So what they are doing, they further increase the blood glucose levels. So in the blood, there is so much glucose present. How much glucose, sir? The DKA patients will be having almost 350 to 550 milligram per deciliter. This much amount of glucose will be there. Not just 200, 300. Okay, most of the cases, they will give around 500. They have so much glucose in their bed. Okay, so much glucose. But do you think still tissues can use that glucose? No, insulin is not there. So they have so much amount of glucose, but their tissues cannot use it. It's just like, okay, there is an analogy. If you are in the ocean, with a boat, okay, there is a lot of water around you, but you still can't drink it. In the same way, glucose is there, but your tissues cannot use the glucose. Now, look, what these counter-regulatory hormones are doing. I have already taught you. These counter-regulatory hormones, they will act on the liver via glycogenolysis and gluconeogenesis. See, the blood glucose levels are elevated. Okay, so much glucose is there in the blood. Now question is, when you have so much glucose, that so much glucose will come to the kidneys, into the nephrons, right? That so much glucose is getting filtered. Now, your kidneys are designed by the God or nature in such a way, they will reabsorb to certain extent. Okay, glucose will be reabsorbed, no doubt. But right now you are having so much glucose. Okay, so all these glucose molecules cannot be reabsorbed. So glucose will start to come out in the urine. So glucose is coming out in the urine. Glucose is osmotically active. Glucose is like a sponge base. Wherever glucose goes, water follows. So along with the glucose is like a sponge piece. Okay, sponge. It absorbs the water. It takes the water. Okay, osmotic gradient. So because of the glucose going out in the urine, even water follows. So lots and lots of water is also excreted along with glucose. So that's why the patient is having what? Osmotic diuresis. Okay, so the patient is having what? Excessive urination. Because glucose is going out, glucose drags the water along with it. Because of this polyuria, excessive urination, the patient is going to get dehydrated. Because of the dehydration, the patient is going to have excessive thirst. So this is the main problem in diabetic ketoacidosis. In diabetic ketoacidosis patient, the patient is having polyuria, polydipsia, and severe dehydration. Okay, polyuria, polydipsia, and severe dehydration. Okay, next. Now, tissues have decided. Array, we are not getting the glucose. We are not getting the energy source. Now, do you know what happens? Now, tissues totally lost their hope on glucose. Now what is happening is, now other type of energy reserves, that is fat. See, carbohydrates, glucose is one type of energy, fats are other type of energy, proteins are other type of energy. Now fats are getting broken down. Okay, fats are getting broken down because of this counter regulatory hormones. I said you till the time insulin is there, okay, till the time insulin is there in the body, what it will inhibit? It will inhibit lipolysis. It inhibits lipolysis. Now abhi insulin nahi hai, now lipolysis starts. Insulin is not there now. Because of that, see, now lipolysis is starting, fats are getting broken down into fatty acids. Now these fatty acids, they will go to the liver. The fatty acids will go to the liver. Now in the liver, the fatty acids are converted into ketone bodies. This is how ketone bodies are produced. And the question asked in FMG exam, ketone bodies are synthesized in liver, not your liver, in your liver. Okay, so ketone bodies are synthesized in liver. Fats are getting broken down because of the counter-regulatory hormones. Lipolysis produces fatty acids. Fatty acids are converted into ketone bodies, and ketone bodies are also a source of energy. These are also a source of energy, just like glucose. Glucose will be converted into ATP. Like glucose is used for the production of ATP, I should say. Glucose will be used for the production of ATP. In the same way, ketone bodies will also help in generation of ATP. That's it. Both are energy sources. So ketone bodies are produced. What are the ketone bodies? Acetone. Okay. Acetoacetate. Ketone. These are the ketone bodies. Acetone is one type of ketone. Beta hydroxybutyric acid. Okay, beta hydroxybutyric acid, acetoacetic acid. Okay, acetone is a type of acid. So now in the body, acetoacetic acid, beta hydroxybutyric acid, all these acids are getting produced. Of course, they are energy sources. No doubt, they are energy sources. But at the end of the day, they are acids. Because of these acids, the pH is going down. The patient is having acidosis. So that's why the name is called as a diabetic patient. Is producing the ketone bodies, leading to acidosis. The pH is going less than 7.3. Okay, pH is going less than 7.3. That's why the patient is having metabolic acidosis. Okay. So this acetone is there in the blood. Right now, this acetone is there in the blood. Because of that, the patient is going to have sweet breath. This baby, 10-year-old boy who is having type 1 diabetes mellitus, this type 1 diabetes mellitus is seen in the small boys, like, okay, yes, younger ages, right? At younger people, seen in the younger people. So this 10-year-old boy, if you go and stand near him, he's going to sweet smell, not because he is sweet. Okay, not because he is sweet, because acetone is there in his blood, that's going to give the sweet smell. And the patient is having acidosis. Remember, whenever the patient is having acidosis, the patient is going to do hyperventilation. Look at me. Whenever, see, if I'm the person, imagine I'm the person who is having diabetic ketoacidosis. I'm the person who is having diabetic ketoacidosis. Do you know how the patient is going to breathe? He's going to breathe like this. He's going to breathe like that. Hyperventilation. He's going to do the hyperventilation. Deep inspiration, deep expiration. Okay, he's going to do the hyperventilation. Why? Because look, when you do hyperventilation, carbon dioxide will be washed out of the body. Okay, carbon dioxide, we are removing the carbon dioxide. Why we are removing the carbon dioxide? Because this is normal. Carbon dioxide reacts with water and forms H2CO3, carbonic acid. This is carbonic acid. Okay, so already the patient is having acidosis. Already the patient is under threat. He is having acidosis. So right now, in my body, I should not produce the acid. What is the source of acid? Carbon dioxide is the source of acid. So by doing hyperventilation, I am removing the carbon dioxide. That hyperventilation is called as Kusumal breathing. So hyperventilation is called as Kusumal breathing, seen in ketoacidosis, diabetic ketoacidosis. Okay, and because of this acidosis only, the patient is also going to have potassium disturbances. I'm not going into detail. Simple, remember that potassium disturbances are going to be seen. Potassium disturbances, just this one thing you just by heart it. You will again study this in medicine. Like, there is something like, potassium proton exchange will occur. I don't want to go into detail. Simple, the patient is going to have sweet breath. Carbon dioxide, in order to remove the carbon dioxide, there will be hyperventilation, hyperventilation is seen, that is called the Kusumal breathing. And also in order to maintain the pH, the potassium, okay, the potassium exchange will also occur, that is going to cause a potassium disturbance. Okay, just remember that one point. Okay, so that's it. These are the important points about the diabetic ketoacidosis. So on one hand, the patient is going to have polyuria, polydipsia, and dehydration. On the other side, the patient is going to suffer with metabolic acidosis. Okay, Kusumal's breathing is seen, potassium disturbances are the same. That's it. Is it clear? Okay, it's mainly seen in children. This diabetic ketoacidosis mainly seen in children, but it can also be seen in aged people. Mainly seen in children, but can also be seen in aged. Now I want the confirmation. Satish Kumar asking, Kusumal, sir, did you please repeat Kusumal breathing? Okay, everything okay. Are Kusumal breathing? What is Kusumal breathing? Hyperventilation. See, if I'm having acidosis, imagine I'm having acidosis. Okay, I'm having acidosis, guys. Now you should tell me. Now, should I have to produce more acid or less acid in my body? Already I'm having acidosis, so I have to produce less acid. What is the source of acid? Carbon dioxide is the source of acid in our body. Carbon dioxide is the source of acid. So in acidosis condition, I will remove the carbon dioxide out of the body. How? By doing hyperventilation, I will remove the carbon dioxide out of the body. So that hyperventilation seen in metabolic acidosis is called as Kusumal breathing. That hyperventilation seen in metabolic acidosis patients is called as Kusumal breathing. Okay, we are removing the carbon dioxide so that acid production will go down in the body. Already acidosis is there, so you have to decrease the acid production. Is that clear, Mahima? Okay. Satish is asking glycogenolysis. Glycogenolysis means what? Glycogen lysis. Glycogen is getting broken down. Glycogen. The glycogen which is there in the liver. Okay, glycogen which is there in the liver, it is broken down into glucose. The glycogen is getting broken down into glucose. See, look here once. Now, these counter-regulatory hormones like glucagon, epinephrine, cortisol, growth hormone, all this, what they are doing? They are coming and acting on the liver. So the glycogen in the liver will be broken down into glucose. But there is no use of this glucose. Because insulin is not there. All those glucose will start to go out in the urine. Okay, that is a glycogenolysis. The glycogen is getting broken down. The glycogen is getting converted into glucose. And the glucose is going out in the urine. So causing osmotic diuresis. Potassium disturbance is just by heart. Like, if I go into that detail, like, it will unnecessarily give you the confusion. See, potassium disturbance, why it will occur? Okay, as you are asking, okay, let me tell you. As you are asking, okay, I don't want to just say like, okay, let me tell you, guys. Why potassium disturbances occurs is, see, already the patient is having acidosis. See, protons are acids. Okay, protons are acids. The patient is having acidosis, right? So what your body will try to do? Okay, what your body will try to do is, your body will try to take these protons. So your body, what it is trying to do? Your cells will try to take these protons into the cell. Okay, that protons will go into the cells, because protons are also the acids. H plus is an acid. H plus proton is an acid. The patient is having acidosis. No, in the blood there is acidosis. pH is less. So your body, especially your RBC, will try to take this H plus into the cells. Okay, as H plus, one positive ion is going in exchange for H plus, potassium will start to come out into the blood. So that will cause potassium disturbances. Okay, So just that's it. Don't go too much deep into it. Okay. So potassium disturbances can also be seen. So what is the treatment? Our main problem is dehydration. The patient is getting dehydrated. Okay, so give him normal saline and say the patient, give him hydration. And all this problem is because of what? All this problem is because of the insulin, sir. Insulin is not there. Insulin is not there. So give insulin, that's it. So give IV insulin. So fastly give IV insulin along with hydration plus electrolytes. Okay, he's urinating. No, he's urinating. So he's losing the electrolytes. So insulin, hydration, and electrolytes is the treatment that is given. Simple treatment is insulin, hydration. Okay, insulin, hydration, and electrolytes. The moment you give the insulin, insulin inhibits the ketogenesis. Till the time insulin is there, ketone body production is not there. So the moment you give insulin, ketogenesis stops in the liver. Okay, done. Next, look at these two questions. The answers might be true or might not be true. You just look at these two questions. A 50-year-old man presents with a DKA. Yeah, DKA can also be seen in 50-year-old. True. He was started on IV insulin therapy. Yeah, we have given immediately IV insulin therapy. He is at a risk of developing which abnormality? See, when you give suddenly a lot of insulin, I said you, insulin moves the potassium into the cell. Insulin moves the potassium into the cell. The moment you give insulin, say here, insulin moves the potassium into the cell. All the potassium will go into the cells, will be packed into the cells. The patient might get hypokalemia. The patient might get what? All the potassium is moving into the cells. So the blood levels of potassium will decrease. Hypokalemia. After giving IV insulin, hypokalemia is going to be seen. Same here also. On administering insulin, which of the following events are first to occur? Potassium influx into adipocytes. Potassium goes into the cells. Potassium will move into the cells. That's the first thing to occur. Other things will also occur. Okay, but that's the first thing to occur. Okay, of course, glycolysis is going to be activated. Protein synthesis will be activated. This too, okay, true. But this is the first event to occur. This is the first event. Okay, so with this, insulin, one more important MCQ is there. Now, what is the most common cause of death? Most common cause of death in DKA. This is the question which was also tested in the exam. What is the most common cause of death in DKA? Any idea? Garima, excellent, Garima. Excellent, Garima is true. So that is cerebral edema. Why cerebral edema? See, our patient, especially these children, okay, especially in the children, the blood-brain barrier not properly developed. It's not properly developed. Already it's not properly developed. Upon which if the patient is having acidosis, that causes further damage to blood-brain barrier. Acidosis causes damage or leakage of the blood-brain barrier that will cause cerebral edema. Okay, acidosis, if the patient, already the patient is having acidosis, guys. Because of this acidosis, the blood-brain barrier will be damaged. When the blood-brain barrier, it's like a protective lining, right? It's like a protective lining. When the blood-brain barrier is damaged, that will cause edema in the brain. That is the cerebral edema. That's the most common cause of death, MCQ. This is FMG MCQ. Okay, most common cause of death in children, mainly. Okay, it is cerebral edema. So done. Chalo, let's go with the adrenal gland. We are almost at the end, sir. Next 1 hour, that's it. It will be completed. Any doubts? So don't worry about the sir, sure, okay, can we complete all these things? Don't worry about that. Just trust your teacher. All MCQs will be completed. All MCQs will be covered. But one thing which you need to manage is consistency. You are in your homes and universities, right? You will feel like, after some time I can watch this video. It's like, so much, if you are getting so much information, sometimes you'll feel like, bored or kind of. You need to self-motivate. I have to watch it. That's it. Oh, can you zoom? Definitely I will zoom it. No issue. I will zoom it. Now, adrenal gland. Now, that adrenal gland, where there are two regions, which is called as the adrenal cortex. Outside is adrenal cortex, and inside is adrenal medulla. Okay, so adrenal cortex, it is developed from the mesoderm. Okay, adrenal cortex, this cortex area, it is developed from the mesoderm, and adrenal medulla, it is developed from the neural crustacles. Adrenal medulla, this central area, the medulla, it is developed from the neural crustacles. Okay, just let me put this in a different way for your better understanding. Guys, have you ever heard that this adrenal medulla, what it will produce? Adrenal medulla, what it produce? Adrenaline, noradrenaline. Okay, adrenaline, noradrenaline. See, adrenaline, noradrenaline, they are also called as epinephrine or norepinephrine. Epinephrine, norepinephrine. Epinephrine, norepinephrine, they are the neurotransmitters, right? They are the neurotransmitters. Neurotransmitters are supposed to be produced by the neurons. Neurotransmitters are supposed to be produced by the neurons. Then how this adrenal medulla is producing the neurotransmitters? The answer lies here. Adrenal medulla, it is a neuronal in origin. It is derived from the neural cells. Actually, here the neuron cell bodies are present. That's why they are producing the neurotransmitters. So adrenal medulla is derived from the neural crystals. Adrenal cortex is developed from intermediate mesoderm. Okay, cool. Now let's discuss about the parts of the adrenal gland. Adrenal gland, cortex, the outermost part. Only I'm talking about the cortex. Cortex, there are three zones: zone 1, zone 2, zone 3. So that's, remember it as GFR. Mnemonic. Okay, GFR. What is this GFR? Outermost area is called as zona glomerulosa. The middle region is called as zona fasciculata. Okay, zona fasciculata. And the innermost region, this region is called as zona reticularis. So zona glomerulosa, fasciculata, and reticularis. Zona glomerulosa, it is going to produce what? It's going to produce mineralocorticoid called as aldosterone. It's going to produce mineralocorticoid. What is the example of mineralocorticoid? Aldosterone. Wait, now you'll get it out. Why aldosterone is called as mineralocorticoid? Why it is called as mineralocorticoid? Because it regulates the mineral balance. Which mineral? Sodium. It regulates the sodium levels in the body. And why it is called as a corticoid? Because it is coming from adrenal cortex. It is coming from the adrenal cortex. Okay. So aldosterone is called as a mineralocorticoid because it is coming from the adrenal cortex and it regulates the minerals in our body. Which mineral? Sodium. Zona fasciculata, it produces a glucocorticoid. What is a glucocorticoid? Cortisol. Okay, why cortisol is called as glucocorticoid? Because it is coming from cortex. So corticoid. Why it is called as a gluco? Because it regulates the blood glucose levels. Okay, cortisol increases the blood glucose levels. True. Via glycogenolysis, it increases the blood glucose levels. True. Okay, and zona reticularis produces sex corticoids. Which sex corticoids, sir? Male sex corticoids like DHEAs. Okay, dihydroepiandrosterone sulfate. Dihydroepiandrosterone S for sulfate. This is a question which was asked tested in the MCQ FMG exam. DHEAs is produced by adrenal gland. Okay, dihydroepiandrosterone sulfate is produced by zona reticularis. It's a sex corticoid. Why it is sex corticoid? It's a corticoid because it is coming from the cortex and it's going to regulate the sexual functions. It's an androgen. Okay, and androstenedione, it's also an androgen. These are all the androgens. Okay, these are the androgens. Now, these are the weaker androgens. Okay, but anyway, they are the androgens. What is the function of these androgens? These androgens are also present in the female. Adrenal gland is also present in the female. These androgens, what is the function? In females, में androgens का function क्या है? I'm asking you guys. Anyone? Can anyone tell me? Adrenal glands, I'm asking you. Adrenal glands are also present in female. Even in the female, DHEAs is getting produced. True. Androstenedione is getting produced. True. So female में androgen का function क्या है? Anyone? Yes, of course, androgens will be converted into estrogens, but androgens do have some function. Exactly, Mahima, yes, it's the axillary hair and pubic hair. Secondary sexual characters. Tell me secondary sexual characters like pubic hair, axillary hair, and libido. Libido. Okay, so right, the function of the androgens in the female are secondary sexual characters. Secondary sexual characters, sir. Like axillary hair. MCQ asked. Axillary hair, pubic hair. Okay, and these androgens, what they are responsible for? They are responsible also for what is that? Libido, sexual drive. Look at the desire for the sex is because of the androgens, not because of the estrogens. And don't say secondary sexual characters may breast development. Breast development is because of estrogen. Breast development is because of estrogen. Hair development is because of the androgens. And third one, these androgens in the female are also responsible for acne during puberty. During puberty, most of the females, most of you guys have the acne, right? And the acne is because of what? Androgens. Okay, done. And medulla. Let's come back to the medulla. So medulla is neural crest in origin. It's derived from the neural crest cells, and the cells which are present in the adrenal medulla, these cells are called as chromaffin cells. Okay. The cells in the adrenal medulla are called as the chromaffin cells, and these chromaffin cells produce what? Catecholamines like epinephrine, norepinephrine, and dopamine. Okay, mainly epinephrine, norepinephrine. So these chromaffin cells in the adrenal medulla mainly is going to produce epinephrine or adrenaline. Okay, so that's the thing. Chromaffin cells are present in adrenal medulla. Chromaffin cells are present in adrenal medulla. Neural crest in origin. They produces catecholamines like adrenaline mainly. Done. Okay. Now we have to discuss about this aldosterone, mineralocorticoid, and cortisol, glucocorticoid. Now chalo. So before this, take a white paper. Take a white paper, sir. This thing should be remembered 100% at least till the time of your exam. Lifelong, I don't say lifelong. At least till your exam. Remember this. At least till your PG exam. Remember this one point. Same. This is your adrenal gland. Who is getting produced? Aldosterone. Okay. Iska kaam kya hai? Now aldosterone is going to come and act where? Now can you tell me what I am drawing, sir, here? Okay, what is the structure that I'm drawing? So looking like a sperm that is like, doing some dance. It's bending and doing some dance. Is it sperm? Sperm cell? What is this? This is nephron. Nephron. So this is the last part of the nephron called as the collecting duct. Okay. This is the collecting duct. So on the collecting duct, there are two types of cells. Let me write here. Draw this with me. This is collecting duct. The last part is called as, this part is called as the last part. It's called as the collecting duct. Okay. So collecting duct may, there are two types of cells present. One is a principal cell. Principal cell. This PC means principal cell, right? Principal cell. PC means principal cell. Red color thing. Red color cell is intercalated cell. Intercalated cell. There are principal cells, intercalated cells. Now aldosterone, what it will do? Aldosterone will come and act on this principal cell and also act on this intercalated cell. Aldosterone acts on this principal cell and intercalated cell. True. How it will act? One thing, aldosterone. Aldosterone. It's a steroid. It's a steroid. Aldosterone, it's a steroid. Okay. So it will cross the cell membrane. Steroids cross the cell membrane. Steroid hormones cross the cell membrane. So aldosterone is coming into the cell. Okay. Aldosterone came into the cell. ALD. Aldosterone. ALD. Aldosterone. So right here, aldosterone, it's a steroid. Now wait, some students will have a doubt. Sir, steroid ka meaning kya hai? What is steroid, sir? Anyone? Steroid means what? Steroid ka meaning kya hai? Steroid ante enti. Tell me. No, steroid. Steroid means, okay, let me put it this way. Biryani is made up of what? Tell me. So biryani is made up of rice and chicken. Main two ingredients. So it's what is the ingredients? Raw material. Raw materials are like masala, rice, and like chicken, biryani. Okay. In the same way, steroid means a hormone which is derived from cholesterol. Okay, hormone which is derived from cholesterol. Cholesterol. Okay, steroid means a steroid hormone. Say estrogen, progesterone, testosterone. Right now, I'm discussing about the cortisol, aldosterone. All these are steroids. Steroid means first write this thing. This is the basic thing. Steroid means derivatives of hormones which are derived from cholesterol. Hormones which are derived from cholesterol. So when aldosterone is acting on this principal cell, what happens? Sir, the cells will reabsorb sodium. One positive charge is coming into the cell. Okay, when aldosterone is acting on the principal cell, okay, now what is happening? Sodium from the urine is getting reabsorbed. Sodium from the urine is getting reabsorbed with the help of a transporter called as ENaC, epithelial sodium channel. This green color channel name is called as ENaC, epithelial sodium channel. When aldosterone is acting on the principal cell, sodium is reabsorbed. One positive charge is coming into the cell. So what happens is one positive charge will go out. Potassium is excreted. Okay. So sodium is coming in, potassium is going out. Sodium is coming in, potassium is going out. This black color channel name is called as ROMK. Renal outer medullary potassium channel not needed. Simply remember ROMK. This green color thing is super important. With the help of epithelial sodium channels, sodium is getting reabsorbed and potassium is getting secreted. Now the same aldosterone, look, is also acting on the intercalated cell. When the aldosterone is acting on the intercalated cell, what happens? The cells will excrete protons. The cells will excrete protons into the urine. Repeat, the cells will excrete protons into the urine. So, three are the functions. 1, 2, 3. Okay. So aldosterone is acting on principal cell and intercalated cell. Aldosterone is acting on principal and intercalated cell. First thing done. So aldosterone have which receptors? Where the receptors are? Aldosterone receptors, where they are present? Aldosterone receptors are present in the cytoplasm. Aldosterone receptor, not in the nucleus. Thyroid hormone have intranuclear receptor, but aldosterone have intracytoplasmic receptor. Intracytoplasmic receptor. Aldosterone have intracytoplasmic receptor. So what are the three functions? Sodium reabsorption, potassium and proton excretion. Sodium reabsorption, potassium and proton excretion. Done. The same thing I'm going to show you here. Look at this. Aldosterone. Okay, even if you don't know, not an issue, no problem. So right now, say I'm talking about the principal cell, intercalated cell. Aldosterone, it's having its receptor in the cytoplasm. When it's acting its receptor in the cytoplasm, what happens? See, sodium is getting reabsorbed. See, sodium is coming into the cell. Make a correction. Sodium is coming into the cell. And potassium, it is going out of the cell into the urine. Potassium is going out of the urine. Okay. Now, when the same aldosterone, it also acts on intercalated cell. See, protons are getting secreted. Protons are secreted into the urine. So these three things here I have written. Aldosterone of actions, sodium reabsorption, potassium and proton excretion. Three functions done. Sodium reabsorption, potassium and proton excretion. Sodium reabsorption, potassium and proton excretion. Three functions. Okay. Now, little integration with the medicine. Medicine ka integration है very important. What is Conn syndrome? What is Conn syndrome? Conn syndrome means, draw a small image. Adrenal gland medulla. There is a tumor here. Okay, there is a tumor. What is this tumor called as? Adrenal adenoma. Adrenal adenoma. Okay. What it is producing? This tumor in the adrenal cortex, it is producing high levels of aldosterone. What it is producing? super high levels of aldosterone. Arey, now tell me, sir, in this Con syndrome में, okay, क्या है? High levels of aldosterone. High levels of aldosterone is there. Whenever there is high levels of aldosterone, what happens? Sir, more sodium is going to be reabsorbed into the body. More sodium will be reabsorbed. More sodium is getting reabsorbed means, sodium causes BP. So it causes high BP, hypertension, Con syndrome में. Whenever there is lot of aldosterone, potassium and protons will go out of the body. See, so potassium and protons are decreasing in the body. In the body, potassium is going out, protons are going out. As potassium is going out, that will cause hypokalemia. And as acids, protons are going out of the body. Protons are going out. So that will cause alkalosis. So the patient is going to have, in Con syndrome, the patient is going to have hypertension with hypokalemic alkalosis. Hypertension because of sodium reabsorption. Hypertension with hypokalemic alkalosis. Hypertension with hypokalemic alkalosis. Only these three clinical features I want you to know. Hypertension with hypokalemic alkalosis. Is that clear? Con syndrome. So zyada aldosterone hai. So in this condition, adrenal adenoma. Just wait. So Con syndrome means what? It's adrenal adenoma producing high levels of aldosterone. The patient is going to have hypertension with hypokalemic alkalosis. So what is the drug that we have to give? We have to give antagonistic of aldosterone. Who is the antagonistic of aldosterone? Spironolactone. Aldosterone antagonist spironolactone is a treatment. What is the side effect of the spironolactone? Gynecomastia. That's okay. Topic completed. Khatam. So Con syndrome treatment. For the treatment of Con syndrome, aldosterone. Okay, aldosterone antagonist. Okay, for the treatment, we are going to give aldosterone antagonist, that is called as spironolactone. Spironolactone side effect is gynecomastia. If you say, sir, it's clear, I will go forward. If you say it's clear, I will go forward. So close your eyes for me once. Close your eyes and think aldosterone. It's a steroid. Important point. Just listen to my words. Aldosterone. It's a steroid, sir. Aldosterone have cytoplasmic receptors. Important. Aldosterone have cytoplasmic receptors. Aldosterone ki how many functions here? 3 functions. Sodium reabsorption, potassium and proton excretion. Con syndrome में there is adrenal adenoma producing excessive aldosterone. Body में ज्यादा aldosterone है तो ज्यादा sodium absorb हो जाएगा. Lot of sodium is getting reabsorbed, which will cause BP, hypertension. More potassium and more protons will go out into the urine, leading to hypokalemic alkalosis. Done. Treatment, spironolactone. Simple. Khatam. See, it's simple. This is the medicine. Okay. So, aldosterone completed. Shall we discuss about the cortisol? Have bubble gum in your mouth because afternoon sessions will be little tricky because you guys have your lunch. You're going to have your lunch, right? So most of your energy, most of the blood supply will be taken to the gut, GIT. So your brain activity actually decreases, your concentration level decreases. Most of our energy will be utilized in the digestive purpose. So you'll feel little clumsy, okay, little like dizzy. So little sleepy. So have some bubble gum, have water, coffee, or tea. Okay. Chalo. Next, cortisol. Now, just give me 2 minutes. Don't write anything. Don't write. Don't take screenshots. Don't write anything. Just give me 1 minute. Because I will make this concept as easy as possible. A lot of information is there. All this is for first year students, not needed. Okay, done. Now cortisol. Sir, cortisol is a major catabolic hormone in the body. It breaks down everything. Okay, cortisol, right? Catabolic. It's a major catabolic hormone. Okay, cortisol. Thyroid hormones are catabolic. True. Cortisol is a catabolic hormone. True. So, regarding this cortisol, what you need to know? First, three things you need to know: carbohydrate metabolism, protein metabolism, fat metabolism. These are the three macronutrients. Carbohydrate metabolism, what it will do? It increases the blood glucose level. Simple, right? Cortisol, by causing glycogenolysis, gluconeogenesis, increase the blood glucose levels. True. Cortisol, catabolic hormone, so protein breakdown, so proteolysis. True. Proteolysis. Fat metabolism, it's a catabolic hormone, so lipolysis. Simple, done. Immune system. Sir, cortisol, what it is? Cortisol is a steroid. Okay, steroid. Steroids are what? Immunosuppressants. All the steroids will cause immunosuppression. That's why even after surgeries, even after transplant surgeries, we give steroids because to sleep, to make the immune system to go into sleep. Okay, so a cortisol, it is an immunosuppressant. It's an immunosuppressant. It suppresses the immune system. Okay. Next, blood cells. Cortisol, what it will do? It decreases all WBC. All WBCs will go down. WBCs are also part of immune system. No, all WBCs are going to go down except neutrophils and monocytes. Okay, except neutrophils and monocytes. All WBCs will go down except neutrophils and monocytes. They will go up. Okay, their levels will go up. And even RBCs will go up and platelets will go up. Okay, this is normal. This is normal. Okay, so cortisol decreases the WBC count except neutrophils and monocytes. This is the FMG question. Neutrophils will go up. Neutrophilia is going to be seen. When you inject cortisol, neutrophil levels go up. That's normal. Okay, heart. On heart, what is the function of cortisol? It increases the heart rate. Okay, plus increase the BP. Okay, by causing vasoconstriction, it increases the BP. True. Bones may. It stimulates osteoclast. Osteoclast is stimulated, so that will cause bone resorption. Okay, it will cause bone resorption, bone breakage. Osteoclast will do bone breakdown. Osteoblast, blast for building. Blast means it increases the bone formation. Here it is osteoclast. Clast causes bone resorption, means bone breakdown, not reabsorption. It is a resorption. Okay, so connective tissues. Connective tissues में क्या है? Collagen. So collagen breakdown. So connective tissues में cortisol is going to cause collagen breakdown. GI tract में, when cortisol is acting on your stomach, it increases the acid production. Okay, done. Reproductive system में, see cortisol is a stress hormone. Cortisol is a stress hormone. So during stress के time में, do you want the reproductive activity? Arey, you are in so much stress. Okay, 2 days, after 2 days you are having the exam, you are under so much stress, so you are going to think about the reproductive activity. So some of you will definitely, like, even the war you will think. So but usually saying cortisol, it inhibits GnRH release, inhibits FSH and LH. So first, cortisol, what it will do? It inhibits the reproductive axis. It inhibits GnRH, FSH, LH. Okay, their levels will go down. And cortisol is also responsible for pigmentation. Okay, it's also responsible for the pigmentation. Cortisol is also responsible for pigmentation, skin pigmentation. These are the normal functions. So my part is completed. My duty is completed. So normal I have explained. Normal things I have explained. Now you have to fill the abnormal. Okay, what if there is excessive cortisol? Right. What if there is cortisol excess? Cortisol zyada hai to. There's a lot of cortisol is there. Now let's write from here. Let's go from down. So normal cortisol causes pigmentation. Excessive cortisol in the body, that's called as which disease? Cushing disease or Cushing syndrome. Okay, In Cushing syndrome, there is a lot of cortisol. If there is a lot of cortisol, the patient is going to have what? Hyperpigmentation. Okay, the patient is going to have hyperpigmentation. Okay. So in Cushing syndrome, see the Cushing syndrome patient, he's having a lot of cortisol. Whenever there is a lot of cortisol, no FSH, no LH, the patient is going to have amenorrhea. The patient is going to have amenorrhea because total reproductive axis is going to be inhibited. In Cushing syndrome, lot of cortisol is there, so much acid is going to be produced, so much acid is going to produce, that's going to cause peptic ulcer disease. Peptic ulcer disease. Cushing syndrome patients are going to have amenorrhea, true. They are going to have hyperpigmentation. They are going to have peptic ulcer disease, true. So the collagen in the connective tissues is going to get breakdown. Collagen, the skin is going to get breakdown. So skin will become tight or skin will become loose. Or collagen, the protein in the skin is going down. Skin is going to become loose, not tough skin, not tight skin, loose skin. So that's going to cause what? That's going to cause stretch marks. Stretch marks. Also called as abdominal striae. Okay. Abdominal striae means the skin is stretching. And the collagen in the blood vessels, the collagen is also present in the blood vessels. Collagen is also present in the basement membranes of the blood vessels. When the collagen is getting broken down, the blood vessels also become very friable, very weak. And the blood vessels will easily break. The blood vessels will break. The skin is also very thin. So that will cause bruising. The skin is going to be having bruises, means the blood vessels are going to get a breakdown easily. That's going to cause bleeding into the skin. The patient is going to have bruising into the skin, like petechiae can be seen, purpura can be seen into the skin, bruising. Okay, and that's one of the important clinical feature. Cushing syndrome patients are going to have easy bruisability, bruising into the skin. Okay, stretch marks are going to be seen, peptic ulcer disease is going to be seen, amenorrhea can be seen, hyperpigmentation. And see, too much cortisol will cause too much activation of the osteoclast, that will cause osteoporosis. Okay, porous bones. Now here in Cushing syndrome, normal cortisol increases the heart rate and BP, but here too much cortisol can cause tachycardia plus hypertension. Tachycardia, hypertension, palpitations can be seen. Okay, possible. Tachycardia, palpitations, hypertension can be seen. Possible. So blood cells may. What happens? So how the blood is going to be? देखो blood में ज़्यादा platelets है अभी. Lot of RBCs are there. Lot of monocytes, lot of neutrophils. So number of cells are going to be increasing, especially platelets and RBC. More number of platelets and RBC going to make the blood viscous. So the blood will become hyper viscosity. This hyper viscosity is going to cause a deep vein thrombosis or pulmonary embolism. The deep vein thrombosis, and it can transform into pulmonary embolism. So because of the thick blood, viscous blood, so blood can clot into the veins. That's a deep venous thrombosis, and the thrombus can dislodge. And it can come into the lungs and leading to pulmonary embolism. So done. So half of the topic completed, half of the slide completed. The remaining half is there here. But before that, I want the clarity. Is it clear? In Cushing syndrome, patient is going to be at risk of DVT, true. Palpitations, tachycardia, hypertension can be seen. Osteoporosis, abdominal striae, bruisability, peptic ulcer disease, amenorrhea, and hyperpigmentation can be seen. Is it clear, guys? I'm asking you. Okay, chalo. So the other half here, let's say carbohydrate. So here the patient is having a lot of glucose in his blood. Okay, a lot of glucose is there. Okay, a lot of glucose is there. Now what happens is, here the patient's pancreas is normal. Remember, the patient's pancreas is good. He's not having diabetes. Now as there is a lot of glucose, what happens? His insulin levels are also going to be more. In Cushing patients, lots and lots of insulin is there. So this insulin, I have taught you, the insulin is going to cause adipocyte hypertrophy. Especially adipocyte hypertrophy is going to be seen, especially in face and central part of the body. Face and central part of the body, like trunk, like abdomen, central part of the body. So this is the reason. See, of course, lipolysis is happening, no doubt in that. Okay, some students will confuse. Of course, lipolysis happens, but in these patients, a lot of insulin is there. That insulin is going to cause the adipocyte hypertrophy. So they are going to have, because of that adipocyte, lot of adipocytes. The face is going to be something like this. Okay, so the patient, the Cushing syndrome patient, because of the adipocyte hypertrophy, the face is going to be moon face. Okay, the face is moon face. Okay, it's a moon face. Okay, look, I have said you the patient is going to have hyperpigmentation. Cushing syndrome, last point, the patient is going to have hyperpigmentation, hyper dark, like mucosa, hyperpigmentation. Okay, the patient is going to have abdominal striae. Okay, easy bruisability can be seen, and adipocyte hypertrophy can also cause this what hump? Buffalo hump. The patient is going to have buffalo hump. Okay, and especially see the moon phase, especially central part of the body is going to be obese. So this is called as centripetal, mean the center, centripetal obesity, centripetal obesity. Okay, especially in the center of the body, the patient is going to be obese, centripetal obesity. Look, next thing, proteolysis, right? The protein metabolism, muscles is getting broken down. So the muscles in the extremities, the muscles in the upper limbs and lower limbs, they are getting broken down. The muscles are going broken down. That will cause myopathy, muscle pains. The patient is going to have muscle cramps, pains. They will use the word proximal myopathy, proximal. It's also seen in hypothyroidism, but anyway. So proximal myopathy is going to be seen because the muscles are getting broken down. All the muscles are getting broken down. The bones are getting broken down. So do you know how this patient is going to look? Centripetal obesity can be seen. Okay. So in the center of the body, the patient is like this. But if you look at the extremities, they are very thin. The muscles are getting broken down. The extremities are getting thin. So this type of appearance is called as, see, the lemon. The central body is like a lemon, and the extremities are very thin, looking like a matchstick. So this is called as lemon standing on matchstick appearance. Okay, lemon on matchstick appearance is seen in Cushing syndrome. Lemon on matchstick appearance is seen in Cushing syndrome. Lemon on matchstick appearance is seen in Cushing syndrome. Normally cortisol, look, normally cortisol will cause immunosuppression, but too much cortisol will cause too much immunosuppression, leading to recurrent infections. That's it. Don't write anything here. It will confuse you. So Cushing patients are going to have hyperinsulinemia. High levels of insulin is going to be seen. That's going to be responsible for centripetal obesity. Proteolysis is going to happen. So that's going to cause proximal myopathies with a typical lemon on stick appearance. The patient is going to have lemon on stick appearance, and all these are the clinical features. With this, Cushing syndrome completed. Cushing syndrome bhi ho gaya. Chalo. Next topic is pheochromocytoma. Simple topic, pheochromocytoma. Okay. What is pheochromocytoma, sir? Okay, first let me take a confirmation from you. Is it clear? Abraham, don't worry about the slides, you will get everything. Like previous slide means Cushing syndrome, Abraham, you are talking about? This one? See, simple, but just once cross check. There is hyperviscosity. How a question is going to be coming in your exam? They will say 25-year-old female or 30-year-old female who is present at the clinic with a lot of hemorrhages into her skin. Okay, with a lot of hemorrhages into the skin. Previously, she had an episode of deep venous thrombosis. She's a known case of DVT. She's saying that she's having pains in her muscles. Okay, she's having joint pains. Why pains in the muscles? Because of the proteolysis. Proteolysis is going to cause a muscle pain. Why she's having joint pain? Because of the osteoporosis. She is also going to complain you that she is having pain in her stomach after meals. Pain in her stomach after meals because of what? Peptic ulcer disease. Okay, and she is not regular in her cycles. That's amenorrhea. And if you look at her mucosa, the mucosal surfaces are going to be dark. That's the hypopigmentation. So all these are the keywords. All these are the keywords. Bruisability, easy bruisability is one of the very important keyword, especially I have seen in the questions in exam, clinical questions. Okay, easy bruisability of the skin, hyper viscosity, all these are important. Are long back, 10 years back, they used to ask moon face, buffalo hump, lemon on stick appearance. These are very old key features. This slide is very important. Which count is going to increase? Neutrophils are increased, monocytes are increased, but all the other WBCs are going to go down. Okay. Chalo. Now let's discuss about pheochromocytoma. So what the hell is this pheochromocytoma? Simple. Now previously I have said you, if there is a tumor in adrenal cortex, if there is a tumor, that is Conn syndrome. That is Conn syndrome. You know, in Conn syndrome there is high levels of aldosterone. High levels of aldosterone is there. Conn syndrome. We have discussed. Now Abhi, where is the tumor? Now right now the tumor is present in the adrenal medulla. Okay, so where is the tumor? The tumor is present in the adrenal medulla, sir. Okay, so now this tumor is making excessive amount of epinephrine, norepinephrine. So this tumor is going to make what? It's going to make lots and lots of epinephrine and norepinephrine. So what is pheochromocytoma? It's a tumor of, right? It's a tumor of adrenal medulla. It's a tumor of adrenal medulla. So what is there in excess? There is excessive levels of catecholamines in this condition. Okay, look, this epinephrine, norepinephrine, or adrenaline, they are catecholamines. They are sympathetic neurotransmitters. They are the sympathetic neurotransmitters. So the patient is going to have all the sympathetic symptoms. The clinical features are going to be all sympathetic in nature. Now, lot of epinephrine is there. So that's going to cause what? Whenever there is a lot of epinephrine, that's going to cause vasoconstriction. That's going to cause vasoconstriction. So that's going to cause BP, hypertension. Look, so epinephrine, norepinephrine, they cause vasoconstriction. Because of the vasoconstriction, that causes increased BP or hypertension. Whenever the patient is having hypertension, that will present as headache mainly. Okay, hypertension is going to be seen, headache is going to be seen. So sympathetic symptoms. One of the sympathetic symptoms is profuse sweating. When you are sympathetically active, when you are in fear, epinephrine, norepinephrine, what they will do? They will cause sweating. Profuse. This patient is having sweating. Whenever you're in your fear, sympathetic symptom, palpitations are going to be seen. Tachycardia, palpitation. You can feel your own heart rate. Okay, you can feel your own heartbeat. Okay, that's a palpitation. And when you are sympathetically active, you are anxious. Okay, you are worried. You are anxious about everything. Okay, anxiety. When you are sympathetically active, I have said you, epinephrine, norepinephrine, what they will do? They will cause, here I have explained you, say, epinephrine, norepinephrine, they will act on the liver, causes the glycogenolysis, gluconeogenesis. That will cause breakdown of the glycogen stores. Your stores are going to get broke down. That will cause weight loss. Because you are not storing anything. You are not storing any fat. Everything is getting broken down. Glycogen is getting broken down. Lipids are also going to get broken down. That will cause weight loss. Weight loss. I have said epinephrine. Where? Just let me show you. Say epinephrine. Like epinephrine, norepinephrine, what they will do? They will increase the blood glucose levels. They increase the blood glucose levels. So that's why even pheochromocytoma, say the patient is going to have elevated blood sugar level. You just strike hypercalcemia not needed. In a patient who is having pheochromocytoma, the patient is going to have hypertension, palpitations, headache, profuse sweating, anxiety, weight loss, and hyperglycemia. Hyperglycemia. The blood sugar levels are going to be elevated. Then that's it. Pheochromocytoma. Physiology में 1 important point, excessive production of epinephrine, norepinephrine. Endocrine में, that's it. It's a tumor of adrenal medulla. Okay, tumor of adrenal medulla. Clinical features, sympathetic features. I have explained you. Clinical features are sympathetic features. Done. And FMG exam favorite question is how to put the diagnosis. Pheochromocytoma को diagnostic test FMG question. अरे, buddies, देखो इधर. So this is your adrenal medulla. Here there is a tumor. This tumor is making what? High levels of adrenaline or epinephrine. When you have high levels of adrenaline, okay, when you have high levels of adrenaline, This adrenaline, where it will go? Once its function is completed, adrenaline ka kaam ho gaya. So adrenaline will be going into the liver. Okay, it will be broken down. The adrenaline will be broken down, break down. In the liver, it's break down. Break down into what? The adrenaline will be broken down into substances called as metanephrines. And these metanephrines and also substances like vinyl mandelic acid, they will come out of the body through the urine. Now, in our condition, dekho. So there is a tumor in the adrenal medulla. So there is lot of adrenaline present. Lot of breakdown is going to happen. So in the urine, you will see high levels of metanephrines and vinyl mandelic acid. Okay. In the urine, if you see lot of metanephrines, lot of vinyl mandelic acid, you can think about maybe this is pheochromocytoma. Okay, maybe this is pheochromocytoma, and you can do the MRI of the adrenal gland. So what are the diagnostic tests? Collect the urine, measurement of 24-hour urine, measurement of 24-hour urine levels of metanephrines is the most sensitive test. Most sensitive, one of the NEET PG questions. The most sensitive test for pheochromocytoma is metanephrines. VMA means vinyl mandelic acid. So we'll check the metanephrine levels and vinyl mandelic acid levels. Okay. So the treatment. What is the treatment? There is a tumor, remove the tumor. Okay, so we are going to do the tumor removal. But the point is, when you are trying to remove this tumor, guys, listen carefully. When you are trying to remove this tumor, there is a 99% chance that this tumor is very friable, very very fragile, very soft tumor. There is a chance that it will rupture. Definitely it will rupture, and what it will leak? It's having lot of epinephrine and adrenaline. It's going to, at a time, it's going to release adrenaline into the blood. So during surgery, the patient is on the bed. The patient is on the bed. When you are trying to remove this tumor, there's a lot of chance it will rupture and release a lot of adrenaline. What this adrenaline will do? Adrenaline during surgery itself, it will come and act where? It will come and act on the blood vessels. It will come and act on its receptors. Now, when its receptors are getting stimulated, see, these are all the alpha-1 receptors on the blood vessel. This adrenaline will come and stimulate the alpha-1 receptors. So immediately what will happen to the blood vessels? The blood vessels will undergo vasoconstriction during surgery. Vasoconstriction leading to increased BP. There's a hypertension leading to heavy blood loss, and the patient will die immediately. Okay. So what I'm trying to put into your mind, during surgery, if you do the surgery to this pheochromocytoma, there is a chance that this adrenaline will go and stimulate the alpha-1 receptors. All this adrenaline will go and stimulate the alpha-1 receptors. The alpha-1 receptors, whenever they are stimulated, there will be vasoconstriction followed by hypertension. That can kill the patient. What you have to do? You have to, before taking him to the surgery, you have to close this alpha-1 receptors. You have to block this alpha-1 receptors with the help of a alpha blocker. So pre-operative, before surgery, administer alpha receptor blocker. Okay, it's alpha receptor blocker, non-selective alpha receptor blocker called as phenoxybenzamine. This is MCQ. Phenoxybenzamine, it is used, it's the alpha receptor blocker. It prevents the hypertension. Okay, it prevents the hypertension. So that's it. So pre-operative management of the pheochromocytoma is done with the help of which drug? Phenoxybenzamine, which is an alpha receptor blocker. Phenoxybenzamine is an alpha receptor blocker. Done. Pheochromocytoma completed. Shall I continue? Can you zoom? Okay. Definitely I will try to do it. I forgot. But anyway, sir, pheochromocytoma. Till here, is it completed? Sorry, not complete. It's complete, of course. So is it clear? So just see, we have discussed about the pheochromocytoma. Okay, clinical features, some important points. These are the images, the Cushing syndrome patient images, Cushing syndrome clinical features. aldosterone and Conn syndrome, its clinical features. Okay, hypertension with hypokalemic alkalosis. Okay, so diabetic ketoacidosis. All these things are not usually not usually taught in physiology. Like, of course they are taught, but not in clinical integrated way. I'm trying to do it as much as possible. Of course, even other faculty will do it, but from my side, I'm trying to do it as much as possible because a lot of questions will come from your exam. So the next condition is congenital adrenal hyperplasia. Congenital means by birth. Adrenal glands are bigger in size. Congenital adrenal hyperplasia. So congenital means by birth. Take a deep breath. Congenital adrenal means adrenal glands. Hyperplasia means big in size. Why by birth adrenal glands are bigger in size? Why by birth adrenal glands are bigger in size? Let me tell you something. Let me tell you something. I'm asking you a question. Generally, I'm asking you a question. See, let's take a female. Let's take one of your female, one beautiful female. Let's take her. Okay, right now, this 20-year-old female. Okay, let's take her. Now I'm trying to inject androgens into her body. Right now, she's 20 years. Now, right now, I'm trying to inject androgens into her body. Okay, now do you think she will become female? Sorry, she will become male. If I start to inject androgens into this female, okay, androgens, I'm giving her into her body. How do you think she will become male? She will turn into a male. What do you think? Bolo Mani, yeah, Jyoti, Vijay Krishna, yeah, everyone is saying no, and Vijay Krishna is saying yes. Do you think she will turn into female? She will turn into male? Yes, of course, she will turn into male, sir. Of course, it's all the hormones. It's all the hormones. Why a male is because of androgens. Let me tell you. See, the moment you start to give androgens into her body, she is going to develop. What she is going to develop? She is going to develop the mustache first. She is going to develop mustache and beard. Okay, male thing. Her voice is also going to be now male-like. Low pitch voice. She's going to develop the low pitch voice. Low pitch voice is a male voice, right? Low pitch is male voice. She's going to develop the facial hair. Okay, just that. She's going to develop male type of chest, broad chest. She will start to have the broad chest with atrophy of the mammary glands. Okay, the breast is going to get atrophy, and she's going to start to develop the chest hair. Okay, if you look at her, the muscles. If you look at the muscles, because of these androgens, she's going to have big bulkier muscles like a male. Okay, and not only that, the main thing, the reproductive system, the reproductive organs, the internal reproductive organs will start to undergo atrophy. Okay, and the external genitalia, if you look at the external genitalia, because of these androgens, what happens is the clitoris, whatever is there, the small clitoris, whatever is there, it will start to become enlarged. The clitoris will start to look enlarged and start to look like a micro penis. Okay, because of this androgens. If you give androgens 6 months, first dose 6 months, second after 6 months, if you are giving the androgens, that is called as a hormone replacement therapy. Okay, so she will start to look like a male. She will have the facial. She will start to have the male-like features. Okay, there will be development of the micro penis. Her labia major and her labia minora, the labia major and labia minora, they will start to fuse. They will start to fuse, and it looks like scrotum little bit. Yes, of course, true. Not complete. I am not saying that she's exactly going to develop the penis and she's going to develop the scrotum. I'm not saying that. So the changes will start to occur. Okay, you can watch the hormone replacement therapy videos on the YouTube. You can't even believe your eyes. Okay, you can't even believe that the person is a female. They will absolutely turn into males, like male-like. Okay, of course they will go with the surgery, plastic surgery for the organs, but they look like the males. So at the end of the day, the concept which I want you to know is, look, I will explain the concept now. When we are at embryo stage, see, this is embryo. Okay, I'm taking 2 embryos. One is a male embryo, one is a female embryo. Listen carefully. Why I'm saying this is a male embryo? Because it is having XY. Why this is female embryo? Because it's having XX. Okay, XX, XY. Because of the presence of this Y chromosome, on Y chromosome there is a gene called as SRY gene. Okay, this SRY gene, it codes for what? Testis. Testis is going to produce what? Testosterone. Androgen. It's going to produce. Okay, let me write androgen. Rather write testosterone. Let me write androgens. Androgen. Even other androgens also. Okay. Now, see, this male embryo, there is one special area. Okay, there is one special area. In the future, this special area is going to develop external genitalia. Even in the female embryo, see, even in the female embryo, the same area is there. Same area is there. There is this one special area. In the future, it will develop into external genitalia. In the future, it will develop into external genitalia. Now, what's happening? What's happening is, see, now in males, there is Y chromosome. Y chromosome is having a gene called as SRY gene. Males may SRY gene is there, SRY gene. Okay. SRY, see, males are having, males have to say so many sorries, right? Even in their genes are also having the sorry. Okay, for everyone, for everything. Sorry. Okay, so SRY gene is there. It codes for testis. Testis produces the androgens. See, these androgens will come and act on this area. The androgens will come and act on this area. When the androgens are coming and acting on this area in the future will turn into male external genitalia. Male external genitalia. But in female, there is no Y chromosome. As there is no Y chromosome, no testis, no androgens. As there is absence of androgens, this is important. The word is absent. The word is important. Absence. The absence of androgens, by default, automatically, this area in the future will develop into female external genitalia. Okay, it will develop into female external genitalia. What is the female external genitalia? That is vulva. Vulva, that is clitoris, majora, labia majora, and labia minora. Okay, so clitoris, labia majora, labia minora, mons pubis, like that, something like that. Okay, so it's the absence of androgens, not because of estrogens, not because of estrogens. It's the absence of androgens automatically makes this area to develop into female external genitalia. Presence of androgens converts this area in the embryo into male external genitalia. Male external genitalia. Okay, understood. For example, now imagine I'm a scientist. I'm doing some experiment. What is that experiment? Now, what I have did is into this female embryo from outside, I have injected androgens. From outside, what I have injected? Androgens. I have injected androgens. Now, if I inject androgens, though this is female, though it is XX female embryo, it will develop in the future. It will develop male external genitalia because of the androgens. If there is androgen, this female is going to take birth. If I give high levels of androgens, this female will take birth with a penis. True, no doubt in that. Okay, if you give high levels of androgens, absolute, based on the amount of androgens, if you give super high levels of androgens, exactly male looking genitalia will be seen, the penis and the scrotum. Of course, testis won't be there in that scrotum, but exactly male looking. Okay, or if I, in male embryo, see, this is XY. Somehow I have taken out the androgens. I have removed the androgens here. In the male embryo, I have removed the androgens. If I remove the androgens, do you know what happens? Though it is a male, XY, though it is a male, if I remove the androgens, the boy is going to take birth with vulva. Okay, the boy is going to have the mons pubis, clitoris, labia majora, and labia minora. So it's all the hormones, okay, which is responsible for the development of external genitalia. Androgens hai to male, androgens nahi hai to female, by default female. So this is the basic concept which you need to know to understand congenital adrenal hyperplasia. Okay, so shall I continue? We are almost done. Shall I continue? Yeah, it's like a pseudohermaphrodite. Next. See, what is congenital adrenal hyperplasia? What's the problem? Let me tell you. See, normal. First, let me tell you what is normal. You know this already. Sir, hypothalamus is going to produce CRH, corticotropic releasing hormone. Okay, corticotropic releasing hormone is getting produced from hypothalamus. The CRH will come to the anterior pituitary. Anterior pituitary में corticotropes are going to produce ACTH, you know it. ACTH comes and acts on adrenal gland. Now, adrenal gland, what it will do? When ACTH is acting on the adrenal gland, adrenal cortex, now for the first time, the cholesterol, see, this is the raw material, cholesterol will be converted into pregnenolone. Pregnenolone will be converted into 17-hydroxyprogesterone. Okay, 17-hydroxyprogesterone. Pregnenolone, 17-hydroxyprogesterone. Now, this 17-hydroxyprogesterone, for example, if you have 100 molecules, now out of this 100 molecules, almost 33% is going to convert into aldosterone. The other 33% is going to convert into cortisol. And remaining 33% is going to convert into sex hormones, androgens. Okay, so in equal proportions. So you have produced the mineralocorticoid, glucocorticoid, and sex corticoids. This is how all these hormones, aldosterone, cortisol, androgens, are produced from cholesterol. So all these three are the steroids. The point which I want you to know is the biochemistry point. For the production of aldosterone production के लिए and cortisol production के लिए, you need these two enzymes. These are the special enzymes. Okay, so 21 hydroxylase and 11 beta hydroxylase. 21 hydroxylase and 11 beta hydroxylase. Okay, 21 hydroxylase and 11 beta hydroxylase, they are required for the production of aldosterone and cortisol, but it is not required for androgens. Nahi chahiye. Okay, androgens ke liye that's not required. Okay, completed. Now, once you have enough amount of cortisol, what cortisol will do? Cortisol will give negative feedback. Okay, cortisol, what it is giving? Negative feedback. So negative feedback is given by cortisol. So this is normal, sir. Normal. Then what is congenital adrenal hyperplasia? Congenital adrenal hyperplasia, let me tell you. Now let me tell you the story. Congenital adrenal hyperplasia, these are not there. Okay, what is not there? Congenital adrenal hyperplasia, in congenital adrenal hyperplasia, there is a deficiency of 21 hydroxylase. That's the most common enzyme deficiency. This enzyme is not there. 21 hydroxylase deficiency or deficiency of 11 beta hydroxylase. These are not there. Whenever they are not there, there is no aldosterone, no cortisol. Whenever aldosterone, cortisol is not there, all the 100%, see, all the 100%, 17-hydroxyprogesterone is converted into, now this is all happening in the embryo stage. Now all the 17-hydroxyprogesterone molecules are converted into androgens. Now there is so much amount of androgens. Now what happens? Nothing will happen to a male embryo. But if this is happening in a female embryo, now think, if this disease is happening in a female embryo, now there is no aldosterone, no cortisol, unnecessarily lot of androgens are getting synthesized. All the 17-hydroxyprogesterone is converted into androgens. Now because of the higher androgens in the female, okay, because of the higher androgens in the female, now what happens? Now there is virilization. Okay, there is virilization, that is development of male external genitalia, male-like or male-looking. Okay, male-looking external genitalia. So male-looking external genitalia is going to be seen. Okay, so this is how, like, no, there is no clarity. Okay, is it a clitoris? Is it penis? What is it? You can't say. Is it labia minora or is it scrotum? You can't say. Okay, if there is too much amount of androgens, even it will be better. It will exactly form like a scrotum, and you can properly say penis. Okay, but at the end of the day, so this is actually a female, but looking like a male. See, it's looking like a scrotum. It's looking like a small penis. Okay, so there is ambiguous genitalia. Now you can ask me, sir, why we are discussing about this congenital adrenal hyperplasia? One thing, first, the number one reason is it's high yielding. Lot of times questions has been asked, and it's all about my hormones, endocrine. Aldosterone nahi hai. In congenital adrenal hyperplasia, please tell me which hormones are not there. aldosterone is not there, cortisol is not there. So glucocorticoid is not there, mineralocorticoid is not there. No glucocorticoid, no mineralocorticoids. Then who is there? Excessive androgens. Androgens are responsible for ambiguous genitalia. Okay. Now, why the name congenital adrenal hyperplasia? Why that name, sir? Because look, cortisol nahi hai, so negative feedback bhi nahi hai. Whenever there is no negative feedback, there is a lot of ACTH. Whenever there is a lot of ACTH, it is continuously stimulating the adrenal glands. So what happened to the adrenal glands? It becomes hyperplasia, adrenal hyperplasia. Okay. So negative feedback nahi hai. So a lot of ACTH is there that's stimulating the adrenal glands. So by birth, the baby, especially the female baby, is going to have the trouble, not the male baby. Mainly female baby is going to have this ambiguous genitalia. Again, due to deficiency of what? 21 hydroxylase or 11 beta hydroxylase. Most common is 21 hydroxylase deficiency. Okay, so in one of the exam, they have asked this in NEET PG exam. This question has been asked. See, lot of ACTH, lot of stimulation to adrenal gland. So lot of cholesterol will be converted into a lot of pregnenolone, and there will be a lot of 17-hydroxyprogesterone. The 17-hydroxyprogesterone levels will also spill into the blood. So in one condition, if you see this word 17-hydroxyprogesterone levels is elevated, that is CAH, congenital adrenal hyperplasia. So in congenital adrenal hyperplasia, the patient is going to have lots and lots of 17-hydroxyprogesterone. That is getting converted into androgens. So androgen levels are also going to be more. That is leading to this ambiguous genitalia. Is that clear? Simple topic, little interesting topic. A female is going to be converted into male. Female is going to be looking like a male. Okay. Same things will happen. Yes, true. Abra, yes, true. If a female will start to have the hormone replacement therapy, if a female start to inject herself with the testosterone, definitely, okay, she's going to have the male voice, like, her musculature differs, her chest is going to become like, the breast is going to get atrophy, the broad chest will occur, everything will change. Okay. So this is all about congenital adrenal hyperplasia, sir. See, lemon arm stick appearance is because of the centripetal obesity. Mainly, then Cushing syndrome, because of the hyperinsulinemia, high levels of insulin is there, right? That insulin is going to cause the adipocyte hypertrophy, especially in the face and in the trunk. We exactly don't know the reason why. If you ask me why only in face, why only in abdomen, we don't know. But because of high insulin levels, adipocyte hypertrophy will occur, which will cause moon face, buffalo hump, and centripetal obesity. Yeah, secondary sexual characters are going to change. Not the internal reproductive organs. Internal reproductive organs, they can never be changed. Okay, not the internal reproductive organs. The external genitalia, they will be changed. Okay. External genitalia, I'm talking about the external genitalia. They can be changed. Not the internal reproductive organs. Not internal reproductive organs. So, questions which was asked in the FMG exam. Look, in congenital adrenal hyperplasia, let me ask you. Can you tell me what is the main problem with the congenital adrenal hyperplasia? Main problem kya hai, sir? In congenital adrenal hyperplasia, what do you think is the main problem? Come on, guys. In congenital adrenal hyperplasia, I'm asking you, what is the main problem? Tell me. Someone is saying excessive androgen, more androgen. Main problem. This female is at a risk of death. Don't say external genitalia. The female doesn't know whether it's a male or female. It's a few days baby. Okay. The main problem is body ke andar. In body there is no steroids, no aldosterone, no cortisol, That's the main problem. What is the main problem is right now after the birth, the baby is not having steroids. So that can kill the baby. So this is the question. Look. Same. Important points is, what's the drug of choice? Lifelong, she have to take steroids. So mineralocorticoid is not there. She have to take the replacement. Glucocorticoids are not there. She have to take the replacement. So how much time? Lifelong she have to take. So congenital adrenal hyperplasia, baby. Doesn't matter whether it's a male or female. Doesn't matter. They do not have steroids. So they have to take steroids lifelong. Mineralocorticoid replacement is fludrocortisone. Glucocorticoid replacement is hydrocortisone. Okay. Next, laboratory findings also I have explained you. So laboratory findings is in these patients, 17 hydroxyprogesterone levels is elevated. That's one of the FMG question. Know this. Now, in congenital adrenal hyperplasia, see, female is going to look like a male. Female is going to look like a male. So that's why it's a female pseudo-hermaphroditism. It's the most common cause of female pseudo-hermaphroditism. So the most common cause of female pseudo-hermaphroditism is congenital adrenal hyperplasia, where a female falsely looking like a male. Pseudo means false. So female pseudo-hermaphroditism, female falsely looking like a male. Okay. These things. Okay, I said you what are the clinical features. Clitoris will be enlarged. It will become like it will look like a micropenis. Genital folds fuse, and labia majora will also fuse. Appears like a scrotum. Okay, all these things are going to be seen. Okay, let me highlight what are the important MCQs. This is the important MCQ. Steroids are lifelong. Laboratory finding is MCQ. CAH, most common cause of female pseudohermaphroditism, MCQ. And here 21 hydroxylase deficiency, MCQ. So done, sir, completed. So the last thing, calcium homeostasis. This table I'm not going to discuss here. This table will be discussed later. Not here, definitely not here. Okay, this table will be discussed in the renal. Not at all needed here. What is needed, I will tell you. Look. Take the heading. Calcium may, at least I will show you 6-7 questions. We will discuss about those questions. Wait. Calcium. Here, let's first take the topic, estrogens and osteoporosis. Estrogens and osteoporosis. What is this estrogens and osteoporosis, sir? Calcium regulation here also. Now, look here, guys. In your bones, so this is your bone. There are two types of cells present. This is osteoblast, like a good boy. And there is one more cell present. There is osteoclast. Okay. Osteoblast and osteoclast. So let me write here. Draw this. This is osteoblast and this is osteoclast. Now, what is the function of osteoblast? It's like a good boy. So osteoblast, blast for building. So bone formation. Okay, bone formation. Osteoclast, what it will do? Bone resorption. Bone breakdown. Bone resorption. Means breakdown. Old bone should be broken down and new bone should be forming. Actually, it looks like, see, osteoclast is like a bad cell. Okay, it's breaking down. It's breaking down the bone. It's breaking down the bone. But in reality, do you know who is the real villain? It's the real villain is the osteoblast. Okay, he is the real villain, sir. Osteoblast is the real villain. What he will produce? He's producing a chemical called as rank. Okay, he's producing something called as a rank ligand. Now this rank ligand, it's going to come. It's going to act on its receptor. The rank ligand will come and act on its receptor. So then only this osteoclast will work. Then only they will work and causes the bone resorption. Okay. So osteoblast produces something called as rank ligand. And these rank receptors, this is what? This black color thing is the rank receptor. This is the receptor, rank receptor. Rank receptors are present where? Rank receptors are present on osteoclast. Okay. So it's the osteoblast who determine the activity of osteoclast. Okay, it's the osteoblast decides the activity of osteoclast. Okay. Now, during reproductive age, like 20, 30, 40s. Okay, 20s, 30s, and 40s, and like at the end of the 40s. During reproductive age, a female is not going to complain about the joint pains or body pains. But once she is into her 50s and into her menopause, she will start to complain about, sir, I'm having body pain, backache, joint pains, all this stuff. So why during reproductive age she is not having any pains? Because let me tell you, during reproductive age mein, she's having a lot of eggs. This is the ovary. Imagine this is the ovary. She's having lot of eggs. Lot of eggs are there in her basket. So lot of eggs are there. These are the follicles. Eggs are nothing but the follicles, right? Okay, oocytes. So in the ovary, lot of oocytes are there, and follicles. Oocytes surrounded by the granulosa cells. Now, during reproductive age, we know these follicles produce estrogens. Estrogens, what they will do? Estrogens act on bone marrow. Important point, bone marrow. Stromal cells. Bone marrow mein cells are called as bone marrow stromal cells. These bone marrow stromal cells are going to release a substance called as, important substance, like a beautiful girl, called as osteoprotegrin. Osteoprotegrin. Okay, osteoprotegrin. Okay. Now let me ask you one question. So imagine there is a boy. For example, you are in your university, right? You are in your university right now. After the university time, you have to go back to where? You have to go back to your flats. Okay, you have to go back to your hostel. Now there is, imagine this boy is there. Okay, this boy is there. Now, when he came out of the university, there is this one beautiful girl who is standing out. Okay, there is this one beautiful Russian girl who is standing out, and she is calling him. Okay, come with me. Okay, let's go and have, like, date. Let's go and enjoy. She's saying, do you think this boy is going to go back to his hostel? Do you think he will go back to his home? Definitely, he's not going to go back to his home. In the same way, the rank ligand have to go and stimulate the rank receptor. That is normal. But in the presence of osteoprotegrin, it's like a beautiful lady. Now this rank ligand will be inhibited. The rank ligand will go to the osteoprotegrin. Okay, it's not stimulating the rank receptor. So when the rank receptor is not stimulated, now the cell is crying. It's not activated. So this rank ligand, where it is going? The rank ligand will go to the osteoprotegrin. So the rank ligand is inhibited. Now the rank ligand is not coming to the osteoclast. So this is why during reproductive age, osteoclastic activity is less and bone resorption is also less. Okay, because what? Because of what? One thing, estrogen. Estrogen acts on bone marrow stromal cells. Bone marrow stromal cells produce osteoprotegrin. Osteoprotegrin inhibits. Okay, let me write osteoprotegrin inhibits. Let me take out the arrow. Inhibits rank ligand. So osteoclastic activity is less and bone resorption is also less. Okay, done. But after menopause, okay, during menopause, like what's going to happen during menopause? What happens, sir? All eggs are completed. Menopause means now all her eggs are gone. She is not having any more eggs. So what happened to the estrogens? Estrogens are gone. Estrogens are not there. So what happened to osteoprotegrin? Osteoprotegrin is not there. When osteoprotegrin is not there, inhibition is also not going to be there. So rank ligand will go and stimulate the rank receptor. So during menopause, what happened to the osteoclastic activity? Osteoclastic activity increases, bone resorption increases. Bone resorption increase means what? That will cause osteoporosis. So this is why osteoporosis is going to be there in menopausal females. This is why osteoporosis is going to be seen in the menopausal females. That's it. So all this story may one question is there. I will ask you the questions. You just try to answer them. Okay. So repeatedly asked in even the recent FMJ question. The question has been asked from the this area. First questions. Let me check whether you can answer or not. Osteoprotectins are produced by which hormone? Osteoprotectins are produced with the help of which hormone? Osteoprotegrin. Estrogen. Estrogen. Okay. Rank receptors are present on which cells? Rank receptors are present on. Rank receptor. Osteoclast. Rank ligand is produced by which cell? Rank ligand. Blast. Osteoblast. Okay. Osteoblast. Next. Osteoclastic activity is regulated by which cells? Osteoclastic activity is regulated by which cells? Osteoblasts. Okay, don't forget. Osteoblast control the osteoclastic activity by producing rank ligand. Let me see who can answer this. I haven't taught you this, but let me see who can answer this. Osteoblastic activity is regulated by which hormone? Osteoblastic activity is regulated by which hormone? Who activate osteoblasts? Who activate osteoblast? Blast. Who activates osteoblast? I haven't taught you this. Osteoblastic activity, one hormone is there, and that's a high yielding MCQ. Excellent, Pawan. Meena, you are true. It's a parathyroid hormone. It's a osteoblastic activity is activated by parathyroid hormone. So parathyroid hormone in low quantities, actually in normal physiological levels, parathyroid hormone activates the osteoblast. So osteoblastic activity is regulated by parathyroid hormone. Okay. So now let's see important MCQs. See, I have explained you already this. See, the estrogens are going to act on bone marrow stromal cells. So bone marrow stromal cells produce osteoprotegrin. Osteoprotegrin. What it will do? Osteoprotegrin inhibits. Okay, osteoprotegrin inhibits rank ligand. You know it, right? So osteoclastic activity decreases, bone resorption decreases. You know the story. Now, MCQs, during menopause, yes, during menopause, more osteoclastic activity during menopause. See, after menopause, osteoprotective effect of estrogen is lost because estrogens are gone. There are no more estrogens. Estrogens are gone. So the female is going to have osteoporosis and fractures. What are the most common fractures? Very, very important MCQ. The most common fractures are vertebral compression fractures. The most common fractures during menopause, you should ask all your mothers and grandmothers that have take care about the waist, especially the lumbar vertebrae. Okay, have a LS belt, lumbosacral belt, waist belt to prevent the fractures. Okay, so the most common fractures are going to be vertebral compression fractures, especially lumbar vertebral. Okay, lumbar vertebral. Don't bear more weight. Ask your mothers and grandmothers not to bear more weight. Don't lift more weight. Otherwise, the vertebra will be compressed and fractured. Okay, so vertebral compression fractures most common. The second most common fractures are the wrist fractures. That's the Cooley's fracture, the wrist fracture. First common, second most common. Okay, done. So how to treat this condition, osteoporosis? Now we know the culprit cell here, who is causing the bone resorption. Who is causing the bone resorption? The bone resorption is done by osteoclast. So let's kill the osteoclast. So the bisphosphonates are the drugs. Okay, there are a group of drugs called as the bisphosphonates, like alendronate, ibandronate, zoledronate, pabindronate. Okay, these drugs. Okay, alendronate, ibandronate, pamidronate. These are the drugs. What they will do? They will cause apoptosis. Okay, they are going to kill, sure shot kill. Okay, they are going to kill the osteoclast. Okay, so these are the first line drugs in the treatment of osteoporosis, or you can even say that the drug of choice. Okay, they are the drug of choice for osteoporosis. These phosphonates are the drug of choice. Done. In one of the FMG exam, they have asked one of the rare side effect, but the serious side effect of this bisphosphonate is it can cause necrosis of the jaw, osteonecrosis of the jaw. Okay, bisphosphonate side effect is osteonecrosis of the jaw. Now, look, let me ask you one thing. Second, all this problem is because of what? Estrogens are going down during menopause. Estrogens nahi hai. Estrogens nahi hai to osteoprotectin bhi nahi hai. So osteoprotectin is not there. So all this problem is because of estrogens are not there. So why can't we give estrogens? So 50 years back, scientists thought, okay, in the early 1900s, not 50 years back, almost like, it's almost 75 years back. See, in the early 1900s, scientists thought, okay, let's give back the estrogens. Let's give back the estrogens. So actually it worked. Estrogen, when they give back the estrogens, osteoporosis is treated. But when you give, nature have decided to remove the estrogens. Nature have decided to remove the estrogens. When you give back the estrogens, that increases the risk of breast cancer. That increases the risk of what? Breast cancer. It increases the risk of uterine cancer or endometrial cancer. Okay, uterine cancers, endometrial cancers. So now we have to use estrogens. Yes, we have to use estrogens, but that estrogen should only act on the bone. So we use what? Selective estrogens. SERMs. Now to this 50-year-old woman, we have to give SERM. What is SERM? It's a selective estrogen receptor modulator. Okay, modulator. It's a selective estrogen receptor modulator. We are going to give the SERMs. Don't think that we are going to give the sperms. No, to that 50-year-old woman, we are not giving any sperms. It is SERM, selective estrogen receptor modulator. Example is raloxifene. So what is the something important about this? It acts like estrogen only on bones. That's it. It acts like estrogen only on bones, not on the breast and uterus. Okay, so that's it. It exhibits estrogen-like action on bones. Okay, but antagonistic action on breast. It doesn't act like a estrogen. It's like estrogen blocker on breast. Okay, so do not increases the risk of endometrial cancer or breast cancer. It do not increase the risk of. Okay, so the selective estrogen receptor modulators do not increase the risk of endometrial cancer or breast cancer. It's a selective estrogen receptor modulator. Done. So these two things I want you to know. Drug of choice for the osteoporosis is bisphosphonates, and you can also use selective estrogen receptor modulators. And see, just like that beautiful lady, osteoprotectin. Osteoprotectin is the right osteoprotectin. I have said you, that beautiful Russian girl. Okay, just like that, in the pharmaceutical industry, we have manufactured a drug which is called as a denosumab. So what is denosumab? It's MAB. MAB stands for monoclonal antibody. MAB stands for what? Monoclonal antibody. What it will do? It inhibits rank ligand. Okay, just like osteoprotectin inhibiting the rank ligand, this denosumab, which is a monoclonal antibody, it also inhibits the rank ligand. Okay, that's it. This is also used for the treatment of osteoporosis. Okay, osteoporosis treatment ke liye, yes, you can use denosumab too. And last and final drug which I want you to know is there is a drug called as a strontium ranelate. This strontium ranelate, for example, see, this is SR, strontium ranelate. It is having two hands. With one hand, it activates osteoblast. With the other hand, it inactivates osteoclast. See, this is good, actually good. The osteoblast need to be activated so that there will be bone formation. And osteoclast need to be inactivated. So what happens? Bone resorption decreases. So there is only such one drug, that is strontium ranelate. See, it inhibits bone resorption as well as it stimulates bone formation. Okay, so this is the one drug which can be used. Strontium ranelate. Okay, strontium ranelate, denosumab, SERM, that is raloxifene, selective estrogen receptor modulator. Okay, and bisphosphonates are the drug of choice for osteoporosis. I don't want to go into teriparatide, just leave it. You can study it in pharma. So with this, endocrine physiology, whatever is there in your book, it's completed. Okay, whatever is there in your book, endocrine physiology, it is done, sir. Okay, whatever is there in your book, it's all done. Now, is there anything left over in the endocrine physiology, sir? Endocrine physiology, a topic is left over. A small 5 minutes topic is left over. That is the secondary messengers, hormones and their secondary messengers. How to diagnose congenital adrenal hyperplasia in males? Same, 17-hydroxyprogesterone levels are going to be super elevated. The patient is going to have a severe hypotension. Congenital adrenal hyperplasia in males, the patient is going to have, see, congenital adrenal hyperplasia means what? high levels of androgens are going to be there. So male is going to have super high levels of androgens. Beyond the normal limits, high levels of androgens is going to be there. Same 17-hydroxyprogesterone levels are also going to be more. Okay. Aldosterone is not there. When aldosterone is not there, sodium levels will be less, potassium levels will be more. Okay. So based on that, we will put the diagnosis. So till here, is it clear? Till here, is it clear? Come on, I want the response from all students. All students, please give me the response. If you have any issue, you can always say me. All clear. Okay, done. Let me ask you questions. A few questions. Quickly, let me see who can answer. Quickly. 17-hydroxyprogesterone levels are checked in diagnosis of which condition? 17-hydroxyprogesterone levels, CH, excellent. With S, true. Congenital adrenal hyperplasia. In congenital adrenal hyperplasia, which enzyme is deficient? In congenital adrenal hyperplasia, is 21 hydroxylase. That's the most common enzyme deficiency. True. So, in pheochromocytoma, there is a tumor of adrenal cortex or adrenal medulla. Pheochromocytoma. Pheochromocytoma, there is a tumor of adrenal medulla. Okay. Adrenal adenoma is seen in Iqbal, yes, you are true. It is Conn syndrome. In Conn syndrome, there is adrenal adenoma. That's seen in the adrenal cortex. Okay. Which hormone have intranuclear receptors? Which hormone have intranuclear receptor? Intranuclear. Intranuclear receptors. Intranuclear thyroid hormones. Thyroid hormones, T3 I have said. Thyroid hormone have intranuclear receptor. Aldosterone have intracytoplasmic. Never ever forget. Okay. Just write this 1 point. Write it. Intranuclear receptor means receptor inside the nucleus. Sex with T3, T4. Okay, sex with the T3, T4. So what is the sex with the T3, T4? See, like the sex is an activity which should be done in a very confined space, right? You are not going to do it on the roads. It should be done in a proper confined, like private space. So in a cell, the most private area is what? Nucleus with a lot of DNA and genes. Okay. So remember it like this. So intranuclear receptors, sex with T3, T4. What is this? Sex hormones. Okay, sex hormones, estrogen, progesterone, sex hormones, vitamin A, and T3, T4. T3, T4, these are the thyroid hormones. So sex hormones, vitamin A and T3, T4, they are going to have the intranuclear receptors. Okay, don't forget this. This is one of the mnemonic. Sex with the T3, T4, sex hormones, vitamin A, T3, T4, they are having intranuclear receptors. And some books mention even vitamin D also. So, intranuclear receptors for sex hormones, T3, T4, and vitamin E and D. Done. That's it. So I want you to take a 5 minutes break, a 5 minutes simple tea break. Have it, and let's continue with the other system, total other system. Endocrine, a few important topics are there. I will discuss that, and later on we are going to jump into the new system. Okay. Now the time is 4 o'clock, right? Exactly 4 o'clock, right? 4:02. So okay, take 4:10 till 4:10. Till 4:10. Okay. I'm trying to do it as much as like possible. Zooming. Okay, I will do it. Which system next, sir? Which system next? I don't want to go into a bigger system because already endocrine is it's one of the biggest system. So I will go with a small system. That's the GIT. I will go with the GIT. Okay. The next system is going to be GIT. Now break till it's 4:02. So 4:02 means we can start 5 minutes break. 4:07. So okay, let's take 4:10 till 4:10 till 4:10. Break till 4:10. After break, I will explain you about the secondary messenger system, and after that GAT.
So Shashank, 10 minutes break is completed. Hello guys. Still connection is there. So you can see me, right? Okay. No. Okay. So take this heading, secondary messengers. So secondary messengers means, see, for most of the hormones, okay, let me take a white paper and show you. See, most of the hormones, they cannot cross the cell membrane. For example, see, there is hormone X. So imagine it's a peptide hormone. Peptide. Okay, which is a peptide hormone. It's not a steroid hormone. It's a peptide hormone. So it cannot cross the cell membrane to show its effects. It cannot cross the cell membrane. So it's going to act on the receptor. This hormone is going to act on the receptor. Okay. When it is acting on the receptor, now when this receptor is stimulated, now inside the cell, secondary messengers are going to be produced. Secondary messengers are going to be produced. For example, like there is production of CAMP or CGMP or IP3, inositol triphosphate. So these are all the secondary messengers. These secondary messengers will further do their duty. Okay. So hormones, when they act on their cell surface receptors, when their cell surface receptors are stimulated, inside the cell, secondary messengers are produced. These secondary messengers will further continue their work. They will continue their work. Okay. So which hormones uses CAMP as their secondary messenger? And which hormones uses CGMP? Which hormones uses IP3? That's the question. Direct questions, straightforward questions. Okay. Now, let me start with the CAMP. See here, come to this slide. CAMP, look. Same. CAMP will be used by anterior pituitary hormones. See, it's very easy. Anterior pituitary hormones. Which anterior pituitary hormones? See, it's all HH things. H, FSH, LH, ACTH, TSH. Okay. So I used to like, it's like a rhythm. FSH, LH, ACTH, TSH. Okay. FSH, LH, ACTH, TSH. So these hormones. So ACTH, FSH, LH, all these hormones will increase the CAMP levels inside the cell. Okay. Which other hormones? Parathyroid hormone. And other hormones like glucagon, antidiuretic hormone, when it acts on its V2 receptor, V2 receptor, and histamine here also, H2 receptor, and beta HCG, okay, beta HCG, epinephrine, norepinephrine, they are all going to increase the CAMP levels inside the cell. Okay, which hormones uses? So let me write here one by one. Which anterior pituitary hormones? FSH, LH, ACTH, and TSH. These anterior pituitary hormones. Apart from that, parathyroid hormone also uses or increases CAMP, glucagon, antidiuretic hormone, when it acts on V2 receptor, it increases the intracellular levels of CAMP levels, intracellular CAMP levels. Histamine, when it acts on again H2 receptor, histamine acting on H2 receptor, increases the CAMP levels. Okay. Beta HCG uses CAMP as its secondary messenger, and epinephrine, norepinephrine. So these hormones uses CAMP as their secondary messenger. If you still feel like, sir, I have better memory, I can still remember the things, then I remember CRH and GHRH, growth hormone releasing hormone, and corticotropic releasing hormone. These are the hypothalamic hormones. These hypothalamic hormones. So corticotropic releasing hormone and growth hormone releasing hormone.
Corticotropic releasing hormone, growth hormone releasing hormone. Okay, CRH and growth hormone releasing hormones. They increases the intracellular CAMP levels. Okay, done. CAMP का story हो गया. So let me write here CRH and growth hormone releasing hormone. Done. Okay. Next, CGMP is the secondary messenger, which is used by simple nitric oxide and atrial natriuretic peptide. That's it. Completed. Look, atrial natriuretic peptide and nitric oxide. These two uses CGMP as their secondary messenger. Okay. Done. And last secondary messenger. The last secondary messenger is IB3. Inositol triphosphate. Okay, let me write here. Inositol triphosphate. This inositol triphosphate is used by. I used to remember when I was a student. I used to remember. Say, inositol triphosphate. Where it is used? Any place wherever there is contraction or constriction. Okay, wherever or any hormone which is causing the contractions or constrictions, there IP3 is used as a secondary messenger. For example, look here. See, oxytocin causes what? Uterine contractions. Oxytocin causes uterine contractions. Okay. Antidiuretic hormone, also called as vasopressin, causes vasoconstriction. Antidiuretic hormone. When it acts on V1. Okay, V1, don't confuse. Here it is V2. Antidiuretic hormone, when it acts on V1 receptors, causes vasoconstriction. Again, constriction is coming. Histamine causes bronchoconstriction. Okay, histamine, when it acts on H1 receptor, causes bronchoconstriction in the lungs. Angiotensin 2, in the name itself, is there angiotensin means it causes vasoconstriction. Okay. So the important points which I want you to know is, come on, let's write here. So IP3, it is used by oxytocin, angiotensin 2, antidiuretic hormone acting on V1 receptor, histamine. These are the important things. At least these four I want you to know. So gastrin causes GI contraction. Gastrin. Contraction of stomach. Gastrin. GI contractions. Okay. Oxytocin, uterine contraction. Angiotensin 2, vasoconstriction. Antidiuretic hormone causes vasoconstriction. Histamine causes bronchoconstriction. Gastrin causes contractions in the stomach. GI contractions. So that's it. These are the secondary hormones and these are the secondary messengers. Secondary messengers and hormones. Secondary messengers and their hormones. So first, let me take these two slides. Okay. Let me take these two slides. Copy. Let me paste in the beginning of our endocrine. Okay, paste it. Okay, in our PPT also it is pasted. So with this, I am closing the endocrine physiology. Okay, a lot of questions, not just from the endocrine physiology, also a lot of questions will be coming from your medicine and patho related topics. Okay, done. So now let's begin with the gastrointestinal physiology. I'm just stopping the screen share for a minute. I just want to download the files from my personal Telegram. So I'm just stopping the screen share. Just wait for a minute. I'm sharing the screen. 3, 2, 1. Now by this time you should be able to see the screen. Is it clear? I think you should be able to see the screen now. See, if you have any doubts, please post it in the chat box, not in the Q&A session. Okay, please post it in the chat box. So, chalo. Gastrointestinal physiology. See, every student knows. First, let's start with the basics. Every student knows how many layers are there in the JT. So there are 4 layers in the JT. Okay, there are 4 layers in the JT. So make this diagram. If I do the cross section of your JT anywhere, okay, if I do the cross section, the innermost layer that you are going to see is called as what? Mucosa. The innermost layer is called as a mucosa. Okay, mucosa, it is surrounded by, following the mucosa, what do you have? What is this? This is submucosa. Okay, red color is mucosa, blue color is submucosa, and following that there is one more layer, that is, for example, here submucosa is surrounded by this green color layer, that is muscularis, and the outermost layer, which I am showing here in the yellow color, that is called as what? Serosa. So these are the 4 layers in the GIT. Everywhere in stomach, intestines, everywhere it's there. But one important point about the serosa is absent in right. Absent in esophagus. So serosa is absent in esophagus. And one more important point is, out of all these 4 layers, which layer do you think is the strongest layer? Which layer do you think is the strongest layer? Which layer do you think is the strongest layer? Submucosa is the strongest layer. Okay, so submucosa is the strongest layer, right? So look here in this diagram once, guys. Whatever I'm showing you, the total thing, whatever I'm showing you, all this thing, this is your mucosa. This is the mucosa. Okay, following mucosa, what is this? This is the submucosa. This whitish color layer is the submucosa, followed by muscularis. This is the muscle layer, muscularis, and last, this white color is the serosa. Okay, there are 4 layers in total. Now let me show you in my diagram. Just wait. Okay, first let me show you here itself. Guys, look at the mucosa once. Look at the mucosa here. A mucosa, you know? This is the mucosa. The innermost layer is called as mucosa. This is the mucosa. See, even in mucosa, further there are 3 layers. There is epithelial layer. Okay, even in the mucosa there is epithelial layer. Okay, there is lamina propria. Here it is a lamina propria, and there is muscle layer also present. See, there is a thin band of muscle, thin muscle layer is present. That is called as what? That is called as muscularis mucosae. Aha, okay. Even in mucosa, there are 3 sublayers present. Mucosa mein 3 sublayers are present. What are they? Epithelial layer, lamina propria, and muscularis mucosae. So, sir, if you ask me, sir, do we have to remember this? Not every point, but one thing is important. This muscularis mucosae is important. Now, most of the students will think, if I ask you, can you tell me what is the function of this muscularis mucosae? Okay, tell me. I'm asking the students, can you tell me what is the function of this muscularis mucosae? It helps in what? Can anyone tell me what is the function of the muscularis mucosa? Can anyone tell me what is the function of muscularis mucosa? Anyone? Can anyone tell me what is the function of muscularis mucosa? See, yeah, students are answering. Yeah. Maria, you are saying peristalsis, muscularis mucosa is going to cause the peristalsis? Absolutely not. That's the point which I want you to know. Okay, that's the point which I want you to know. It doesn't cause any peristalsis. It's not involved in peristalsis because this is the mucosal layer. It is not involved in peristalsis. See, these muscles are involved in peristalsis, but not this muscle, not this muscle. So, right, muscularis mucosae is not involved in peristalsis. So, in this table, I have written about the mucosa. Mucosa is the innermost layer. It is having further 3 layers are present. The epithelial layer, lamina propria, and muscularis. mucosa. Okay, muscularis mucosa. This muscularis mucosa is not associated with peristalsis. Submucosa is the strongest layer. You already know it. Don't write again and again. Submucosa is the strongest layer. In the submucosa, neurons are present, nerves are present. Okay, in the submucosa, neurons are present. I will show you those neurons. Nerve plexus. Okay, almost 100 trillion, not billion, 100 trillion neurons are there. Okay, in our GIT, so much neurons are there. So many number of neurons are there. So this neuron are called as, these neurons are called as the mesenteric plexus. Let me show you. Please look at here, sir. Please look at here. In the submucosa, are you able to appreciate? Say, this is the submucosa layer, right? In the submucosa, please look. Neurons are there. These yellow color wire-like structures, what are they? They are the plexus, nerve plexus, network of neurons. Okay, these are the network of neurons. So this network is called as the mesenteric plexus. Here I have written the submucosal plexus are mesenteric plexus. And same even in this muscle layer also. Look here. Even in the muscle layer, you can see this plexus. Then what is this plexus called as? So this plexus is called as myenteric plexus or Auerbach plexus. Okay. So come to our table. Submucosa is the strongest layer. Okay. It contains nerve plexus called as mesenteric plexus. Mesenteric plexus का function क्या है? Mesenteric plexus helps in secretions. Mucus secretion, like all the secretions, mucus secretion, acid secretion, okay, bile secretion. All the secretions are under the control of intestinal secretions, pancreatic secretions. All the secretions are under the control of mesenteric plexus. So mesenteric plexus helps in secretions. In the muscle layer, muscularis layer, look. In the muscularis layer, there is which plexus? Only write this 1 point enough. There is Auerbach plexus, also called as myenteric plexus. It helps in contractions, GI peristalsis or GI motility. Auerbach plexus helps in peristalsis. Auerbach plexus or myenteric plexus present in muscularis layer. Muscularis layer. Don't write all these points. Not needed. Not needed. Okay. And serosa, the final layer, it is absent in the esophagus. That's it. That's it. Now I'm going to ask you some questions. Okay, I'm going to ask you some questions. See, how many neurons are there in myenteric plexus and mesenteric plexus? Almost 100 trillion neurons are there. So that's why this enteric nervous system, this mesenteric plexus and myenteric plexus, this is called as the little brain. Okay. See, there are, let me write here, enteric nervous system, which includes what? Mesenteric plexus. Okay. Myenteric plexus. Okay, mesenteric plexus, myenteric plexus. How many neurons are there? Almost 100 trillion neurons are there. Okay, in the GIT. My question to you is, neurons are supposed to be present in the brain and spinal cord. Okay, neurons are supposed to be present in the central nervous system and peripheral nervous system. But how you got these many neurons in the GIT? How you got them? How you got them? You understand it? So neurons are supposed to be present in the central nervous system and peripheral nervous system. That's okay. But how you got these many number of neurons into your GIT? Yes. How means? It's a neural crest cells. It's a neural crest cells. Okay. See, it's a neural crest cells. Let me show you. This is a little important. Let me zoom and write. See, imagine when you are an embryo, there is a structure that is formed. This is called as a neural tube. Right, neural tube. When you are at the stage of embryo, neural tube is formed. This neural tube is going to form your central nervous system. That is your brain and spinal cord. Okay, brain and spinal cord. This neural tube is going to form your central nervous system. Okay, no doubt. Surrounding the neural tube, there are these cells which are located peripherally. These are called as the neural crest cells. These are neural crest cells. What do they form? The neural crest cells, they form your peripheral nervous system. Okay. This neural crest cells, this is a neural crest cells. They forms what? Peripheral nervous system, PNS. PNS means what? PNS means spinal nerves and cranial nerves, spinal nerves and cranial nerves. That is your peripheral nervous system. So neural crest cells, they forms your peripheral nervous system. Okay, that's the spinal nerves and cranial nerves. But important point is, these neural crest cells, they will migrate to certain places. Okay, these neural crest cells, what they do? What do they do? They will go on a vacation, sir. These neural crest cells, they will migrate. See, for example, this neural crest cell, what it will do is, it will migrate into different places. It will come into GIT. Okay, they are coming where? These neural crest cells, they are coming into the GIT. So let me write. It is neural crest cell migration. So these neural crest cells here in the GIT, they forms Meissner's plexus and Myenteric plexus. The Meissner's plexus and Myenteric plexus are formed because of this neural crest cell migration. Okay, everything is cool. Everything is cool. Okay, now the integration part from medicine side. There is a condition called Hirschsprung disease. What is this Hirschsprung disease, sir? What is this Hirschsprung disease? Is now look, listen carefully. I will go back to that slide. Don't worry. Now look carefully. This is the part of JT. You should tell me what is this part of JT. What is this part of JT? This is ascending colon, transverse colon, and descending colon. So to this part of JT, okay, this is the last part of the colon. This is the distal colon. Which part? Distal. Where is the distal colon? So to this part of the JT, most of the time, neural crest cells didn't came. Neural crest cells either nahi hai. So this part is called as aganglionic colon. Okay, this part is called as aganglionic segment. Okay, first let's say it's an aganglionic. Okay, aganglionic segment. This is aganglionic segment. So aganglionic segment means what is absent? The neural crest cells are not there. So here, no, a very important point, no Meissner's plexus. No Meissner's plexus, no Myenteric plexus from birth. Okay, no Meissner's plexus and no Myenteric plexus by birth. Okay. So what happens is, normally the baby is going to pass the meconium. Normally the baby is going to pass the meconium. It's the first feces. Baby during delivery, the baby is going to pass the first feces during delivery. Okay, right? Now in this baby, see, the baby is like, when the baby is in the womb, the baby is drinking the amniotic fluid, the baby is taking lots and lots of cells, and some feces forms. Now feces, it's going to move, no problem. The feces is going to move like this, moving. But when the feces come into this area, okay, the first feces, when the feces is going to come into that area, now either Myenteric plexus nahi hai. Here Myenteric plexus, which are responsible for the contractions, in this segment Myenteric plexus are not there. So now do you think the feces is going to go forward? No, the feces is not going to go forward. So do you think the baby is going to pass the meconium? No, failure to pass the meconium. Yes, that's it. That's the key point. Failure to pass meconium. It's the first feces of the baby. First feces. Okay, first feces. So the baby is not passing the feces because here in this aganglionic segment, no Myenteric plexus is not there and Meissner's plexus is not there. So that's the thing. And later, okay, the baby is delivered. Okay, the baby is getting breastfed. Okay, the baby is getting breastfed, and whatever the food like you are giving, the food will come to this area. Okay, the food is moving. Okay, the food is going to come to this area, but all the food cannot go past from this area. The food is going to start accumulate here. The food will be starting to accumulate. So because of this reason, the colon will be dilated. The colon will start to dilate. Okay, the colon is going to start to dilate. The proximal segment. Okay, the proximal segments are starting to dilate. Okay, like this. So leading to big size colon, that is called as a megacolon. Okay, so there is a ganglionic segment leading to big size colon because the food is not going to move forward. The food is not able to move forward, leading to a big colon. Okay, so that is called as a ganglionic megacolon or Hirschsprung disease. Okay, a ganglionic megacolon or Hirschsprung disease. Now, what is the problem? Let's go one by one. This Hirschsprung disease is also called as aganglionic megacolon. I have taught you. What's the problem? Absence of both the myenteric and submucosal plexus. Both myenteric plexus and Meissner's plexus are absent where? In the distal colon. Why? There is a defect in migration of neural crest cells during development. Okay, it is associated with, it is seen in, this Hirschsprung disease is seen in which people? Down syndrome, that is trisomy 21. So Down syndrome babies, they will have this Hirschsprung disease. And not every time they might have this Hirschsprung disease. Okay, that is aganglionic megacolon, absence of Meissner's and both Meissner's plexus and myenteric plexus in the distal colon. Okay, associated with the Down syndrome. Okay, this is one GAD abnormality in Down syndrome. So what is the GAD abnormality that is associated with the Down syndrome? Down syndrome babies is going to have Hirschsprung disease. And not only that, if you want to know, Down syndrome patients are also going to have duodenal atresia. Okay, duodenal atresia. Okay, duodenal atresia is also going to be seen. In Down syndromes, which GAD abnormality is seen? Down syndrome may 2 GAD abnormalities are going to be seen. One is Hirschsprung disease. Second one is duodenal atresia. Duodenal atresia is famous MCQ. If you take X-ray, duodenal atresia will show which sign? If you take X-ray, duodenal. If I am the baby, imagine. Okay, let me show you my face. If I am the baby, see, imagine I am the baby with a duodenal atresia. Which sign is going to be seen? I am the person with a duodenal atresia. If you take X-ray, which appearance is going to be seen? Double bubble sign. Excellent, Rekha. Excellent, Pranita. You're true. This is a double bubble sign. Say double bubble. Okay, yeah. It's not just bubble sign. It's double bubble sign. So the patient is going to have duodenal atresia may double bubble sign. Okay, double bubble sign is going to be seen. Double bubble sign. So these are some important points. Important point is don't ever forget failure to pass the meconium. Failure to pass the meconium. Now, whenever you see a baby who is having a failure to pass the meconium, there are only mainly two possibilities in your FMG exam. Mainly two possibilities. One is Hirschsprung disease. Can anyone tell me what is the other possibility? The other condition where, and that's actually the most common cause. The other condition where the baby is not passing the meconium. Can anyone tell me? No. One more condition, meconium ileus. Exactly. The cystic fibrosis is the answer which I want you to know. Subhatra Vasudevan. Excellent. I appreciate that. It is the cystic fibrosis. One of the most important asked MCQ in the NEET PG exams. The cystic fibrosis. Remember. That is, of course, even other conditions are there, but look, even cystic fibrosis, it's a failure to pass the meconium. Also think about cystic fibrosis. Let me write here. Think about cystic fibrosis. Okay, here the secretions are going to be very thick. In cystic fibrosis, the body secretions are going to be very thick, so the feces is not going to come out. Cystic fibrosis. Okay, done. Complete, sir. The basics are done. Now let's go into a little topics, small topics. GI secretions. How much secretions are going to happen in your GIT? Almost 9 liters, sir. Okay, 9 liters of secretions are going to happen to your GIT. Not that important. What are the secretions? You will produce saliva. You will produce gastric secretions. Gastric secretion means HCl acid. Okay. Pancreatic enzymes. You will produce bile. Will produce bile. And intestinal enzymes. We produce the intestinal enzymes. So all these are accounting for 9 liters. 9 liters. Okay. Important points, sir. See, what is the maximum secretion out of all this? Who is more in quantity? Gastric secretion. That's the acid. Okay, out of all this, we'll produce almost 2 liters. 2 to 2.5 liters. Okay, 2 to 2.5 liters of acid. We every day produce 2 to 2.5 liters of acid. Okay. What is the most acidic secretion? The most acidic secretion is again acid. Okay, the most acidic secretion is acid. How much? What is the pH? 1.5 question. The most acidic GI secretion is HCl. HCl. What is the pH? 1.5. Then what is the most basic secretion? Most of the students answer this like it's in the wrong way. Most basic secretion in our GIT is Brunner gland secretion. pH is 8 to 9. Okay, the Brunner gland secretion, the pH is 8 to 9. Okay, the Brunner gland secretion pH is 8 to 9. Most basic secretion. Now students will have a doubt. What are these Brunner glands? Okay, let me draw a small diagram for you. Don't worry, I will come to the slide back again. Okay, don't worry. Just look at this. Sir, hey, your stomach, your beautiful stomach. So here is the HCl. Acid is getting produced here. So there is no problem for the stomach because stomach is having proper mucus lining. A thick mucus lining is there. So there is no problem for the stomach. Okay. Now, after some time, this HCl, where it will enter? The HCl is going to enter into the duodenum. Now comes the problem. Acid in the stomach, no problem. But when acid is coming into the duodenum, the acid can cause damage to the duodenum. The acid can cause ulcers. So duodenum have its own protection. So duodenum may special cells are there. What are these cells? Actually, these are the glands. These are called as Brunner glands. Okay. These are Brunner glands. So these Brunner glands are going to produce mucus. Okay, Brunner glands are going to produce mucus, which is rich in bicarbonates. So bicarbonate rich or base rich or alkaline rich mucus is going to be produced. Okay, so that will give the protection, that will cause the neutralization of acid, that will neutralize the acid. So these Brunner gland secretions will neutralize the acid. True. So that's why they are highly basic in nature. So most basic secretions are Brunner gland secretion, pH 8 to 9. Where are these Brunner glands present? The Brunner glands are the mucus producing glands in duodenum. MCQ. Okay, direct singular question. And maximum water absorption, not just absorption. Maximum water absorption, FMG direct question, occurs where? Water absorption, most of the students will confuse and say water absorption occurs in colon. No. Maximum, the word important here is maximum. Maximum water absorption occurs in jejunum. In the jejunum, most digestion occurs and most absorption occurs. Most water reabsorption, maximum water absorption occurs in jejunum. That's it. So let's talk about the saliva. Sir, how much saliva you produce every day? 1.5 liters, direct line. Single line question. From where the saliva is coming? Saliva is coming from the salivary glands. MCQ. Sir, how many salivary glands do we have? We have parotid salivary glands, sublingual salivary glands, submandibular salivary glands. See, the submandibular salivary glands, submandibular means below the mandible, below our mandibles. Okay, let me show you here. See, these are the submandibular salivary glands. Look at here. These are the submandibular salivary glands. Here, submandibular salivary glands are there. These submandibular salivary glands, okay, they are the major salivary glands. The submandibular salivary glands are the major salivary glands. Why they are major salivary glands? Because they produce 70% of the saliva. Submandibular salivary glands are the major salivary glands because they produce 70% of the saliva. Recently, a new salivary glands was discovered. Okay, almost there are 200 different types of salivary glands. They are very, very small salivary glands are there throughout our pharynx. Okay, but recently in 2020, a new salivary glands were discovered. They are named as tubarial glands. So tubarial glands are nothing but salivary glands. Okay, tubarial glands are nothing but salivary glands. Okay, that's also tested in the AIMS exam. That's why I have kept it here. Okay, so tubarial glands are newly discovered salivary glands. So saliva mein kya hai? What is there in the saliva? Okay, what is there in the saliva? Saliva mein enzymes hai. So in saliva, what do we have? Enzymes. Which enzymes? Carbohydrate digestion ke liye there is thiolin. I don't know why, but FMG examiner love to ask this. Thiolin is present in saliva. Thiolin is also called as salivary amylase. It digests what? Carbohydrates. So carbohydrate digestion ke liye you have thiolin, which is also called as salivary amylase. And to digest the lipids, lipid digestion ke liye you are having lingual lipase. Lipase digests the lipids. So lingual lipase is produced by a small salivary gland, a minor salivary gland, which is called as the Ebner's gland. MCQ in NEET PG. Ebner's salivary glands. Ebner's glands are the salivary glands which produce lingual lipase. Lingual lipase. They digest lipids. Okay. But protein digestion ke liye, so carbohydrates are digested, lipids are digested. But what about the proteins? No enzyme for protein digestion. Okay, there is no enzyme for protein digestion. The last point, I don't know whether you can see it or not, but there is no enzyme for protein digestion. So that's it. So MCQs. Maximum acidic secretion is HCl. Maximum basic secretion is Brunner gland secretion. Brunner glands are present in duodenum. Maximum water absorption, jejunum. Major salivary gland is submandibular salivary gland. Enzymes present in the saliva, thiolin and lingual lipase. No enzymes for protein digestion in the mouth. No digestion of proteins in saliva. That's it. Now, questions, what they will ask you is simple. Don't write each and everything. Don't write each and everything. See, your parotid gland is there. In your cheeks, what do you have? Parotid glands. In your cheeks, mein, parotid glands are there. What they produce? Saliva. Simple, you know it. They produce saliva. Parotid salivary glands. So from where nerve innervation is coming? Every gland, for example, parotid is a gland. Every gland have a nerve innervation. Every gland have a nerve innervation. So this parotid gland is getting its nerve innervation from where? Which cranial nerve? Which cranial nerve? See, P, reverse the P, reverse the P. It becomes ninth. Okay, right, that's it, that's it. From anatomy, this is little integration. Cranial nerve 9 innervates parotid gland. Parotid gland. What are the other two salivary glands? Other two important salivary glands. Submandibular gland and sublingual gland. It's starting with which letter? S. S for 7. So 7th cranial nerve. That's a facial nerve. Here it is a glossopharyngeal. Okay, cranial nerve number 9. Cranial nerve number 9 is glossopharyngeal. Cranial nerve number 7 is facial. So facial nerve innervates submandibular, sublingual, and cranial nerve number 7 cranial nerve number 9 innervates parotid. Reverse the P, 9. Submandibular, sublingual, SS for 7th cranial nerve. That's it. Nerve supply also completed. Okay. Any other important points about the saliva? Yes. A few important single liners are there. Saliva, what else are there? Saliva, there is an antibody which is called as IgA antibody. Okay, it's present in all the secretions. It's present in all the secretions. So that's why it's called as a secretory antibody. So saliva contains which antibody? IgA antibody, not IgG, IgA antibody. It's present in all body secretions. Apart from that, antibacterial substances like lactoferrin and lactozyme are present. Okay, lactoferrin and lactozyme are present. In the last FMG exam, not the recent one, the last FMG exam, last June. Okay, the question which was asked me is, guys, look, there is a disease in which, okay, this is the salivary gland. Imagine this is the parotid salivary gland. Okay, plus there is a disease in which these are the lacrimal glands. See, salivary glands, both the salivary glands and lacrimal glands, both are destroyed because of the autoimmunity. There is autoimmune destruction of lacrimal glands and salivary glands. Autoimmune destruction of, let me write, autoimmune destruction. Autoimmune destruction of lacrimal gland is destroyed and salivary glands are destroyed. So what happens? So there is no salivation, so that will cause dry mouth. Okay, dry mouth or xerostomia. Dry mouth also called as xerostomia. Dry mouth because no saliva. And lacrimal glands are destroyed, so lacrimation is not there. That will cause xerophthalmia. So what is this disease? I hope you already know it. Okay, but I want you to answer. I want to hear it from your mouth. So tell me, what is this? There is a condition in which salivary glands are getting destroyed. Why I am discussing the salivary glands? Salivary glands are destroyed. Autoimmunity. What is this condition? Sjogren, Sika syndrome or Sjogren's? Excellent. Okay, Sjogren. Yes, Sjogren syndrome also called as Sika syndrome. Sjogren syndrome or Sika syndrome record. Excellent. So that's the point which I want you to know. So it's called as Sjogren syndrome. This was the question asked in the last FMG exam. What else you should know? Say this baby. Okay, I don't know whether it's a male or female. Okay, until unless we get the lower picture. So this baby is little worried. Why this baby is little worried? One thing what you can appreciate here is the cheek is swollen. Okay, the cheek is swollen. What is happening? So the baby is having parotitis. Okay, there is inflammation of the cheek, inflammation of the parotid gland. Okay, parotitis. So this condition is called as a mumps. So in mumps, because of this virus called as paramyxovirus, okay, this mumps virus or the paramyxovirus, it's belongs to the paramyxoviridae family. So this mumps virus, where it will love to replicate, it will love to divide, it will love to grow in parotid salivary glands. And this baby is worried not because his cheek is swollen, but because his future generations are under threat. His future generations, his progeny is under threat because the mumps virus will also affect testes in males and ovaries in females. So leading to architis and oophorytis. Architis and oophorytis. Mumps is going to cause inflammation of the salivary gland. Okay, but other organs which are affected in mumps, the next second most organ that is affected in mumps are the gonads, testes and ovaries, leading to architis. Is inflammation of the testes and oophorytis. Oophorytis, architis and oophorytis. Done. Okay. So why I am discussing mumps here? Because salivary glands are involved. Which salivary gland? Parotid salivary gland is involved. Parotid salivary gland is involved most commonly. Okay. Done. And other single liners in our body, maximum potassium secretion occurs into. See, secretion. Maximum potassium is secreted into, released into saliva. Okay. And in which body? Like in which body fluids? In which body fluids? Maximum potassium concentration is there. Concentration, C for C, colon. In which body fluids maximum potassium is secreted? Saliva. Potassium secretion into saliva. Maximum potassium concentration is present in the colon fluids. Okay, fluids of the colon. So with this, all the direct single liner questions are done. Okay, single liner questions are done. The next topic that we are going to start is the stomach. So just take a deep breath. Stomach, important. Take a deep breath, sir. Now, so what is this small bag-like structure? This is the stomach. Okay, you know it. Now I'm taking a small part of the stomach. Okay, I'm taking a small bit of it. Okay, biopsy. Now I'm putting under the microscope and I'm just showing it to you. Okay, I'm just showing it to you. Okay. Now you already know it. Sir, how many layers are there in stomach or anywhere? How many layers are there? 4 layers are there. So look here, mucosa, the first top layer. Here all this layer is the mucosa. There is submucosa. There is muscularis. And there is serosa. Final layer is serosa. The same thing. Mucosa, submucosa, muscularis, serosa. These are the 4 layers in the stomach. But what I want you to appreciate is, guys, please appreciate in the mucosa. Look, in the mucosa, there are these glandular structures present. These glands are present. See, these are all the glands. So what are these glands? So these glands are the gastric glands. Simple. These are all what? These are all the gastric glands. Now what I want you to know is, sir, a gastric gland may, how many types of cells are there? Tell me how many types of cells are there? Is it made up of single type of cell? No, this is the different color cell. This is a different cell. This is a different cell. And here are the different cells. These are different cells. So gastric glands are made up of different types of cells. That's the point which I want you to know. Okay. So the gastric gland made different types of cells are there. Okay. This is the first point. So now see, look, this is the one gastric gland. It is made up of different types of cells. Okay. So let me write all these cells one by one. So first cell, it's already there in your book. You don't write anything. You don't write anything. Just look here. So this cell, first cell I'm talking, it's missing in your book also. It's not there. This first cell, the topmost cell, is there on the surface, right? So this cell is called as surface mucus cell. Surface mucus cell. Okay, the first cell in the gastric gland. The first cell in the gastric gland is called the surface mucus cell. It is going to produce what? Very tough question. Surface mucus cell is going to produce what? Simple mucus. It's going to produce the mucus. The surface mucus cells are also called as foveolar cells. Okay, the surface mucus cells are also called as what? Foveolar cells. Okay, now you have to answer like this. In stomach, who produces the mucus? It's the surface mucus cells or foveolar cells. In duodenum, who produces the mucus? In duodenum, it's the Brunner glands. Brunner glands produces the mucus in the duodenum. Okay, never say goblet cells. Some students will confuse and they will say, who produces the mucus in the stomach? They will say goblet cells. No, goblet cells are not there in the stomach. Mucus is produced by surface mucus cells, also called as foveolar cells. Now down, next. So these cells, which I am showing here, for example, maybe these cells. Okay, it's not that specific. You can say, for example, these cells. So those cells down to the surface mucus cells are called as the neck mucus cells. Neck mucus cells. From here you can start. See, these are the neck mucus cells, mucus neck cells. What they'll produce? Mucus neck cells. They will also produce mucus, but the neck mucus cells, they act like stem cells. They act like what? They are the stem cells in the stomach. The mucus neck cells are the stem cells. Okay. Every day you will lose the surface cells. So every day the surface lining is going to be lost. Surface lining is going to be lost. So the mucus neck cells will replace them. So mucus neck cells, they act like a stem cell. They will replace the surface mucus cells whenever needed. Okay, done. Okay, done. Two cells are completed. Surface mucus cells and mucus neck cells. Next, what we are left over with? Next, we are having parietal cells. In your book, come to this slide. Okay, mucus neck cell ho gaya. Next, parietal cell. What does this parietal cells produce in your stomach? Parietal cells gastric glands mein hai. True. Parietal cells are present in the gastric gland. And these parietal cells produce acid. They produce the acid. And also the same parietal cells produce intrinsic factor. Parietal cells produce acid and intrinsic factor. Okay. The same thing. Parietal cells produce acid and intrinsic factor. Intrinsic factor helps in absorption of vitamin B12. Intrinsic factor helps in absorption of ABS means absorption. Intrinsic factor helps in the absorption of vitamin B12. Vitamin B12. Okay. Next cell in the gastric gland, next different type of cell is called as the ECL cell, enterochromaffin-like cell. Okay, ECL cell, enterochromaffin-like cell. The enterochromaffin-like cells, anyone? Okay, let me ask anyone. Enterochromaffin-like cells produce. Ask in FMG exam. Enterochromaffin-like cells produce. Enterochromaffin-like cells produce serotonin. Serotonin. Enterochromaffin cells produce serotonin. Now I'm talking about enterochromaffin-like cells. Enterochromaffin-like cells produce histamine. Histamine, not serotonin. Okay, these are like cells. Enterochromaffin-like cells produce histamine. Okay, what is the function of histamine? Histamine increases acid. Histamine, see this histamine, what it will do? This histamine, it will go and stimulate the parietal cells to release acid. Histamine stimulate the parietal cells to release acid. Okay, you can write directly here. Okay, see here I have written enterochromaffin-like cells produce histamine. Chief cells. Chief cells produce enzymes. Which enzymes in the stomach? Pepsinogen. Pepsinogen. And gastric. Gastric means stomach gastric lipase. Okay. Pepsinogen for the digestion of protein digestion ke liye. Pepsinogen for the digestion of proteins. And gastric lipase for the digestion of lipids. Okay, lipid digestion ke liye. So gastric lipase for the lipid digestion. And D cells. D cells helps in the digestion. D cells produce what? D cells produce somatostatin. Somatostatin का function क्या है? Somatostatin decreases acidity, decreases everything. From the morning I am telling you. So D cells inhibit everything. They inhibit insulin, they inhibit glucagon, they inhibit growth hormone, they inhibit acid, everything. True. Last but not the least, G cells. G cells produce gastrin. G cells produce gastrin. Gastrin, what it will do? Gastrin will go and stimulate the parietal cells. Okay, so this gastrin, it will go and stimulate what? Parietal cells. To release acid. Gastrin increases acid. Gastrin increases acid. That's it. Okay. So same things as you are asking me to sir Zoom, same thing. Okay. So mucous neck cells produce the mucus, parietal cells produce acid, intrinsic factor, enterochromaffin-like cells produce histamine, chief cells produce pepsinogen gastric lipase, D cells produce somatostatin, G cells produce gastrin. That's it. Okay. A small thing is intrinsic factor helps in B12 absorption. That's it. Is that clear? So far, is that clear? If it's clear, I will ask you questions. If it's clear, no, do the cells location in the stomach is not important. No one will ask you about the location of the stomach. They're all present in the mucosa. They're all present in the gastric glands. They're all present in the gastric glands. Location is not that important. No one will ask you about that. It is important for USMLE exam. In USMLE exam, they will ask you. They will show you the biopsy and they will ask you. But for FMG exam and NEET PG exam, it is not important. Okay. Now, let me ask you questions. Pepsinogen is produced by. Let me see who can answer. Pepsinogen. Immediately, come on. Pepsinogen is produced by which cells? Let me see who is that good student. Satish, chief cells. Okay. Sir, intrinsic factor is produced by. Intrinsic factor is produced by. Yes, you are true. It is parietal cell. Parietal cell. Histamine is produced by. Histamine is produced by. Simple. ECL, not ENT, ECL otherwise. It's ECL, enterochromaffin-like cell. Okay, enterochromaffin-like cell. Okay, that's the question. Enterochromaffin-like cell produces histamine. Okay, now let me tell you a story about a naughty boy. Okay, who is the naughty boy in this class? Satish is a naughty boy. Vishnu Yadav. Let me. Yeah, Rahul is the naughty boy. Okay, let's take Rahul in the story. Okay, look. So this is our Rahul. Okay. So Rahul, being naughty, he is satisfied with one. Definitely, he is not satisfied with one. Okay. So he need multiple stimulations. Okay, let's look here. So, so this Rahul is having 3 girlfriends. Okay. Now, one girlfriend name is gastrin. The gastrin is produced by G cells. Okay, G cells produce what? Gastrin. Next, enterochromaffin-like cells produce what? Histamine, the second girlfriend. Histamine. So all these girlfriends are coming and stimulating him. Okay, gastrin is stimulating. Gastrin is acting on its receptor, CCKB receptor. Gastrin receptor is CCKB, cholecystokinin B receptor. Histamine is acting on H1 receptor. Okay, histamine is acting on the H1 receptor. Okay, so he's also having one secret girlfriend. No one knows in the college. He's maintaining a secret Russian girlfriend. Okay, not Chinese girlfriend, whoever. Now there is a secret girlfriend. Her name is acetylcholine. Okay, acetylcholine. From where it is coming? Acetylcholine is released by which nerve? Vagus nerve. Vagus nerve. Okay, parasympathetic nerve. Vagus nerve releases acetylcholine. Acetylcholine is stimulating its receptor, M3 receptor, M3 muscarinic receptor. So now, Rahul, okay, alias which cell? This is our parietal cell. Okay, this is a parietal cell. Now, parietal cell is having how many stimulation? The parietal cell is having stimulation from gastrin, histamine, and acetylcholine. These are the 3 stimulations. Okay, So whenever our parietal cell is being stimulated, whenever our hero, our naughty boy is getting stimulated, he is going to release certain things. What he will release? Okay, what he is going to get, what he is going to release? Whenever he is stimulated, don't think too much, he is going to release acid. Okay, parietal cell is going to release acid. Okay, so what are the three stimulations for the release of acid? The three stimulations for the release of acid are gastrin, histamine, and acetylcholine. Now this parietal cell, with the help of this pump, there is a mouth. This mouth is called as proton pump. Proton pump. So through the proton pump, acid is going to be released into the stomach. Okay, so this is the story of our naughty boy and three girlfriends. Okay, and what he is releasing? Acid. These are the three stimulations. Now let me show you the real naughty boy. So this is our parietal cell. Okay, so histamine. Sorry, I made a small mistake. Histamine is acting on H2 receptor. Why I made H1 here? No. Histamine acting on H2 receptor. H1 receptor means there's a totally different thing. That's a bronchoconstriction. Histamine is acting on H2 receptor. Okay. Yeah, see. Histamine, it's acting on H2 receptor. Acetylcholine is acting on M3 receptor. And gastrin is acting on CCK-B receptor. Okay, CCK-B receptor. Now, with the help of this proton pump, okay, this pump is called as is a proton pump through which the acid is being released into the stomach. Okay. So, is that clear? Is that clear, guys? Now, if you understand this, I will explain you a little integrated topic. Now, imagine I'm saying you, I'm coming to your clinic and I'm saying you, doctor, are you a relative? A relative is coming to your home and saying, buddy, after eating food, I'm having pain in my stomach. What is your diagnosis? After eating food, खाने के बाद दर्द है, पेट में दर्द है, there is a pain in the stomach. What do you think? It's a peptic ulcer disease. It's a stomach ulcer. It's a gastric ulcer. Okay, that's one thing. Second thing, sir, after eating, there is pain in the chest. After eating, there is a pain in the chest. What is your diagnosis? Good. Okay, gastroesophageal reflux disease. Okay, heartburn. It's a good. So in both the conditions, what you have to do, you have to increase the acid production or you have to decrease the acid production. Just tell me. You have to increase the acid or you have to decrease the acid production. You have to decrease the acid production. So that's why, see, for the peptic ulcer disease and for the gastroesophageal reflux disease, we have to decrease the acid. Okay, how we can decrease the acid? By blocking his mouth. Proton pump inhibitors, I have told you. So there is this mouth. You have to block this mouth. This proton pump ko block karo by using drugs like proton pump inhibitors. What are the examples of proton pump inhibitors? Omeprazole, pantoprazole, esomeprazole. These are proton pump inhibitors. They all decrease the acid. Even in Zollinger-Ellison syndrome, later I will discuss here. In Zollinger-Ellison syndrome, we will use the proton pump inhibitors. They decreases acid. They all decreases acid. Okay. What are the other ways to decrease the acid? You can block also H2 blockers. This histamine receptor can be blocked. You can block the histamine receptor because it's one of the powerful stimulant. Histamine is one of the powerful stimulant for the release of acid. Okay, out of these three girlfriends, the more beautiful girlfriend, the more stimulation is coming from where? Histamine. Okay, so block the H2 receptors. So H2 receptor blockers, what are they? Ranitidine, cimetidine. Ranitidine and cimetidine, they will also decrease the acid. So H2 blockers and proton pump inhibitors, they all decrease the acid. Okay, clear? They all decrease the acid. Next, what is this little patho link from medicine? Like a patho and medicine link, Zollinger-Ellison syndrome. What is this Zollinger-Ellison syndrome? Zollinger-Ellison syndrome is nothing but gastrinoma. Okay, there is a tumor called as the gastrinoma. Okay, there is a tumor called as gastrinoma. What it is, this gastrinoma is doing, it produces more gastrin. You know, gastrin is also a stimulant. So gastrinoma mein zyada gastrin hai. There is a lot of gastrin. That gastrin is increasing the acid. Okay, so Zollinger-Ellison syndrome, there is a tumor called as gastrinoma. Okay, who will get this Zollinger-Ellison syndrome or gastrinoma? Who will get this? Men syndrome patients. Okay, men 1 syndrome patients are going to have this gastrinomas. Okay, Men 1 syndrome patients are going to have this gastrinomas. Okay. Okay. Now, where is this gastrinoma located? It's a very small tumor. Do you know how small this is? It's the size of a pinhead. It's the size of a pinhead. Small tumor. Very, very, very small tumor. See, in surgery, you will get this. They will ask you this question. See, most of the time, tumor is located in this triangular area. So this triangle, these borders, this triangle, I'm not going into the too much details about the border. This triangular area, it's called as Passaro's triangle. So gastrinomas are located in the Passaro's triangle. Okay, that's also called as the gastrinoma triangle. Okay. So in Zollinger-Ellison syndrome, very important thing. What is the investigation of choice? This is important. Investigation of choice is the MCQ. Secretin study. Why secretin study? Why secretin study? Let me tell you. Look here. I am having Zollinger-Ellison syndrome. Imagine. Okay, Zollinger-Ellison syndrome है मेरे को. What happened to my acid levels? अरे body में ज़्यादा acid है sir. Stomach में lot of acid is there. Too much acid is there. Whenever there is too much acid, what your body will try to do? What your body will try to do? Your body will try to protect you. Your body will try to produce antacid. So what is the nature's antacid in your body? Secretin. Okay, secretin is the nature's antacid. Okay, it increases bicarbonate levels in the mucus to neutralize the acid. So once you have Zollinger-Ellison syndrome, yeah, you are having more acid levels. Also, your secretin levels will be more. Early morning, you are having more secretin. Every time, whenever you check, secretin levels are going to be more in the blood. Okay, more secretin levels are going to be there. So that's why, so secretin study will do. Okay, to know how much acid is there in the stomach, we will check it indirectly via secretin. Acid more hai to automatically secretin be more. So investigation of choice is secretin study. And what happened to the secretin levels? Increase, right? Secretin levels are going to be increased. Secretin levels are going to be increased. Okay. So this medicine question. How to locate the tumor? I said it's a very small tumor. How to localize this tumor? The most sensitive test for tumor localization, to locate the tumor. This is pure medicine. How to localize that tumor, gastrinoma, small chota gastrinoma. How to localize it? There is a study called as somatostatin receptor scintigraphy. Okay, somatostatin receptor scintigraphy. So what is the concept here, sir? If you ask me, sir, I want to understand the concept. Look here. Array, what do I have? Gastrinoma. First of all, gastrinoma. Gastrinoma का meaning क्या है? It's a tumor of G cell. G cell का tumor. Gastrin cells. It's a G cell. Okay. What this tumor is producing? Excessive amount of gastrin. Okay. What gastrin will do? Gastrin will stimulate the parietal cells to release acid. Once your digestion is completed, do you want further acid production? No. No. Okay. Now, do you know what happens? Now D cells, let me show you the red color. D cells, what they will produce? D cells produce somatostatin. Okay, somatostatin. Now the somatostatin receptors are present here. Okay, what are these red color things? These are the somatostatin receptors. Somatostatin receptors are going to be stimulated once your digestion is completed. Somatostatin is released. Somatostatin will come and stimulate, so that what happens? Gastrin levels goes down and acid levels later goes down. Okay, so how to identify this gastrinoma? How to identify where are the G cells? Identify the somatostatin receptors. Okay, so by looking at the somatostatin receptors, you can identify the gastrinoma. So that's why the study is called as somatostatin receptor scintigraphy finding. Somatostatin receptor scintigraphy is a tumor localization study for gastrinoma. And how to treat this? Zollinger-Ellison syndrome. Already we have discussed Zollinger-Ellison syndrome. We can use drugs like proton pump inhibitors. Yes, we can use proton pump inhibitors. Also use octreotide. Why? Because octreotide is a somatostatin. Okay, octreotide is what? It is somatostatin. It's a somatostatin, right? Octreotide is a somatostatin analog. It is used for Zollinger-Ellison syndrome. True. Okay, for secretory, all secretory diarrhea conditions, you can use octreotide. For acromegaly, you can use octreotide. Okay, something like that. So done, sir. So Zollinger-Ellison syndrome, again repeat, Zollinger-Ellison syndrome. There is a gastronoma in a triangular area, in the triangular area called as the Passaro's triangle. What is the investigation of choice? Secretin study. To identify the tumor localization study is called as the somatostatin receptor scintigraphy. Treatment is octreotide, proton pump inhibitors. Done. Okay. What is the problem with cimetidine? Can anyone tell me what is the problem with cimetidine? Cimetidine causes gynecomastia. Don't forget FMG famous question. Cimetidine can lead to gynecomastia in males. Is that clear? Shall I go forward? Cimetidine. In the morning, I have discussed one gynecomastia causing drug. One drug which causes a gynecomastia in the morning, I have discussed. Can you tell me what is that? Can you tell me one drug which causes the gynecomastia in the morning? I have discussed. It is used in the treatment of Conn syndrome. Yes, exactly, Abra. Yes, spironolactone. Yes. Yes, Maria. Yes. Abdul Rahman, Sai Pranita. Yes, spironolactone. Spironolactone causes gynecomastia. True. Okay, it causes gynecomastia. Okay, let me check. Mucus production in the stomach occurs with the help of which cells? Mucus production in the stomach is done by which cells? Mucus production in the stomach. Surface mucus cells, also called as foveolar cells. Surface mucus cells are foveolar cells, and mucus neck cells, of course, mucus neck cells also. Okay, gastrin is produced by. Gastrin is produced by. Gastrin is produced by G cells. Sir, G cells के ऊपर, on the surface of G cells, which receptors are there? Somatostatin, excellent. Excellent, Maria. Yeah, it's a somatostatin receptor site. Just now I have discussed somatostatin receptors are there. Whenever digestion is completed, somatostatin will stimulate the somatostatin receptors. So gastrin levels goes down, acid production decreases. Okay. Done. Parotid gland is innervated by. Parotid gland is innervated by. Parotid gland is innervated by. Ninth cranial nerve. See, parotid P reverse the P. Ninth cranial nerve. The other sublingual submandibular innervated by SS. Sublingual submandibular. Seventh. Excellent. So what about the Zollinger-Ellison syndrome? In Zollinger-Ellison syndrome, what about the secretin levels? Secretin levels are going to be more or less. In Zollinger-Ellison syndrome, secretin levels are going to be high. Secretin is the nature's antacid. Secretin is the nature's antacid. It's anti-acid. I will discuss about the secretin, secretin, gastrin, all these things I will discuss. Okay. Okay, chalo. So next. Pernicious anemia. Pernicious ka meaning dangerous. Pernicious word meaning is dangerous. Okay, dangerous anemia. What is this pernicious anemia? See, pernicious anemia is an autoimmune disorder. It's an autoimmune condition. You know what is autoimmune? In this condition, own parietal cells are damaged. Okay, so for example, this is our naughty boy parietal cell. Okay, this is our parietal cell. Is getting attacked not by the girls but by the police. Okay, so parietal cells are getting damaged. When the parietal cells are damaged, now you tell me what happens. So there you go. So parietal cell is dead now. Okay, parietal cell is dead. So there is no acid and no intrinsic factor. Intrinsic factor available nahi hai. No acid. So no acid means achlorhydria. Achlorhydria. So parietal cell is dead because of the autoimmune damage, because of the autoimmune destruction of parietal cells. Only the parietal cells are getting destroyed. So acid nahi hai. So leading to achlorhydria. Achlor means A means no. Chlorhydria means acid. No acid. Intrinsic factor is not there. When intrinsic factor is not there, B12 is not absorbed. B12 is not absorbed. When B12 is not absorbed, that will causes anemia. B12 deficiency causes anemia. So that's the thing. So pernicious anemia, autoimmune disease, characterized by severe lack of intrinsic factor. Okay. Why all this problem? Because antibodies attack parietal cells. Okay, antibodies are going against the parietal cells. Okay, now tell me, अरे guys, in this condition में acid है या नहीं है? Acid is not there. Acid is not there. So what your body will try to do? What your body will try to do? Sir, your body will try to produce acid. Your body will try to produce acid. So what happened to the gastrin levels? Our body will try to produce the acid because acid is not there. So what happened to the gastrin levels? Gastrin levels are going to be more secreted by, characterized by increased serum levels of gastrin. Okay, more gastrin hai abhi. Okay, the gastrin levels are going to be more. Okay, gastrin levels are going to be more. Now, some students, really intelligent students, they will get it out. Sir, gastrinoma, that's a Zollinger-Ellison syndrome. Look, previous one. Zollinger-Ellison syndrome may be hypersecretion of gastrin. Lot of gastrin is there. Here also, pernicious anemia also, gastrin levels are more. How to differentiate between these two, sir? There, in Zollinger-Ellison syndrome, I have taught you. Here, Zollinger-Ellison syndrome, mein acid is also there. Okay, Zollinger-Ellison syndrome, mein acid is also there. So that's why secretin levels are also increased. Okay, zyada acid hai to zyada secretin. But right now in pernicious anemia, first of all, acid is not there. So what about the secretin levels? Here, secretin levels are less. Secretin levels are going to be less. That's it. Okay, in pernicious anemia, acid is not there, so secretin is not there. In Zollinger-Ellison syndrome, think in Zollinger-Ellison syndrome, there is more acid, so more secretin. That's right. That's it. That's it. Okay, done. Is that clear? Pernicious anemia and Zollinger-Ellison syndrome are two important conditions which was tested in the FMG exam. That's why. Okay, pernicious anemia में acid नहीं है, so secretin भी नहीं है. In Zollinger-Ellison syndrome में more acid, so more secretin. Okay. Now, the next condition which is called as a Menintrier disease. Okay, Menintrier disease. Menintrier disease means in one of the FMG exam, this image-based question was asked. Say this is actually the stomach, but how the stomach is looking? The stomach is looking like having like gyre and sulci. It's looking like a gyre and looking like a sulci, gyre, sulci, gyre, sulci. Like it's looking like a brain kind of appearance. Like the cortex, how the cortex looks. Gyre, sulci, gyre, sulci, gyre, sulci, something like this. So now here the stomach in this condition, it's looking like a brain. So this is called as the cerebriform appearance, looking like a brain. Cerebriform appearance of the gastric rugae or gastric mucosa. Why it is like that? Because of the foveolar cell hyperplasia. Now you already know what are foveolar cells. Foveolar cells are the mucus producing cells in the stomach. There are certain conditions like in peptic ulcer disease or too much acid production conditions mein, okay, GERD conditions, certain conditions mein, foveolar cells will undergo hyperplasia. When the foveolar cells, when they undergo hyperplasia, the stomach is going to look like a brain. So this disease is called as Menintrier disease. So Menintrier disease is due to foveolar cell hyperplasia. Okay, foveolar cell hyperplasia. Now, let me ask you, general pathology completed. Okay, your pathology is completed, right? In this Menintrier disease, one levels is going to be increased. The one cytokine level is going to be increased. Can anyone tell me what is that cytokine? Actually, it's a patho thing. Okay, first you answer. There is a one cytokine level that's going to be elevated. What is that? No, it's not Crohn's disease. Definitely, that's not Crohn's disease. No, it's not Crohn's. Jitendra, excellent. TGF alpha. Jitendra, excellent. Yes, of course, the patient is going to have hyperproteinemic, hypertrophic gastropathy. Yes, true. You are true. Excellent, Rekha P. You are true. The patho-related question which was asked in exam is TGF alpha levels are going to be more in Menintrier disease. TGF alpha levels. That's the FMG question. Next integrated topic from the physiology is how painkillers cause the ulcers in the stomach. If you take a painkiller, there'll be ulcers in the stomach. How is, see, for example, imagine our naughty guy Rahul. Here Rahul is having body pains. Why he is getting the body pains? Totally debatable topic, but he is having the body pains. Okay. So NSAIDs, these are the painkillers. If you take painkillers, these painkillers inhibits which pathway inside the cells? Cyclooxygenase pathway. If you take a painkiller, the cyclooxygenase pathway is going to be inhibited. Okay. When the cyclooxygenase pathway is inhibited, this is the question. Prostaglandin levels goes down. Okay. So what happens? Prostaglandins are responsible for pain. They are responsible for pain. So whenever prostaglandins goes down, PGE2 responsible for pain. When PGE2 level goes down, automatically pain decreases. Good. But whenever prostaglandin goes down, the blood vessels will undergo vasoconstriction. Vasoconstriction. The blood vessels will undergo what? Vasoconstriction. Whenever there is vasoconstriction, there is a decreased blood flow. To where? To all the body. To all the body, the blood flow is going to get decreased. But the blood flow to the stomach also decreases. Whenever there is less blood flow to the stomach, the gastric mucosa decreases. See, blood flow is a very important protective factor. Blood flow is very, very, very much needed for the production of mucus in the stomach. Blood flow is needed for the production of the mucus in the stomach. Whenever the blood flow goes down, mucus production also goes down. Whenever the proper mucus lining is not there, whenever the proper mucus lining is not there in the stomach, mucus nahi hai to acid can damage the stomach, and that can lead to the ulcers. Okay, that can lead to the ulcers. Done. So this is why the painkillers can lead to ulcers in the stomach. Okay, so question which was tested in FMG exam is, if you take NSAIDs, cyclooxygenase pathway is inhibited and prostaglandin decreases. That's it. Okay. Whenever prostaglandins are not there, prostaglandins decrease hone to immediately the blood vessels will undergo vasoconstriction. So that will lead to decreased blood flow to the stomach. So mucosa will undergo atrophy. Mucosa atrophy will cause the ulcers. So stomach mein, what else you should know? Enzymes. Stomach mein, what enzymes are there? Stomach mein, look, digestive enzymes like protein digestion ke liye pepsinogen is there. See, pepsinogen. Forget about the renin, chymosin. Pepsinogen is going to help in the digestion of proteins. Gastric lipase. Just wait. Gastric lipase is produced by which cells? Let me see who can answer immediately. So gastric lipase is produced by which cell? Gastric lipase is produced by which cell? Chief cell. Subhadra, excellent. It's a chief cell. Okay, chief cell. Gastric lipase is produced by gastric lipase and pepsinogen. Both are produced by the chief cells. True. So protein digestion के लिए pepsinogen, lipid digestion के लिए gastric lipase. But is there any enzyme produced in the stomach? Is there any enzyme produced in the stomach for the digestion of carbohydrates? No. No enzymes for carbohydrate digestion. That's it. Saliva में no protein digestion. Saliva में no protein digestion. Stomach में no carbohydrate digestion. Okay. Sir, pepsinogen, wherever you see the word ogen, ogens are inactive substances. So pepsinogen is inactive. It should be converted into pepsin. We will convert that. HCl, MCQ. Pepsinogen need to be converted into pepsin with the help of HCl. Done. Next. The next concept is gastric emptying. The concept of gastric emptying. What is the concept of gastric emptying, sir? For example, imagine after 5 months, you are going to give your exam, right? After 5 months, you are going to give your exam. Exam date is also there. Exam day came, sir. Exam day. Now look at me. Imagine today is the exam day. Today is the exam. Today morning 9 o'clock exam. Okay, today morning 9 o'clock exam. Right now the time is 6 o'clock. Okay, your mom is going to feed you or not? You are in your home. Your mom will feed you or not? Your mom, your dad, will they feed you or not? Definitely they are going to feed you. Yes, they will feed you, right? What they are going to feed you? Arey, my son is going for the war. Okay, let me feed him chicken biryani, mutton biryani. Will they give you like burgers and pizzas? What they will give you? They will give you light food. Okay, they will give you light food. Like if you are a South Indian, they will give you like small light foods like idli. Okay, if you are like from North, they will give you, I think, curd rice. Like students said me, I am not sure. They will give like upma, like whatever, light foods. Okay, light food. So why they are not giving you chicken biryani or mutton biryani, or why not they are giving you like double cheese pizzas? Because of the concept of gastric emptying. Okay, the concept is carbohydrate. See, look here. Gastric emptying means the movement of food from the stomach into intestines. Okay, here from here intestine starts. That's the duodenum. Duodenum is a part of intestine. The movement of food from the stomach into intestines is called as gastric emptying. If you, for example, take idli, okay, or like upma or whatever, curd rice or something, if you take light food that is rich in carbohydrate, light food means carbs. So carbohydrates are going to stay in your stomach for almost like 4 hours, 4 hours, 3 to 4 hours. Okay, 3 to 4 hours. Carbohydrates. So carbohydrates will go into the intestines quickly. So in the intestines, further digestion happens and absorption happens. Glucose is going to be absorbed. Okay. So first carbohydrates time like 3 to 4 hours. Gastric emptying time for the carbohydrates is 3 to 4 hours. For how much time it will take to empty into the intestines, 3 to 4 hours. Proteins ke liye, how much time it will take? For example, if you are eating the chicken wings, or if your father gave you chicken wings or like chicken leg pieces, it's full of proteins, right? Those protein foods are going to stay in your stomach for a lot of time. Okay, they will take you almost 6 to 9 hours. Okay, 6 hours, like range is there, 6 to 9 hours. If you take fats, for example, if you are eating a pizza with double cheese, like a lot of cheese, these fat rich food is going to stay in your stomach for 9 to 12 hours and even more. Okay, so the time duration is not important, but the order is important. Carbohydrates have fast gastric emptying when compared to proteins and fats. So that's why your parents will give you light food which is rich in carbohydrates. Okay, so they will stay in the stomach. The halt over period, the time period is going to be less. They will move into the intestines quickly. Further digestion happens and absorption occurs. So you will get the energy. If you eat fat, array, exam completed, you came to the home, you are sleeping, still the food is going to be there in the stomach. Still the food is waiting in the stomach. Okay, so that's why. So the concept of gastric emptying completed, and gastric emptying is promoted by MCQs. So gastric emptying, who promotes the gastric emptying? Gastrin. Gastrin promotes the gastric emptying, means gastrin allows the movement of food, allows. Gastrin allows the movement of food from the stomach into the intestines. Okay, gastrin promotes the gastric emptying. Who inhibits the gastric emptying? Secretin and cholecystokinin, these two hormones, they inhibit gastric emptying. Know this. So gastrin promotes gastric emptying, secretin and cholecystokinin inhibits gastric emptying. The two important MCQs which I want you to know. Done. Next. Same thing, right? Next, in how many phases acid is going to be produced? Don't write everything. Only numbers are enough. Don't write anything. Are in how many phases acid is going to be produced in your stomach? Are you haven't ate anything? Okay, you haven't ate anything right now. You haven't ate anything from the morning. You are sitting and listening to the class. Okay, now from your kitchen, like your mom or like someone, okay, in your surrounding rooms, okay, they are making like without knowing to anyone, they are like secretly making like some nice biryani in their rooms. What you are going to get? You are going to get the smell, right? You're going to get the smell. So automatically acid will start to produce in your stomach. When you look at some nice delicious food, acid will start to produce in your stomach. Your body, your stomach is anticipating that this fellow will definitely eat. Okay, so something like that. So whenever you think about the food, whenever you look at the food, or when you smell the food, 30% of the acid is already started to produce in your stomach. This is called as a cephalic phase. In cephalic phase, how much acid is getting produced? 30% of the acid is going to be produced. Right now, you think about the food, close your eyes and think about the food. Acid production will start to happen in your stomach. Don't do it. Okay, so cephalic phase mein 30% of the acid is going to be produced. Now, when you actually eat the food, 60% of the acid is going to be produced. After gastric emptying means the food is going to the duodenum. Okay, food is going into the duodenum means almost digestion completed. So acid production decreases and very little acid is going to be produced. So almost 10%. That is called as the intestinal phase, means food is entering into the intestines. So how much? 30% in cephalic phase. When you actually eat, that's the gastric phase, 60%, and intestinal phase may 10%. So 30, 60, 10. Okay. So 30, 60, 10. Cephalic phase, gastric phase, and intestinal phase. The question which was asked in the FMG exam. Only numbers are enough. Further, all these points are bullshit. Okay, nonsense. Don't write. 30, 60, 10. Now the question which was asked in the FMG exam is, in which phase maximum gastric acid is going to be produced? In which phase maximum gastric acid is going to be produced? Don't write. Only numbers are enough. 30, 60, 10. In which phase maximum gastric acid is going to be produced? Gastric phase. Again, gastric phase, maximum gastric acid is going to be produced in gastric phase. Okay. Done. So this also completed, sir. Now, what is the time now? The time is 5:37. Do you want to have any small break, or is it okay? Jyoti Sharma is asking, explain about the gastric levels increase in pernicious anemia. Wait. Let me put it this way. See, in pernicious anemia, you tell me, Jyoti, pernicious anemia में acid है या नहीं है body में? Tell me. Pernicious anemia में acid is there or not? Tell me. In our body there is no acid. Whenever there is no acid, what your body will try to do? Arey, there is no acid. Let me produce acid by somehow. Okay, let me produce acid by somehow. Okay, as you have asked, Jyoti, let me tell you the real thing. Pernicious anemia, right? Let me tell you what is the real thing. Look, what is normal? See, G cell produce what? Gastrin. Gastrin acts on parietal cell. So parietal cell will produce what? Acid. This is normal. G cells produce gastrin acts on parietal cell produce acid. Once you have sufficient amount of acid will give negative feedback. Okay. Now tell me, in pernicious anemia acid nahi hai. So negative feedback nahi hai. So G cells what they will produce? They will produce a lot of gastrin. So that's it. This is why the gastrin levels are increased. If you want the exact reason, that's the exact reason. Now we understood. Hope Jyoti you understood. Ova is excellent. Jyoti, now it's clear. Chalo, next. You want any break? 2-3 minutes break? Totally up to you. If you want, I will give you, or shall we continue? Nice. Like from tomorrow, I won't ask your suggestions because someone will say 5 minutes, someone will say 10 minutes, someone will say no break. It's not something like that. Okay, just right now the time is 5:40. 5:40. Take break till 5:39. Take break till 5:45. Okay, 5 minutes. Only 5 minutes break. If I continuously extend, most of the students, I'm not talking about the tough ones. Most of the students will get tired. They will get bored. That's why. Okay, small breaks. 5 minutes break. Okay. Done. Next, absorption of substances and their sites. In this FMG exam, okay, in this FMG exam, this question was asked. This question was asked in the recent FMG exam, which happened, I think, 20 days back. This is the question which was asked. What's the question, sir? Iron. I will tell you what is the question. It's not. I will discuss with you. Just wait. First of all, where the iron is going to be absorbed? You already know it. Iron is absorbed in duodenum. Okay, iron is absorbed in duodenum. Vitamin B9, which is also called as the folic acid, it is absorbed in jejunum. And vitamin B12, along with intrinsic factor, it's absorbed in terminal ileum. Okay, terminal ileum. So B12, which is also called as the cyanocobalamin, along with the intrinsic factor, only in the presence of intrinsic factor, it's going to be absorbed in terminal ileum. Okay, so there is this one parasite. There is this one parasite called as the Diphyllobothrium latum. 2019 FMG exam question. Diphyllobothrium latum is also called as fish tapeworm. That's it. That's the question which was asked in 2019. 2019. Okay, not now. So Diphyllobothrium latum, also called as a fish tapeworm, where it will live. It lives in terminal ileum. It lives in ileum. As it is living in ileum, it interferes with absorption of what? It interferes with the absorption of vitamin B12. So it will cause vitamin B12 malabsorption. So Diphyllobothrium latum causes vitamin B12 absorption, leading to botryocephalus anemia. So vitamin B12 nahi hai to it will cause anemia. So that is botryocephalus anemia. Okay. So Diphyllobothrium latum causes botryocephalus anemia due to vitamin B12 malabsorption. Diphyllobothrium latum. It's a fish tapeworm, lives in ileum. So ileum affect ho gaya, so vitamin B12 absorption bhi affect ho gaya. Done. Next, ankylosoma duodenale. The name itself is there. So ankylosoma duodenale, where it will live? It lives in duodenum. As it is living in duodenum, it interferes with which absorption? Iron absorption. So the patient is going to have iron deficiency anemia. Okay, the patient is going to have iron deficiency anemia. So iron deficiency anemia mein RBC size is going to be less. So they can ask you something like this: ankylosoma duodenale causes microcytic anemia. Microcytic anemia. Okay, so B12 deficiency mein, if you are having B12 deficiency, yes, of course, botryocephalus anemia is there. But what is it? B12 deficiency mein, the size of the RBCs is going to be big. So that is megaloblastic anemia. Okay, so ankylosoma duodenale causes microcytic anemia, and Diphyllobothrium latum is going to cause megaloblastic anemia. Okay, megaloblastic anemia. Or you can say botryocephalus anemia is a type of megaloblastic anemia. Okay, done. Next, now something important about the iron. Okay, iron is absorbed in duodenum. Okay, come to this. Look at this. Now, how many forms of iron are there? How many forms of iron are there? See, there are two types of people: vegetarians, non-vegetarians. Okay, vegetarians or non-vegetarians. Vegetarians are going to take the plant-based products, all plant-based products, most of the plant-based products. So you will get iron in the form of Fe3+. Okay, what kind of iron you are going to get? Fe3+. That's ferric or non-heme iron. Ferric. Non-vegetarians are going to get Fe2+ form of iron in their food. Fe2+, that is called as ferrous. Okay, there are two forms of iron: ferric iron and ferrous iron. Okay, now the problem is these vegetarians, they are taking ferric iron, which is not absorbed. You can't absorb it. It's not absorbed. But don't worry, all the vegetarians whoever are listening to this class, no worries at all. Okay, I will tell you why. Non-vegetarians, they will take Fe2+ form of iron, which is readily absorbed. Okay. Now, for example, imagine I'm a vegetarian. Okay, I'm a vegetarian. Really, also I'm a vegetarian. Now, I'm taking which iron? I'm taking ferric iron. Okay, in the I'm taking this Fe3+ from the plants. I'm taking ferric iron. Now, this Fe3+ iron will be converted into Fe2 plus form with the help of acid in my stomach. Okay. The acid, whatever is there in the stomach, with the help of acid in the stomach, the Fe3 plus will be converted into Fe2 plus. Okay. Now this Fe2 plus is absorbed into the duodenum. Okay. With the help of a transporter. This transporter is called as DMT1. With the help of, okay, see at the end of the day, Fe2 plus. Okay, Fe2 plus with the help of this transporter here also. Okay, let me, this is him. Better, okay, let's see here. At the end, this Fe2 plus, okay, Fe3 plus I have said, Fe3 plus will be converted into Fe2 plus. This Fe2 plus will be absorbed into the cell with the help of a transporter called as a DMT1, divalent metal ion transporter 1. Okay, absorbed. Now after this, where do you want this iron? We have to send this iron into the blood first. Okay, so this iron, where it is going? Look, this iron, it is, see here, this is the iron. Okay, Fe2 plus form of iron. Now this iron, it is entering into the blood. Means it's coming out of the cell with the help of ferroportin. So with the help of this ferroportin, iron is coming out of the cell. So Fe2 plus iron. Later, this Fe2 plus will be converted into Fe3 plus. Again, we're going back to Fe3 plus again. But that's not important. But iron came into the blood. Okay, right now, iron, where is the iron? Iron came into the blood. Now, iron is like a naughty boy. Okay, naughty boy. What naughty boys will do? They will go after all the girls. They will irritate all the, girls. They will go after all the girls. No, it's not good. So this iron need to be married. You need to marry this iron. So this iron in the blood will be bound, married. It's getting totally binding with a protein, plasma protein called as a transferrin. Okay, iron is bound with the plasma protein in the blood. Iron is bound with the plasma protein in the blood, and that plasma protein is nothing but transferrin. Okay. So finally, where this iron will go? Where this iron will go? So this iron, it will finally transport the transferrin. The transferrin transports the iron to the storage sites like liver and bone marrow. So this is the story of iron absorption. Okay. So iron in Fe2 plus form absorbed into the duodenal cells or enterocytes, absorbed into the duodenal enterocytes with the help of DMT1. Now with the help of ferroportin 1, iron enters into blood. In the blood, it is bound with transferrin. Transferrin transfers the iron to liver and bone marrow. Okay, transferrin transfers the iron to the bone marrow as well as liver. Now, when you have sufficient amount of iron, listen. When you have sufficient amount of iron, we don't want the extra iron, sir. Extra iron is bad because it will cause hemochromatosis. When you have sufficient amount of iron, liver is going to produce something called as hepcidin. Hepcidin seeds further inhibiting the further iron absorption. Okay, no extra iron will be absorbed into the blood. So when you have sufficient amount of iron, liver produces what? Hepcidin. Hepcidin, what it will do? It inhibits the ferroportin. So iron absorption into the blood inhibited. Okay, because you have enough amount of iron, that's it. So this is the story of iron. Now I will ask you certain questions. You just try to. Now here in the liver, iron is stored. In which form? Fe3 plus form only. This storage of iron is called as ferritin. Okay, storage of iron in the liver occurs with ferritin, or simply ferritin is the storage form of iron. Okay, ferritin is the storage form of iron. Ferritin in Fe3 plus form. Now my questions to you. Okay. Absorption. Iron is absorbed in. Questions. Iron is absorbed in duodenum. Excellent. Okay. What is the transporter through which the iron is going to be absorbed? What is the transporter through which iron is going to be absorbed into the duodenal enterocytes? Transporter. It's a DMT1. DMT1. Okay, DMT1. What is the transporter through which the iron is absorbed into enterocytes? There's a DMT1. Okay. Next. So who downregulates the iron absorption? Who downregulates the iron absorption? Who downregulates? It's hepcidin. Hepcidin. Hepcidin is produced by Hepcidin is produced by liver. Okay, hepcidin is produced by liver, and hepcidin inhibits which transporter? Hepcidin inhibits which transporter? Ferroportin. Okay, ferroportin. Good. Now, finally, the question which was asked in the recent 20 days back. What is the question that was asked? Anyone knows what is the question which was asked? Let me see. Any one of you can answer this or not. What is the question which was asked regarding the iron? In the recent 20 days back, what is the question which was asked in the FMG exam? Not G6PD. No, I'm talking about the iron. The question is not mutation of hepcidin. The question is mutation of hepcidin. You are talking about the hemochromatosis, and that's not the question. The question is who decreases the absorption of iron? Who decreases? Which substance decreases the absorption of iron? Which substance decreases the absorption of iron? The answer which was given in the exam is T. The answer which was, yes, of course, you are Rahul Singh, whatever you're saying, the phytates, true answer, phytates, true. T. Okay, T, tannins, phytates, yes, true. Okay, look, take the next slide. Look, now the Fe3 plus form of iron need to be converted into Fe2 plus. Only this iron is absorbed. You know? So Fe3 plus form of iron need to be converted into Fe2 plus. Only Fe2 plus form of iron is absorbed in duodenum. You know it. Who helps in this conversion process? Fe3 plus to Fe2 plus. Who helps in conversion? Acid. Vitamin C, that is ascorbic acid. They helps in absorption of iron. See, both these two substances, they convert Fe3 plus to Fe2 plus. So these two substances increases the iron absorption. They increase iron absorption. Then who decreases the iron absorption? Who are the bad fellows? The bad fellows are milk, phytates. They are present in the food substances, phytates, tannins. Okay, and one more important thing is antacids. Omeprazole, pantoprazole, cimetidine, ranitidine, antacids. What they do? Antacids. The antacids decrease the acid. No, antacids decreases the acid. Acid decrease hone to it's bad. Iron absorption decreases. So all these things, milk, phytates, tannins, antacids. In the recent exam, instead of keeping the milk, they kept tea. Okay. So they all decreases the iron absorption. Milk, tea, phytates, tannins, and antacids. So that's the question. Next. So iron also completed. The next thing which I want you to know is digestion in the intestines. We are moving into the intestines. Okay, intestinal area. The topic which I'm going to discuss first is the pancreatic secretions. Pancreatic secretions. Now I'm asking you, guys, recently many films came, like one of the film is this film. What is that film? That guy, Animal. This film, Animal film came, and one more film, this Hanuman film came. These are the pan-Indian movies, right? These are all the pan-Indian movies. What exactly are the pan-Indian movies? Can you tell me what are pan-Indian movies? Those movies which are released throughout the India, they have the market throughout the India. Okay, pan means complete dominance, complete market is there everywhere. Okay, so I used to remember it's the same way. Pancreas, my pan is there, which means it can digest carbohydrates, it can digest proteins, it can digest lipids. Saliva mein protein digestion does not occur. Stomach mein carbohydrate digestion does not occur. But pancreas can digest every damn thing. Carbohydrate digestion के लिए pancreatic amylase is there. Protein digestion के लिए trypsinogen, chemotrypsinogen, procarboxypeptidase, MCQ. Procarboxypeptidase is produced by pancreas. True. And lipid digestion के लिए MCQ, colipase. Colipase is produced by pancreas. MCQ. So pancreas can digest every damn thing. It can digest everything. Okay, right. Pancreas can digest carbohydrates, proteins, as well as fats. Next, see, I have said you wherever there is ogen, wherever you see the word ogen means what? Inactive. So trypsinogen need to be converted into trypsin. Who will help in that? Enterokinase. But in one of the FMG exam, instead of using the word enterokinase, they have written enteropeptidase. And further they have asked enteropeptidase produced by or produced in where? Duodenum. Okay, enteropeptidase is produced in duodenum. What this enterokinase or enteropeptidase is going to do? This is going to convert trypsinogen into trypsin. Trypsinogen into trypsin. Don't forget, pepsinogen is converted to pepsin by. Pepsinogen is converted to pepsin by HCl. Don't forget. Okay, let me just for recap purpose, let me show you. See, pepsinogen is converted to pepsin by HCl in the stomach. Now come back. Yeah, here trypsinogen is converted to trypsin by enterokinase. Okay, sir. Then what about this trypsinogen completed? Chemotrypsinogen to chemotrypsin. Chemotrypsinogen, right? Chemotrypsinogen is converted into chemotrypsin with the help of trypsin. So trypsin converts chemotrypsinogen into chemotrypsin. Trypsin, it's this trypsin, it's this trypsin. Trypsin converts chemotrypsinogen into chemotrypsin. Okay. Done. Now, first of all, why these substances are getting produced in inactive form? Why, sir? Why they are like why the pancreas is producing them in active form? For example, what if directly trypsin is produced and directly chemotrypsin is produced in the pancreas? What if directly trypsin is produced? If directly trypsin is produced, the trypsin will first digest the pancreas. It will first digest the pancreas. Rather than digesting the chicken piece, which is there in your intestine, it will digest your own chicken piece. That's your pancreas. Okay. So to prevent the autodigestion, the pancreatic enzymes are produced in inactive form. Why? To prevent autodigestion of pancreas. If active enzymes are produced in pancreas, means if active enzymes are produced, first those enzymes will first digest the pancreas. So to prevent the autodigestion. Okay, so that's it. This slide is also completed. Now the topic which I'm going to teach you in the next 5 minutes, it's a little interesting and it will help you to solve most of the questions. Now with your beautiful hands, draw this image, sir. Small, with your small cute little hands, draw this image that I'm drawing over here. This is your stomach and duodenum. Okay, this is the stomach. Here is the duodenum. Okay. Now in that, well, here there is a sphincter. What is the sphincter? There is a pyloric sphincter. Okay, here is the pyloric sphincter. Now you have taken some food. You ate some food. You ate some food. Now this food is going to produce a HCl. Whenever you eat food, the parietal cells are going to produce acid. Okay, acid is there. Now look here in the duodenum. See, in the duodenum, there are two friends. One friend name is S, and the other friend name is, what happened? Just wait. Yeah, the other friend is I, SI. There are two cells present in the duodenum. There are two cells present in the duodenum. Now, what is the story is, see, whenever this acid comes into the stomach, see, the acid is coming into the stomach. Sorry, not into the stomach, sorry, into the duodenum. Whenever the acid is coming into the duodenum, that's bad, right? Definitely that's bad. Acid in the duodenum is bad. Acid in the duodenum is bad because acid can cause damage to the duodenum. This acid is going to stimulate which cells? S cells. Acid stimulates S cells. Now, what these S cells will do? S cells release immediately secretin. This is how secretin is released. S cells produce secretin. Okay. Now, what this secretin will do? Secretin It's going to act on pancreas. Here I am showing you the pancreas. Okay, here is the pancreas. Here is the pancreatic duct. Okay, this is the pancreas. Now the secretin, it will come and act on pancreas. Secretin is stimulating the pancreas. Now, do you know what happens? Now this pancreas is going to release. Okay, now the pancreas is going to release bicarbonate rich HCO3 minus. Bicarbonate rich pancreatic juices. Now the pancreas releases what? It releases the pancreatic juices. Which type of pancreatic juices? Pancreatic juices are released. Which type of pancreatic juices? Bicarbonate rich pancreatic juices are released because these bicarbonates can go and neutralize the acid. Acid go neutralize karega. Okay. So acid will be neutralized. So that's why antacid. This secretin is antacid. Okay. So secretin acts on the pancreas. So pancreatic juices become rich in bicarbonates, which will further neutralize the acid in the duodenum. So this is what I how many cells are there? S cell is there and I cell is there. We forget about the I. S cell is there. So whenever acidic food enters into the duodenum, okay, whenever acidic food enters into the duodenum, it stimulates S cells. S cells release secretin. Secretin acts on pancreas. Okay, secretin acts on pancreas. Follow the color. Follow the color. Now the pancreas is going to release pancreatic juices, becomes rich in bicarbonates, which helps in acid neutralization. That's it. Done. Next. Look at here, guys. Same diagram, right? After this, I will take the questions. If you have any questions after this topic, I will take you the question. Take the questions. If you have questions, just wait. Again, what is this here? Kya hai? A pancreas hai. Okay. Here I am showing you something special like this. Under the liver, there is something special. Okay. Something like this. Okay. Now, imagine you ate fat-rich food. Okay. Now, what you are eating? You are eating fat-rich food. Your father take you to some place. So now you are eating some like McDonald's or something, Pizza Hut, somewhere. You are eating fatty things. Okay, for example, double cheese pizza you are eating. So you are eating fats. Now these fats, now when they enter into the duodenum, fats, they stimulate which cells? The fats are going to stimulate I cells. Okay, here, let me show you the I cell. Here is the I cell. So these fats, they are coming and stimulating which cells? I cells. Now this I cell releases what? The I cell is going to produce cholecystokinin pancreozymin. Okay, I cells in the duodenum. I cells in the duodenum produces cholecystokinin pancreozymin. Now this cholecystokinin pancreozymin, through the blood, it will come and act on pancreas. Now what the pancreas is going to release? Pancreas is going to release, again, pancreatic juices. What type of pancreatic juices? Enzyme rich. To digest the fats, to digest the fats को digest करने के लिए enzyme rich colipase, pancreatic lipase. Okay, enzyme rich pancreatic juices are released. Enzyme rich pancreatic juices like chymotrypsinogen, trypsinogen, all these enzyme rich pancreatic juices are going to be released to digest the food. Okay, and not only that, this cholecystokinin pancreozymin, it will also CCK PZ. Cholecystokinin pancreozymin, it will also act on something. What is this? This is the gallbladder. So it will cause contraction of gallbladder. Cholecystokinin pancreozymin cause the contraction of gallbladder. So what is going to be released? Gallbladder is going to release what? Bile. Through the cystic duct, the gallbladder is going to release what? Bile. Now what bile will do? Bile will help in the digestion purpose. Fats digestion के लिए you require the bile. So it's simple, logical, right? Whenever you eat the fat-rich food, the fats need to be digested. The fat need to be digested. So fats will stimulate the eye cells. Eye cells releases the cholecystokin and pancreasomin. Cholecystokin and pancreasomin have two works. Cholecystokin acts on the pancreas as well as it acts on the gallbladder to release bile as well as enzyme. To release bile as well as enzymes. Okay. So this is the story. I cell ka story and S cell ka story. S cell and I cell both are present in duodenum. Okay. So same flowchart I'm going to show you. Look at this flowchart. Look at this. See, whenever you eat fat-rich food, I cells are stimulated. I cells release cholecystokin and pancreasomin. Cholecystokin and pancreasomin causes the gallbladder contraction. When the gallbladder is contracted, bile is released. Done. Now the same cholecystokin and pancreasomin also acts on pancreas. Now pancreas, what it will do? If pancreatic juices becomes rich in enzymes. Done. Okay. So with this topic is also completed in JAT. So far is that clear? No, not today. General physiology, I'm not going to start today. Not now. So is that clear so far? Are any doubts? Just let's recap the things. Okay, let's recap the things. Brunner glands are present where? Brunner glands are present in duodenum. Okay. What is something special about the Brunner glands? Can anyone tell me? What is something special about the Brunner glands? It produces alkaline mucus. Okay, it produces alkaline rich mucus. Alkaline rich mucus. Okay, what is the pH? What is the pH? 8.9. 8.9. Now, guys, can you tell me what is meningitis disease? Meningitis disease. Which hyperplasia? Anyone? Which hyperplasia in meningitis disease? Foveolar hyperplasia. Okay, foveolar hyperplasia, meningitis disease. In Zollinger-Ellison syndrome, in Zollinger, see, ZES, Zollinger-Ellison syndrome means high acid levels are there. Zollinger-Ellison syndrome, high acid levels are there. In Zollinger-Ellison syndrome, what about the secretin levels? Secretin levels are going to be high. High secretin levels. Okay, good. Okay, good. If you take antacids, if you take antacid, what happened to the iron absorption? Iron absorption increases or decreases? If you take antacids, iron absorption increases or decreases? Antacids decreases iron absorption. Ascorbic acid, what about ascorbic acid and relation with iron absorption? Ascorbic acid and its relation with ascorbic acid, vitamin C. Vitamin C increases the iron absorption. Okay. Next. Pepsinogen is produced by. Pepsinogen is produced by chief cells. Okay. Histamine is produced by pepsinogen, chief cells. Okay, put 2 persons answered. Next. Histamine is produced by enterochromaffin cells. Good. ECL. Enterochromaffin like cells, I should say. Enterochromaffin like cells. Enterochromaffin like cells. And last but not the least, somatostatin is produced by. Somatostatin is produced by D cells of the pancreas. Okay. So it's the D cells of the pancreas produces somatostatin. In the morning we have discussed. And in the stomach also, D cells of the gastric glands. D cells of the gastric glands. Okay, D cells of the gastric glands. Delta cells, true. Yeah, it's a universal inhibitor. It's a universal inhibitor. Now, can you tell me what are the... okay, let me put it this way. What is the type of anemia that's going to be seen with Diphyllobothrium latum? What is the type of anemia that's going to be seen with the Diphyllobothrium latum? Megaloblastic. Megaloblastic. Iron deficiency anemia is microcytic. Iron deficiency anemia is a microcytic. Diphyllobothrium latum is going to cause a megaloblastic anemia due to benign deficiency. Okay. Failure to failure to pass meconium. Failure to pass meconium in our GI, GI. Hirschsprung. Okay. In respiratory, when we are discussing about the respiratory, we will discuss about cystic fibrosis also. Okay, cystic fibrosis patients will also have failure to pass the meconium. Thick secretions are going to be seen. Okay, you're good. So last topic for today. Okay, last topic for today. I don't want to extend more. These two things are bullshit things. Don't write anything. But anyway, I will share the PDF. If you want to go through them, but unnecessary things not needed. The next topic which I want you to know is bile. Okay, bile. Right. So who is going to produce the bile for you? So bile is produced by liver. How much bile? 500 ml every day. Means half liter bile is going to be produced every day. So bile mein kya hai, sir? What exactly is there in the bile? Biochemistry, bile acids. Biochemistry, sir. Bile acids, bile salts are there in the bile. Apart from that, bile pigments are also there. Bile pigments like bilirubin, biliverdin are the bile pigments. Okay, and in the bile, cholesterol is there, water, and electrolytes. These are the things which are present in the bile. Of course, phospholipases, lot of things are also there. Phospholipids are also there. Okay, so bile mein bile acids, bile salts, bile pigments, cholesterol, water, and electrolytes. That's not that important. Not important. Where is this bile stored? Produced by liver, but it's stored and concentrated. See, stored and concentrated in gallbladder. Okay. Bile by itself, does it have any enzymes? We know bile help in digestion of the fats, but bile mein lipases hai? No, bile does not have any digestive enzymes. Okay, bile have no digestive enzymes. That's it. No enzymes, MCQ. Okay, then what the heck is this bile doing? Say, for example, say bile mein bile salts hai. So this bile acids, bile salts, what they will do? Both these things, what they will do is, whenever you eat food, these fats are complex substances. Okay, these fats, whatever is that, this fat globule, lipases, look, lipases cannot directly act on them. Okay, of course they can act, but their action is not enough. Okay, lipases cannot directly go and attack a large fat molecule, a large fat moiety. They cannot attack. So first you need to convert this large molecule into smaller molecules. So this bile salts, what they will do is they will convert this large fat globule into smaller droplets. So these are emulsified droplets. So this process is called as emulsification. Now lipases can easily act on them. Okay, and digest them. Okay, so bile, what it is going to do? Bile converts large lipid molecules into smaller droplets. This process is called as emulsification. Okay, that's it. I said, see, when you are having RBCs, right? RBC, they will live for 120 days. After the death of the RBCs, you are having this bilirubin. These are the degradation products. RBC degradation products called as bilirubin and biliverdin. These are the bile pigments. They are also coming in the bile. They are also excreted. Okay, RBC degradation products. Once the RBCs are destroyed, okay, what the bile doing? See, bile also plays important role. Bile also plays important role in excretion of bile pigments. Bile pigments kya hai? Bilirubin and biliverdin. What are they? They are the products of RBC metabolism or heme metabolism. Okay, they're the products of heme metabolism. That's it. So this is what bile is going to do, but it's not that simple. Look here, guys. Now your liver, it produces the bile. Okay, bile is coming and getting stored where? Bile is stored in gallbladder. Okay, bile is stored in the gallbladder, and whenever it's required, okay, whenever the gallbladder is contracting because of the cholecystokinin, CCK, what is bile salts are going to be released, bile acids, bile salts are going to be released. And what these bile acids and bile salts will do in the duodenum? What they will do, sir? Tell me. They will cause emulsification process. Fats are digested. Okay, good. But our body will reabsorb this bile salts and bile acids. Bile acids and bile salts are reabsorbed back into our body. Okay, where? From which region? From the ileum. From the ileum region, these bile acids and bile salts, they are getting reabsorbed. Look, all are getting reabsorbed into the blood. And through the blood vessel, where they are coming back? So these bile acids are coming back to the liver again. Okay, they are coming back into the liver. Okay, they're all coming back into the liver. So this circulation is called as, see, this is intestine. Intestines means entero. Liver means hepatic. What is happening? Reuptake. There is reuptake. Means this bile acids and bile salts, they will be again taken back into the liver. This is called as the enterohepatic reuptake of the bile acids. Enterohepatic reuptake of the bile acids. From where it occurs? Ileum. MCQ. This is the MCQ. Bile acids are absorbed from ileum. B12 is absorbed from ileum, mainly terminal ileum. Okay. Now, the point which I want you to know for your exam, little pharma integration here. Look here, guys. What is there in the bile? I have said you bile acid, bile salt, bile pigments, cholesterol, electrolytes, all these are there in the bile. But first of all, what is this bile acid, bile salt? These bile acids and bile salt by themselves, they are also derivatives of cholesterol. They are also derived from the cholesterol. They are also made out of the cholesterol. Of course, bile mein cholesterol hai separately. Okay. But this bile acid, bile salt, hai na, they are also cholesterols. They are also made from the cholesterol. Okay. Now, look, imagine there is a patient. Okay, I'm having a patient who is 60 years old or 50 years old, whatever. Maybe he is a 50 years old patient. He is having hypercholesterolemia. He is having what? Suffering with hypercholesterolemia. So high levels of cholesterol is there in his body. Hypercholesterolemia. So what I'm going to use is I'm going to give a drug. Okay, I'm going to give some X drug. Okay, I'm going to call it Baba. This drug is called as a Baba. Okay. Now this X drug, what it will do is, it will go, this drug, it will go, let me show in pink color. It will go and bind with, this drug is going to go and bind with this bile acids. Okay, it will directly go and bind with the bile acids. So once this drug is tagged with this Baba, okay, once this bile acid is tagged with this drug, now this reabsorption cannot occur. Okay, from the ileum, the reabsorption cannot occur. So what happens now? All these bile acids and bile salts, they will be lost in feces. Which means the cholesterol is going out of the body. The bile acids continuously every day, they are coming out in the feces. So liver is going to make new bile acid. And again that bile acid will come out. Again liver will make new bile acid. Again that will come out. Which means that simply the patient is excreting the cholesterol out of the body. Am I right or not? That simply the patient is excreting what? Cholesterol out of the body. So this drug is called as a Baba drug. Okay, this drug is called as a Baba drug. Baba drug means what? Bile acid binding agent. Okay, so Baba drug, bile acid binding agent. So this drug will go and bind with the bile acid. So further bile acid reuptake is inhibited. Okay. So what are these Baba drugs? Look here. So there are drugs like cholestyramine, cholestyramine, and colcivalam. Cholestyramine, cholestyramine, and colcivalam. These are all Baba drugs. What they will do? They inhibit enterohepatic reuptake, not circulation. They inhibit enterohepatic reuptake, leading to loss of bile acids. So bile acids are going out. So they can be used where? They can be used in the treatment of hypercholesterolemia. Okay, they can be used for the treatment of hypercholesterolemia. Okay, done. Here, bile acids. See, देखो, bile acids are reabsorbed in via enterohepatic circulation. Via enterohepatic circulation means from the intestines to the hepatic, to the liver. Via enterohepatic portal system, the bile acids will be reabsorbed back into the liver. But who will inhibit that process? Cholestyramine, cholestyramine, colcivalam. Already I have discussed what is CCK, cholecystokinin. What it will do? Cholecystokinin increases the gallbladder contraction or causes the gallbladder contraction. Release the bile. release the bile. So this cholecystokinin is also called as a cholegog. Cholegog means any substance which increases the release of bile. Any substance which increases the release of bile is called as cholegog. Who is that cholegog? Cholecystokinin. Cholecystokinin is a cholegog. It increases the bile release. And what is the cholerectic? Cholerectic means not needed for FMGE, but if you want to know, but safe side, cholerectic means they increase the production. This is release. Here it's release, bile release. Any substance which increases the bile production is called as a cholerectic. Example is secretin. At least if you want to know one thing, secretin. Remember one thing, secretin. Okay, secretin increases the bile production. So with this, bile bhi ho gaya. Physiology direct important points about the bile. Bile helps in emulsification. Bile does not have any enzymes. Bile salts are reabsorbed in the bile acids. Bile salts are reabsorbed in the ileum, and BABA drugs inhibits the intrahepatic reuptake. It can be used in the treatment of hypercholesterolemias. Okay, hypercholesterolemias. Okay, so is that okay, guys? Now I just want to end for today. It's 6:30. Of course, I can extend for till 7, but I just want to. Abra, where do you want me to repeat? Is it a fresh message or is it clear now? Abra, can you be a little more specific? Which thing do you want me to repeat? Is it clear? Last box. Last box. Simple. Same. Cholecystokinin. Same. Cholecystokinin. What it will do? It will cause gallbladder contraction. Whenever gallbladder is contracted, what happens? Bile is released. So any substance which causes the gallbladder contraction is called as cholegog. Cholegog means what? It is causing gallbladder contraction. Who causes the gallbladder contraction? Cholecystokinin. That's the answer. Cholegog means it causes gallbladder contraction. Who is causing the gallbladder contraction? Cholecystokinin. That's it. Okay. Next, cholerectic means it increases the production. Okay, it increases the production of bile in the liver. Who increases the bile production? Secretin. Okay, secretin increases the bile production. So that's it. That's why it's called as a cholerectic. Okay. Now is it clear, Abra? So I am stopping for today. Tomorrow we'll be starting exactly by 9 o'clock. Okay, 9 o'clock we'll be starting exactly. We'll be doing 1 hour. In 1 hour, the remaining part of the JAT will be completed. After JAT, we'll start cardio. We'll start the cardio tomorrow. Okay, we'll do the cardio. And not Harish. I actually thought to start at 8:30. Okay, I actually thought to start at 8:30, but the management is not allowing me to start at 8:30. So it's 9 o'clock. Okay, I have to complete in 4 days, right? That's why. Okay. Okay, guys. Bye bye. See you tomorrow. The PDF will be shared. Bye bye. If you have any suggestions for me, please message me personally. Like if there are any suggestions, you please message me. I will take that into consideration. Okay. Yeah. Bye bye, guys.